I mean, like the first three speakers are not there.
Sir, I'm Dr. Sumit, sir. I'm doing this from Dr. Prashanth's laptop.
I think now we are live. Now we are live.
Yeah.
Mr. Shobit, are you there?
We are live now. I just got a message that it's being live streamed.
Yes, sir, we can hear you.
Am I audible?
Yeah,
Yes,
yeah.
sir.
Akash, are we live now?
Mr. Shobit, are we ready to start the presentation?
Doctor, 1 second. Atish, are we live now? Akash,
Yes, sir.
are we live now?
Yes, sir. Yes, sir.
Please announce. Doctors, we are live now.
Start करेगा तब.
Doctors, we can start. We are live now.
जरूरत नहीं बोल रहे हैं कि कर दे कैसे होगा ये उस पे उसको सिलेक्ट करेगा.
Good morning, Sudhir.
Rename कर.
Good morning, everyone. On behalf of DNA Organizing Committee, myself, Dr. Devnath, Dr. Sudhir Kumar Tyagi, we welcome everyone in Day 2 Hall B session. That will be split session award paper, and the respected chairperson will be Dr. Sushil Vasin, Dr. Rahul Gupta, and Dr. P.K. Sachdeva. Now, over to the respected chairperson. Kindly proceed and do the needful. Over to you, sir.
Good morning. I'm Dr. Sushil Vasin. Thanks the organizers for inviting us on this wintry, chilly morning. I think we can warm it up with a good academic feast we have lined up for today's morning session. And I, along with Rahul Gupta and P.K. Sachdeva, will begin the proceedings. I think the first speaker, who's Bhanu Pratap, I think is he there, Bhanu Pratap? In that case, I think I can see Dr. Anil. Do I ask Anil
No, Dr. Sumit. Dr. Sumit is there.
Dr. Sumit is there.
Yeah.
Okay. So I think we're going to have quite an interesting session, and I would call upon Dr. Sumit. In fact, invite Dr. Sumit to speak, to come and give his talk. Sumit is having quite an interesting talk. He'll be talking on the chasing tracts in patients of brain tumors. And Sumit, would you please kindly begin your talk and enlighten us with your views?
Yeah. Good morning, everyone. I am Dr. Sumit, neurosurgery resident.
Sorry to interrupt you. Mr. Shobit, you please kindly stick to the time. The time allotted is 8 minutes plus 2 minutes. Mr. Shobit, please look after this. Thank you. Please continue.
Yes, Anil.
Good morning, everyone. Topic of my presentation is chasing tracts in patients of brain tumor are an initial experience. Diffusion tensor imaging is an MRI modality which predicts the probable location and orientation of subcortical white matter tracts. It measures 3D diffusion of water molecules within the tissue through the application of multiple diffusion gradients. These tracts can either be displaced, infiltrated, or disrupted, and accordingly present with varying degree of clinical manifestations. Various studies have been conducted which support the above-mentioned observations, but there is paucity of data in literature regarding change in the tract position after surgery and its clinical implication, if any. Aim of our study was to assess the effect of displaced white matter tracts on to assess the change in the tract following surgery and to see the change, effect of change in the tract in the clinical outcome. Methodology, it was a prospective study conducted for a period of 1.5 years. 50 patients of brain tumor were included. Pre-op clinical assessment was done along with diffusion tensor imaging. Tract that was assessed were corticospinal tract, corpus callosum, optic pathway, superior, middle, and inferior cerebellar peduncles. All the patients were operated within 15 days of DTI and tract assessment. Patients were assessed clinically in early and the late post-op period. Post-op DTI was done within 10 to 30 days, and changes in tract position with respect to pre-op position were noted. Post-op tract were classified as no change or normalization of tract, or there was further destruction of tract, and corresponding clinical changes were noted and were statistically analyzed. And this is the image showing the displaced tract.
Hello.
Hello. Yes, sir. Hello. Sir, this is the image showing the displaced corticospinal tract in right parietal as well, with the normal tract in the left corticospinal region. This is the image showing the infiltrated corticospinal tract. There is the decrease in the color of this tract over the place where arrow is pointing, and this shows that the tract has been infiltrated, and the tract position thickness has also increased as compared to the left side, which shows that the tract is also edematous. And this image shows the disrupted tract in the post-op patient of the right parietal as well. On the left left side, we can see the corticospinal tract, but there is a disruption of tract. But there was disruption of tract on the right side. There was normalization of tract in 6 patients out of 50 patients, and among these 6 patients, in 5 patients there was a change in clinical condition, whereas there was no change in 1 patient. So overall there was a clinical change seen in 83% of patients. No change in tract position was noted in 35 out of 50 patients, in which 11 patients showed clinical change, whereas there was no clinical change in 24 patients. So there was clinical change seen in 31% of patients, which show the change in tract position in post-op period. And there was disruption of tract in 9 patients, and all the 9 patients shows the worsening of the clinical condition. So as compared to the patient whose DTI showed no change in the tract position after surgery, the patient who showed the patient whose DTI showed change in tract position were significantly likely to show an improvement in clinical condition after surgery. There was no significant difference noted in normalization of tract based on histopathology in our study. So there were 10 cases of meningioma, out of which 2 showed normalization of tract. So the 20% of patients showed normalization in meningioma cases, whereas in 21% cases of low-grade glioma showed normalization of tract. So there was no significant difference based on histopathology. This is a case of a 54-year-old male, case of left parietal meningioma, showing displacement of the left corticospinal tract, and along with there was clinical deterioration of the right side. The power was 4-5. And in the post-op DTI, there was the normalization of the tract, and along with the improvement in power, which improved to the 5/5 on the right side. This is the second case showing the 3-year-old male child, case of cerebellar as well. There was the displacement of the middle cerebellar peduncle inferiorly, but in post-op period, after the removal of the tumor, there was the normalization of middle cerebellar peduncle, and along with the clinical improvement. So in conclusion, the normalization of the tract after surgery is significantly correlated with the clinical improvement after surgery. Moreover, this improvement is seen in early post-op period. Thus, diffusion tensor imaging can be used to predict the symptomatic improvement in the post-op period, along with its use to plan the surgical corridor in the way that minimizes the damage to the surrounding eloquent areas. Strengths of our study were that our sample size was relatively large as compared to the other studies by Yeo et al. And Laundrie et al. And our results were consistent with the above 2 studies, and a fairly wide age group of the patients were enrolled in our studies. And our was one of the first studies in the Indian setting, which studied the association of the change in diffusion tensor imaging with change in clinical condition. And this data could help in further planning of the studies on these lines. And the limitation of our study was that it was conducted in the setting which caters to the patient belonging primarily to the lower or the middle socioeconomic strata of the northern part of the country. And due to the COVID-19 outbreak and resource limited environment, the sample size was limited to only 50 subjects. Thank you.
Thanks, Dr. Bhandari. It was quite an interesting talk. I think any questions could be asked at the end of the session. Are we supposed to ask any questions, or I think we should? Rahul would introduce the next speaker and let's
ask the question. Anybody can ask the question. We have time.
So it was quite. We have time. It was quite an interesting study, Sumit, and wonderful work done. And like meningioma, which you said you would operate on the left side. So you, I mean, like, did you do the eloquent areas imaging too, or it was just corticospinal tracts there?
Just diffuser tensor imaging for the corticospinal tract. The functional MRI or the interop, no study was done for eloquent areas, sir.
Yeah, Dr. Sumit, this is a nice study, and I think this will help us in locating the motor tracts and the other tracts later on in future, and help us to prognosticate the patient. One small question then, in the end you said one of the limitation was that it was belonging to a lower socioeconomic status. How does that affect your study? I don't think that has any bearing on the tracts or anything.
Sir, but
definitely
low socioeconomic status people present later in the late stage of the tumor. So there is the diffuse edema, which can lead to the edema of the tract itself, which can cause the problem. It might not be because of the displacement of the tract, but the weakness or in clinical presentation can be due to the tract edema itself, which might not resolve after the tumor removal or even after normalization of tract.
So I think on the contrary, this would have helped you, because if you have smaller tumors, they will not displace or involve the cortical spinal tracts, and so that study will be more of a failure. So large tumors where there is a displacement has helped you more. Rather, it's not a limitation. You should omit that line from that.
It's not only because of the tumor, but the peritumoral edema, which can infiltrate the tract itself.
No, I agree, but that is not a limitation. That's not a limitation.
But that will be irrespective of whether the patient is from low socio or high socioeconomic strata.
Sumit.
Okay, but there's a very nice study, the nice paper. I think let's go to the next speaker.
So Dr. Sudhir wants to speak.
Dr. Sudhir, yeah.
A comment. First thing, Sumit, you are supposed to mention that you are using neuronavigation along with DTI. So in the whole of your study, you did not mention that you were using the neuronavigation as well.
We were not using neuronavigation.
Why? If you are using DTI and you want to be very precise, along with that, you should use the neuronavigation.
Sir, that interop facility is not there at our center.
If you have, you should use.
Yes, sir.
Further. Another thing is, whenever you are close to the eloquent area,
yes, sir.
Considering the tracts, but you should consider the neurons also. So you have to do the functional imaging and incorporate that also in your during the surgery in your methodology and your procedure.
Yes.
Yes. Otherwise, it is a good presentation. Thank you very much.
Okay. Thank you.
We can.
Yes, Rahul, you can introduce the next speaker and let's.
So I'm not sure if Dr. Neeraj is there. Dr. Neeraj?
Yes, Neeraj is there. Sir.
So I'll invite Dr. Neeraj to present his study on the impact of paraspinal muscles morphology on functional outcome in thoracolumbar degenerative disc disease. Over to Dr. Neeraj. Please stick to your time. Dr. Neeraj.
Thank you, sir. Am I audible?
Yeah.
Good morning, everyone. Today I am going to present on the topic the impact of paraspinal muscle morphology on functional outcome in patients with degenerative spine diseases. It's a prospective case control study. The patient with the degenerative spine disease show improvement in functional status following surgery. The dorsolateral spinal muscles morphology affects the functional status of the patients, which can be assessed by osteostatic disability index and visual analog score. By using T2-weighted images, paraspinal muscle morphology can be assessed, which includes muscle total cross-sectional area, muscle atrophy, and fatty infiltration. The lacunae in the existing knowledge is that there is no such study in Indian literature which study the impact of paraspinal muscle morphology in on functional outcome in patients with the degenerative spine diseases. Association of the paraspinal muscle morphology to functional outcome in patients with dorsal-lumbar degenerative spine disease. Patients with age 18 and above with this dorsal-lumbar spine diseases, we are willing to participate in our research and are the non-responder to conservative management are included in our study. The patient with history of the low back surgery, history of the spine, infective pathology of spine, non-ambulatory patients, patient with the arthritis, and patient with the neurological deficits were excluded from the study. It's a prospective case control study. 41 patients with the low back pain due to degenerative spine disease planned for back pain surgery at Zipmar were included in the study. Patients admitted in any other department at Zipmar without spinal disease were taken as in our study. The patients in the study group were followed up at 3 months post-operative period. Our morphology were assessed over atrophy of the muscles, which were graded at grade 1 if fatty infiltration of or muscle fibrosis was less than 10%. If muscle infiltration and fatty infiltration and muscle fibrosis was 10 to 50%, then we graded it as a grade 2. If it is more than 50%, then we graded it as a grade 3. And we also assess the total cross-section area of multifidus muscles and erectile spiny muscles in the MRI, axial out of MRI. The clinical variables were visual analog scale and associated disability index. Change in ODI we calculated as a pre-op ODI minus post-op ODI and was divided by pre-op ODI and expressed in the percentage. The confounding factors were age, gender, BMI, visual activity, duration of symptoms, types of surgery, duration of surgery. This is the image showing the how we measured the muscle area. This is the multifidus. This is erectile spiny muscle. We graded muscle atrophy as a visual grading. This image showing the grade 1 multifidus muscle atrophy and grade 1 erectile spiny atrophy, while this image showing grade 2 erectile spiny and multifidus atrophy. This image is showing grade 3 multifidus and grade 2 erectile spiny atrophy. The results showed that there is significant difference in multifidus and erectile spiny muscles between study and the control group. It shows that there is a significant difference between the pre-operative and post-operative functional status, which reflects the significant improvement in the post-operative functional outcome. This result showed that the pre-operative multifidus area has a significant negative core association with pre-operative ODI, post-operative ODI, and change in ODI, while pre-operative erectile spiny muscles area has a negative correlation with the pre-operative ODI. This table shows that the grade 1 paraspinal muscle atrophy has a lesser ODI, while grade 2 and grade 3 atrophy has a higher ODI. The result also showed that grade 3 paraspinal muscles atrophy has significant negative association with the change in ODI. This is a linear regression analysis we have done to assess the confounding factors on the various parameters. The table shows that age and BMI are independent factors influencing the pre-operative muscle area. Older the patients, lower the muscle area, while higher the BMI and higher the muscle area. This table shows that the duration of symptoms has a positive correlation with the pre-operative ODI. Longer the duration of symptoms, higher the pre-operative ODI. This table 7 shows that the older the patients, lesser is the change in the ODI. Hello, sir. Hello, sir.
Yeah.
Can I get a few minutes?
Yeah, please continue.
Hello, sir.
Please continue.
Dr. Neeraj, are you there?
Yes, sir. Sir, my laptop got sir charger over, sir. I'm just connecting, sir. Just 1 minute, sir.
Okay.
चार्जर है ना चार्जर वहाँ पर इसमें चार्जर है
Anil, connect with another laptop. Anil, connect with another laptop. Yeah, continue.
This table shows that older the patients, lesser is the change in ODI, higher the BMI, and lesser is the change in ODI. We found no association of various confounding factors with the pre-operative VAS and change in VAS. We conclude that the pre-operative paraspinal muscles total cross-section area is dependent variable that affect the pre-operative functional status. Duration of symptoms is an independent factor influencing the pre-operative functional status. The grades of paraspinal muscle atrophy are a good predictor of pre-operative functional status, post-operative functional status, and improvement in the functional status. Age and BMI are independent factors influencing the pre-operative paraspinal muscle area and post-operative improvement in the functional status. The evaluations of the paraspinal muscle morphology before surgery could help surgeons to predict the functional outcome in the patient undergoing spinal surgery. The limitation of our study was it was a single center study. The follow-up period was short. It was 3 months period, and sample size was relatively small. Thank you.
Dr. Neeraj, that's a nice study. I must congratulate you for conducting this study. We definitely know that after spinal surgery, it is not just the surgical technique or the surgical procedure which determines the outcome, but it is also the pre-operative status of the patient, which includes the muscle strength, as well as the post-operative physiotherapy and rehabilitation, which are very, very important.
Yes,
so if we are able to objectively evaluate what is the strength of the muscles, then definitely we can prognosticate as well as we can aggressively do the rehabilitative process.
Yes,
so if this study is vastly adapted by all the clinicians, this can help them to guide their patients as well as reduce the litigation. Because most of the patients, they complain of backache and some disability even after surgery, and they always try to complain the spine surgeons. So I think this study in certain group of patients in North India, because such studies have been conducted elsewhere as well, but in this area, will definitely in the Indian settings as well as the North Indian settings, where people do less of exercise, most of the patients are females or males with very high BMI. So these patients definitely have muscle weakness. So I congratulate you for your study. Good. I will invite questions from other participants.
Yes, sir.
I have a comment to make. The title of your study should be the impact of paraspinal muscle morphology on functional outcome in thoracolumbar degenerative disease surgery. Just not the degenerative disease. We are talking all the time about the pre-op and post-op. You have to mention that we are talking about the disc surgery rather than just this disease.
Sir, I have mentioned that the impact of paraspinal muscle morphology on functional outcome in patients. Outcomes
undergoing surgery.
Yes.
That's
this is after surgery.
Yes, sir. So we thought of sir that like if functional outcomes terms could itself include the that we are going to follow up the patient.
Dr. Neeraj, you must understand that the surgery word is missing because that will make it more specific and relevant to your topic here.
So thank you, sir.
Because outcome could be rehabilitative outcome too.
Yes, yes.
Yes, sir. Yes, sir.
So now, do we have Bhanu Pratap in our ranks again, or We go with Anil Kumar.
I think Dr. Anil Kumar will present. Dr. Bhanu is not there.
So I invite Dr. Anil Kumar to present his study. He is going to be presenting a study on the assessment of quality of life in operated patients of craniovertebral junction anomalies. Dr. Anil, please come and deliver your talk.
Dr. Neeraj, stop sharing your screen. Yeah.
Hello, sir. Good morning, everyone. Is it clear, sir?
Yeah.
It's clear.
Today, I'm presenting the assessment of quality of life in operated cases of craniovertebral junction anomaly. Craniovertebral, as we all know, craniovertebral junction, being the transit zone between the cranium and the spine, is the most common, most dynamic region of the whole of the spine. CVJ anomaly with neurological deficit is a chronic condition. Long-term outcome of these patients is not so encouraging. In spite of various methods of improvement in surgical techniques to get normal alignment of this region, the quality of life remains poor, and the neurological recovery does not always translate into functional recovery. The functional independence measure and the spinal cord independence measure are the two frequently used tool to assess the quality of life.
Please make it in a PowerPoint mode.
There are limited studies on the quality of life in operated cases of CVJ anomaly. So in this study,
Anil, kindly click the button of slide share.
Yes, sir, it started.
No, slideshow. In the top of the button, you can see a slideshow in the top. File, home, insert, design. Like one button is slideshow. Please click and start the slideshow. Can you find this button in the top?
Its slideshow is on, I think, sir.
No, it's not visible in our screen.
Okay, no problem. Continue.
Continue. Okay.
There are limited studies on the quality of life in operated cases of CV junction anomalies. So in this study, we assess the quality of life using SIM score and functional neurological assessment using area grading. Anderson et al. Recommended use of the following 4 outcome measures in spine surgeries. One is modified Barthel index, functional independent measures, quadriplegia index of function, spinal cord independence measure. The key area of interest of all these outcome measures were the neurological status, weakness of upper and lower limbs, pain, gait, spasticity, self-care, and daily living. The aim of our aims and objective of our study was to assess the quality of life in operated cases of CV junction anomalies, and secondarily to correlate between the radiological and clinical outcome. It was a prospective study conducted between 2020 and 2021 at GV Pant Hospital. All patients who were newly diagnosed as a CV junction bony anomalies were included in the studies, and the data were entered in the master chart, and they're assessed using SPSS version 25. The diagnosed cases of CV junction anomalies, when the patient were admitted, were neurologically assessed and were subjected to radiological investigations of NCCT CVJ, MRI CVJ, CT angiography of the neck to see the vertebral articulation. The neurological assessment was done under neck pain, lower cranial nerve involvement, weakness of upper and lower limbs, spasticity, quadriplegia, bladder and bowel involvement, and neurological assessment was done using ASIA score, and functional pre-operative functional score was assessed using SIM score. They were followed through 3 months, and at the end of 3 months, clinical examination was done, and NCCT post-operative NCCT MRI was done after 3 months, and they're assessed in the similar heading. The Asia grade has 5 grades with A, B, C, D, E. A is the poor grade with the complete loss, motor and sensory loss of functions, and E is the normal motor and sensory function. And this is the SIM score. And SIM score is divided into 3 parts. It has values from 0 to 100. 100 is the most functional patient, and it is divided into 3 headings. Self-care is given 0 to 20 points. Respiratory and sphincter management was given 0 to 40 points, and mobility was given 0 to 40 points. The results of our study was all patients underwent C1, C2 fixation. 60% of the patients were in the pediatric age group. 15 patients were male, 5 patients were female. The majority of the cases belong to type 1 EAD with basilar invagination. And we also found that in CV junction anomaly, the coronal joint inclination was more than 120 degrees in 14 patients. The clinical improvement was, there was pre-operatively 15 patients who presented with a neck pain, and post-operatively we saw almost 100% improvement in the neck pain, and 3 patients had a cranial nerve involvement. In that, 2 patients improved completely in the post-operative period, and there was no improvement in 1 patient. Limb weakness was seen in 20 patients, and post-operatively there was 60% there is complete improvement, and partial improvement was seen in 40%. Spasticity was present pre-operatively in 20 patients, and 80% showed complete improvement. With 3 patients remaining, there was no significant improvement seen. And bowel and bladder involvement was seen in 10 patients, and post-operatively all 10 patients recovered. This is the slide shows the radiological correlation. The atlantodental interval in the pre-operative state was in the range of 2 millimeter to 10 millimeter with a mean of 6.4. And there was significantly reduction in the post-operative period with the range of 2 to 5 with a mean of 3.35 millimeters. This other graph shows the decrease in the reduction. There is the reduction in the distance of atlantodental interval. This is the pre-operative values of the patient, and we can see significant reduction in the distance in the post-operative state. And similarly, we also showed that AP canal diameter, that is the posterior atlantodental interval of the pre-operative patients, range from 5 millimeter to 11 millimeter with a mean of 9.1 millimeter. And there is significantly improvement. There is increase in the post-operative posterior atlantodental interval with a post-operative measurement ranging from 12 millimeter to 16 millimeter with a mean of 14.25 millimeters. Improvement in neurological outcome as measured by Asia score was considered when there is at least 1 grade increase in the score, and the same with a SIM score. We observed this in 85% of the patients, and 15% remained in the same state. This is the slide showing Asia score, where 13 patients were present in grade 3, grade D in the preoperative state, and 5 patients were in the C, 2 patients in the A group. In the post-operatively, there was significant improvement, and 10 patients from group class D improved to class E, and two patients improved from class D to class E. And similarly, SIM score, the pre-operative SIM score was ranging from 0 to 94 with a mean of 62, and post-operatively we could see the range increase to 12 to 100 with a mean of 83. This is a significant improvement. To summarize, the mean SIM score in the pre-operative period was 62, which improved to 83 in the post-operative period. Even though there is mean increase in the SIM score in the post-operative period, some patients did not achieve enough improvement in neurological function so as to carry their daily activities and self-care. This is because the minimum score to achieve functional independence was in the self-care category it is 12, the respiratory and sphincter category it is 12, and mobility is 16. Total minimum of 40 score is required to achieve independent daily activities and self-care. These are some of the pre-operative and post-operative images. where we can see type 1 atlantoaxial dislocation in the pre-operative CT, and post-operatively there is a reduction in the AAD with normal alignment of facet joint. This is the second case showing the type 1 AAD, and post-operatively there is reduction of dislocation with a fixation. In conclusion, the patients with worst neurological state at initial presentation are at risk of developing complications associated with neurological deficit and has the overall poor quality of life as measured by SIM score, even though there is good post-operative alignment in CVJ spine. The morbidity in case of CVJ anomaly is mainly due to respiratory infection, infected pressure, and sepsis secondary to cord injury. To summarize, surgery led to significant reduction in the proportion of patients complaining of neck pain, limb weakness, spasticity, bowel and bladder. The clinical outcome and quality of life parameters of patient as measured by the ASIA score and SIM score showed significant improvement. We also found good amount of concordance between the two measures of quality of life, that is ASIA score and the SIM score. Radiological parameters also showed improvement after surgery. Imaging revealed that cord changes has improved in the majority of the patient, when most of them had achieved a correction of CVJ anomaly and facet joint union after surgery. After surgery, there was significant reduction of atlanto-dental interval. Thank you, sir.
Thanks, Dr. Anil. That's quite a lucid talk. Anything which you want to add, Rahul or Dr. Tyagi, your comment?
Yeah, so that was a nice talk. Yeah, we all know that craniovertebral junction is one of the very difficult areas, and functional outcome may not be directly related to the quality of the surgery which we may perform. In spite of achieving a good alignment, there may be some cord changes which may not let the patient to become functionally independent, but that is the best we can do. We can achieve a good decompression and an alignment, and after that fixation, so that we can continue with that alignment. And these patients require a lot of care and support by the caregiver, which can be family in India, otherwise by the centers of rehabilitation in other countries, like developed countries. And also we have to assess them frequently, because the problems may not end by a single surgery. Patient may require aggressive physiotherapy, regular follow-up, and some patients, they may require a resurgery also at a later date. Yeah. So all these things are very important. Thank you for highlighting all these things. So Dr. Tyagi, sir, anything you want to add?
I wanted to say, is there any way to just correlate between the ADI and the quality of life post-operatively?
Sir.
ADI, if you measure the ADI, pre-op, post-op, and check the quality of life, outcome and quality of life.
Sir, I could not, sir, I'm not
audible. Just radiological finding of the ADI, atlanto-dental interval, and outcome.
Yes, sir. Sir, when there is reduction of atlantoaxial dislocation, even though with a minimal reduction, if there is a rigid fixation, we can see good outcome neurologically and also functionally. Basically, for functional outcome, patient should have a constant physiotherapy, continued physiotherapy with the guided until there is bony fusion. Bony fusion is very much also important, that is facet joint fusion.
I want to say, you have already have the data. You can just concise it to the just one correlation, ADI and the outcome. That will be a good study. You have included so many factors, just include one.
In my study, 3 patients, basically only with the patients who presented only with basilar invagination were 3. So except for this patient, all patients showed significant improvement in the ADI.
No, sir. Sir is asking whether the radiological criteria, ADI, correlated with the functional outcome, and how well did it correlate?
Yes,
only
sir. Yes, sir. Yes, sir. Then the value to which up to which the atlanto-dental interval decrease.
बोल रहा है मेरा हो नहीं रहा यार इसमें आया नहीं
the value up to which the atlantodental interval improved, I mean decreased.
नहीं अनिल का तो आ गया यार.
There is significant improvement in the post-operative recovery. Some patients showed a score of 12 in the pre-operative period. To post-operatively, there is significant, I mean 46. Even though we need further follow-up to assess the patient, how patient recovers. This is a follow-up period for only for 3 months.
Okay, thank you.
So thank you, Dr. Anil. So now we have Dr. Prashanth Lucky, who shall be presenting on chondrocyte clustering and ultrastructural hallmark in of the degenerating nucleus pulposus. So over to Dr. Prashanth.
Very good morning, sir. Am I audible, sir?
Yeah, you're audible and visible.
Very good morning, sir. The topic for my presentation today is chondrocyte clustering, the hallmark of the degenerating nucleus pulposus, and electron microscopic observational study. The primary components of an intervertebral disc are water, proteoglycans, chondrocytes, collagen, and matrix components. Several etiological factors such as aging, smoking, infection, etc. have been shown to be involved in the pathogenesis of the intervertebral disc degeneration. However, the triggering factor in the onset of the degeneration is still not clear. The lacune in existing literature includes the initiating factors in the disc degeneration have not been studied adequately on an electron microscopic level, and no such study has been carried out in the Indian population. The aim of the study was to find the electron microscopic changes in the intervertebral disc and to correlate these with clinical and radiological features. It was a prospective observational study carried out over a period of 18 months on patients diagnosed with lumbar disc herniation. Included were patients presenting with the classical symptoms of lumbar disease with or without a neurological deficit, and the patients with a previous history or an infective etiology were excluded from the study. The sample size calculated was 73. However, for the convenience, the sample size considered was of 50 patients. After admission, patients' demographic factors like age, sex, weight were documented. A detailed history regarding chief clinical complaints, their nature, duration, pain severity, as per the VAS score were considered. MRI scans were performed and severity was documented as per the Fuhrman grade, and modic changes were also documented. After the pre-anesthetic checkup, patients underwent discoidectomy either by open or an X-tube assisted method. After excision, the disc tissue was immediately transferred into Karnofsky solution for the further electron microscopic examination, which was performed using a Talos thermoscientific 200 kV electron microscope, which is shown in the figure. The variables which we studied, the clinical ones were the age, sex, patient's pain severity. The radiological included Fuhrman grade and modic changes, and rest of the findings were as per the electron microscopic features. Coming to the observations and results, the total number of patients included were 50. Clinical parameters studied showed that the majority of the patient, that is 62%, belonged to the 40 to 60 year of age group, whereas the mean age was 47.42 years with a slight male preponderance. The mean duration of symptoms was 12 months, and maximum patients reported to have a pain severity of 8 on VAS score. The radiological parameters, the most common involvement was a paracentral disc protrusion at L4-5 level. Most of the patients, that is 32%, were found to have a modic type 2 changes followed by the type 1, and maximum patients, that is 68%, demonstrated a Fuhrman grade 4 of degeneration. Electron microscopic features. The most common electron microscopic finding in this study was chondrocyte clustering, which was present in 92% of the patients, followed by abnormalities of the extracellular matrix, and later on intracellular inclusions were also seen. The other less commonly observed features were formation of long processes, apoptic cells, and chromatin clumping. This is an image which is showing 3 chondrocytes clustered together. Also is seen intracellular inclusion, and we can note the presence of abnormal encircling matrix. This is a cluster of two chondrocytes together, also called as a chondrone. Here we can see the characteristic of a degenerating cell, the classical formation of long processes in a viable pulposus cell. Here we can see the marked abnormal extracellular matrix being laid down around a degenerating cell, and also are seen the large intracellular inclusions. And here we see a advanced stage in degeneration, which is probably like to progress to apoptosis. Majority of the patients who showed chondrocyte clustering had a VAS score of 8. All the patients with a higher VAS score, that is 9 and 10, demonstrated these findings. 2 patients who did not demonstrate the finding had a VAS score of 6 and 7, and a longer duration of symptoms correlated with the presence of chondrocyte clustering. The same results have been depicted in this bar diagram. Maximum patients with a VAS score of 8 had this finding, and all the patients with VAS score 9 and 10 had this finding. With radiological parameters, 67% of the patients lied in the category of Fuhrman grade 4, and 63% patients had modest type 2 changes. Here we can see maximum of the patients lying in the Fuhrman grade 4 and modest type 2 changes. The other features, namely inclusions and extracellular matrix, were also maximally associated with a VAS score of 8, and those with an abnormal extracellular matrix had a longer mean duration of symptoms, that is 13 months, and a Fuhrman grade of 4 was present in 67% patients. Coming to discussion, the exact reason which results in initiation of the degenerative cascade in the intervertebral disc still remains unknown. Previous studies have demonstrated the role of various inflammatory and signaling mediators in the degeneration process. All the factors we observed here were interrelated. We found that chondrocyte clustering was the most prominent feature, which can be considered as the first or the central event in the degeneration. Whether it is a defense mechanism of the nutritionally deprived chondrocytes or a normal aging process needs to be determined. Under normal circumstances, the chondrocytes lay down the extracellular matrix, which is essential to maintain a favorable environment for the viability of cells. The accumulation of abnormal matrix suggests an hyper-response of the clustered or stimulated chondrocytes in a response to uncertain, unfavorable stimulus. Presence of large inclusions implies a cell progressing towards apoptosis. It needs to be determined whether the process of apoptosis in a normal healthy disc is comparable to that in a degenerative disc. Studies have shown an occurrence of greater number of apoptic cells in the affected disc tissue. Our study was limited to a relatively smaller sample size, with most of the patients having an advanced degree of degeneration and no healthy controls available. To conclude, electron microscopy can be a very useful tool in intervertebral disc degeneration. Chondrocyte clustering may be the herald of onset of the degenerative cascade. It also has a direct correlation with clinical and radiological presentations. Longer is the duration of symptoms, more pronounced are the electron microscopic changes. Thank you, sir.
So a nice presentation, Dr. Prashanth, and a nice electron microscopy correlation with the symptoms and the duration of the symptoms of the patient. Definitely, this gives us an insight as what can be the reason for the disc generation, which is still an enigma. Some think about inflammatory process, some think about an infective process. So electron microscopy may help us to find some treatment later on, which can prevent a disc disease. So what was your correlation with the age of the patient? And I think the sex predilection was not that much, but what about the age?
Sir, age of the patient, the minimum age of the patient was 35 years. Maximum age of the patient was 71 years in our study. Maximum of the patients fell in the category of 20 to 40 years age group, sir.
So how does it correlate with your finding, electron microscopy findings in different age groups? Was there any change?
Sir, in an advanced age group, the findings which were present were the abnormal extracellular matrix and apoptic bodies were more in the age group of beyond 60 years. Whereas the age group between 20 to 40 years had chondrocyte clustering equally distributed as it was in the advanced age group. So that might be because of, sir, an hereditary this thing, or some underlying inflammatory process that chondrocyte clustering is even in
So
the young.
what I gather from your study is that in 92% there was chondrocyte clustering. In around 60-70% there were other findings like inclusion bodies or extracellular matrix.
Yes, sir.
So in some of the patients, the electron microscopic features were almost normal. Okay.
Yes,
So
sir.
were they in the lesser age group, or were they in the middle age group, or were they in the higher age group? That is what I want to ask. Some patients had a near normal electron microscopic features. So which age group were they in?
Sir, all these features suggest a degenerative process like chondrocyte clustering, inclusion body.
So, but they were not present in all the patients.
Yes, sir. They were not present.
They were present in about some features were in 60-70% patients, and some were in 90% patients.
Yes,
so there were probably some 10 to 20% patients who did not have any of the features suggestive of the degenerative diseases on electron microscopy. I'm just asking, is there any correlation with age?
Yes, sir.
Or is there any correlation of these normal findings with the symptoms?
Sir, shorter duration of symptoms. Those patients who had an acute presentation and underwent a surgery in a relatively shorter duration were less likely to show these features.
Okay. So one was the shorter duration. Any correlation with age or any correlation with the MRI findings?
Correlation with age was there, sir. The younger age group was less likely to show these features. However, MRI correlation could not be established because all the patients were in the Fuhrman grade 4 or 5, those who were going for surgery. So that was a limitation of our study, sir. But age and duration of symptoms definitely had a correlation with the amount of findings on electron microscopy.
Okay. What do we deduce from this surgery? What do we gain? I mean, like doing all this electron microscopic study. How is it helpful? How is it going to be helpful to the future patients? And what message do we give?
Sir, taking into account the vast prevalence of low back pain and lumbar disc herniations, we need to find out options like intradiscal stem cell therapy or implantation of hydrogels. So, sir, to develop these strategies, therapeutic strategies, we need to understand what can be a biologically ideal substrate. So to understand that, we need to go through the ultrastructural electron microscopy.
Do we advocate an early surgery in these kind of patients? I mean, like, do we deduce that? I mean, Rahul.
The early surgery will have less changes in the disc, so it may be beneficial.
Yeah.
This is what. Yes, I want to
and how to convince the patients to go to undergo an early surgery? People usually delay the surgeries. They don't want to get operated at all.
Sir, except in cases where performing surgery
unless they have neurological deficit, only then that is a
has a emergency or neurological deficit. Sir, because these the changes which we observed can be considered as a representative of the all of the intervertebral discs of a patient. So we can also predict the future course of the illness or the susceptibility to develop the herniation
in other discs, you mean? Yeah.
So maybe if we can have a good follow-up, then we can correlate these findings with the follow-up improvement in the symptoms and any recurrence of symptoms, and then they can be correlated. So we need a larger study and a longer study.
Yes, sir. And with a follow-up will be a better study.
Yeah, it's quite an innovative study. It's really enlightening.
Chondrocyte clustration.
Sorry, sir?
Chondrocyte frustration.
Is there any way to prevent chondrocyte clustration so that we don't go into the cell?
Sir, what we observed, we think that it is the first event, it is the initial event. So what leads to the chondrocyte clustering is that
prevention.
Yeah, that is what it is. Can we prevent a patient? I mean, it would be useful if we can advise a patient to have those kind of chondrocyte clustering inside the discs before the surgery, so that the surgery can be averted.
Yes, sir. So those factors which lead to the chondrocyte clustering need to be identified, sir, which may be
inflammatory mediators, which may be genetic susceptibility because of certain genes. Studies have shown susceptibility due to like SMAD7 gene or a role of interleukin 6 in this thing, sir. So these factors need to be evaluated, sir, which can be then applied in clinical.
Very nice.
Where did you do this electron microscopy?
Sir, in our center, it is available, sir.
Okay.
One.
Yes, sir.
The pictures were very good, actually.
I think we should move to the next candidate.
Yeah.
Yeah. Do we have?
Yeah, I think we have one more.
So I invite Dr. Jayanika Kutum to deliver her talk. Over to Dr. Jayanika Kutum to give a talk on evaluation and comparison of two anesthesia protocols for electrocorticography guided epilepsy surgery. Have you found our ideal anesthetic regime? That is the topic of discussion. Please go ahead, Dr. Jayanika.
Thank you, sir. Good morning. I'm Chanika Kutum, third-year resident in DRNB Neuroanesthesia and Critical Care. My topic is evaluation and comparison of two anesthesia protocols for electrocorticography-guided epilepsy surgery. Have we found our ideal anesthetic regime? Epilepsy surgery is needed in drug-resistant focal epilepsy. It requires precise mapping of the epileptogenic area and hence is done under ECOG guidance, which is the direct recording of the EEG from brain surface. Avoiding or minimizing interference to intra-op ECOGs by the anesthetic drug is the most important anesthetic concern for us. Various anesthetic drugs have been studied with variable effect on intra-op ECOG signals. They may either suppress or enhance it. So to minimize the interference, the anesthetic agents are often reduced or stopped prior to ECOG recording, which may result in undesirable intra-op awareness. So the optimal anesthetic agent for epilepsy surgery should minimally affect the ECOG without requiring dose reduction. So the ideal requirements for the optimal anesthetic regimes is that they should have no or minimal interference to ECOG recordings, no hemodynamic fluctuations, and they should not cause any intra-op awareness. Dexmedetomidine is an increasingly popular neuroanesthetic agent and has been seen to have promising role in epilepsy because it causes minimal effect or marginal enhancement of ECOG. However, its effect on intra-op ECOG is inadequately studied. Also, it cannot be used as a sole anesthetic maintenance drug, and its combination with routine anesthetics are not evaluated. Our study compares two dexmed-containing anesthetic regimes, and it is the first study of dexmed combination in ECOG-guided epilepsy surgery. Our aim was to study the effect of dexmed on ECOG recording when used in combination with either propofol or isoflurane, and also to study the effect of both these combinations on intra-op awareness, hemodynamics, and anesthesia recovery. We also aim to compare the two combinations and to determine the suitability for use in epilepsy surgery. Our primary objectives was to see the changes in electrocorticography, and our secondary objectives were to see and compare the following parameters in both the groups, that is hemodynamics, recovery pattern, and awareness. As per the objectives, these were our primary and secondary outcomes. So, as the effects of dexmed isoflurane and dexmed propofol combinations are being studied for the first time, we made a hypothesis that either of the combinations would be non-inferior to each other with respect to effect on ECOGs, intra-op awareness, hemodynamics, and patient recovery from anesthesia. Ours was a prospective randomized comparative study conducted over a period of 18 months, and these were the inclusion and the exclusion criteria. The patients for surgery were selected by the institutional epilepsy team. Detailed pre-op evaluation was done, informed consent was taken. Regarding anesthetic monitoring, bispectral index, that is BIS for anesthetic depth, was added to the routine neurosurgical monitoring. Anesthesia technique, in both the groups following drugs were common. In addition to this, in group I, patients receive isoflurane, and in group P, patients receive propofol to maintain a BIS of 40 to 60. After craniotomy and dural reflection, ECOG grips were directly placed over the brain surface. After that, the BIS was increased to 60 to 70, that is the anesthetic depth was slightly reduced. Then the first ECOG reading was taken in both the groups, that is the control and baseline for each group. Then Dexmed bolus was given over 5 minutes. After that, the second ECOG reading was taken. Dexmed was continued till the end of the surgery, and post-operatively, patients were closely monitored. The following data were interpreted: ECOG pattern, hemodynamics, recovery pattern, intra-op awareness, and other events like seizure or malposition of electrodes. This is the Martin grading to grade the ECOG. Here there are 5 grades, and as the grade increases, there is increase in amplitude and decrease in frequency. Usually grade 1 is considered normal, and grade 2 to 5 falls under the abnormal or the restrictive zone. And in grade 4 to 5, we can see epileptiform activities. This is the modified Bryce interview, which is a set of 5 questionnaires, and it is used to assess the incidence of intra-op awareness. If the answer to question number 3 is yes, then it indicates intra-op awareness. This is the layout of the epilepsy OT with the surgeon on the head end and the neuroanesthetist with the neurologist at the foot end of the patient. Here is the representative case of right MTS with the MRI showing hippocampal sclerosis. Next is the intra-op image of the exposed cortex with the grid electrodes in place. And this is the resected lesion, that is the hippocampus. Here we can see 2 ECOG recordings. First is the pre-resection with increased spike wave activity. And the second ECOG reading is the post-resection with the spike waves absent. Statistical analysis: data was analyzed using appropriate tests for each variable. The demographics were comparable. The following bar graph shows the distribution of epileptic lesions and type of surgery done. Mostly, the most common diagnosis was MTS, that is mesial temporal sclerosis. Electrocorticographic findings: in group I, there was significant increase post-Dexmed bolus, whereas in group P, there was no change. The time to emergence was longer in group I as compared to group P, but the time of extubation was similar and normal in both the groups. Hemodynamics, that is heart rate and MAP, were comparable. Isolated events of bradycardia and hypotension were there. No seizure or electrode malposition. Now the effect of anesthetic regimes on ECOG. Firstly, the Dexmed isoflurane combination. These are the previous studies done, which show that satisfactory ECOG recordings obtained with the use of isoflurane alone, whereas there was significant increase in ECOG in one study when Dexmed was given alone and for limited time. Whereas in our study, satisfactory spike wave activity was seen. There was no depression of ECOG. However, there was significant increase in ECOG when combined with Dexmed. Coming to Dexmed propofol combinations, these were the previous studies which show the satisfactory ECOG recordings were obtained with use of propofol alone. However, propofol can cause the obscure the underlying spike activity for up to 20 minutes, which is a major shortcoming. Whereas in our study, satisfactory spike waves were found. There was no depression of ECOG, and also there was no change in ECOG grade when combined with Dexmed. Bradycardia and hypotension are the known side effects of Dexmed. Previous studies show that both Dexmed regimes are not studied in epilepsy before. However, Dexmed has been shown to maintain intra-op hemodynamic stability in supratentorial surgeries. While in our surgery, in both the groups, hemodynamics was stable. Only few episodes of bradycardia and hypotension were seen, which responded to IV fluids and did not require any pharmacological intervention. Regarding effect of anesthetic regimes on recovery profile, delayed recovery was seen with isoflurane in previous studies when compared to propofol. In our study, the emergence time was significantly high in group I, whereas extubation time was within normal limits. However, this did not lead to the delay in post-op neurological examination. The recovery times were normal in group P. Now the effect on intra-op awareness. Intra-op awareness was found in one study receiving propofol and remifentanil, whereas in our study, there was no incidence of intra-op awareness. Limitations: we had a few limitations like limited sample size, no awake ECOG recording, Dexmed bolus over 5 minutes, ECOG was manually analyzed, and there was a slight possibility of bias. So to conclude, Dexmed plus propofol, they had no effect on ECOG, hemodynamics, intra-op awareness, and recovery time. Second group was Dexmed plus isoflurane. There was no ECOG suppression, no hemodynamic instability, and intra-op awareness. whereas it augmented the ECOG and prolonged the emergence. However, increase of both these parameters were not in the harmful range, and it should be emphasized that it requires further studies in larger patient group. So as per our hypothesis, we found both the regimes to be non-inferior to each other regarding optimal overall efficacy in epilepsy surgery. So have we finally found the ideal anesthetic agent for epilepsy surgery? In our study, propofol dexmet was found to be near ideal combination. However, with certain limitations, like time to increase BIS after decreasing propofol is higher, there were isolated cases of bradycardia in patients with already baseline bradycardia. Both of these needs anticipation and proper planning and preparation. So to finally conclude, to cement its place as the ideal anesthetic regimen in ECOG-guided epilepsy surgery, propofol dexmet should be tested more using larger sample size. Thank you.
Thanks, Dr. Chenika. It's quite a lucid talk. Since this is a field of interest of Dr. Tyagi, I would request Dr. Tyagi if he can put in a comment.
Yeah, I think it's a beautiful study and very enlightening for us also. The epilepsy surgery. I would like Dr. Kj Chaudhary to come, our senior neuroanesthetist. His video is on now. I think comment, and he's the one who helps us do the epilepsy surgeries. Dr. Chaudhary?
Yes. Actually, this this is now standardized with BIS, that is the depth of anesthesia monitoring. It is easy to find out whether you have to balance between the patient is awake or is deep enough or too deep to suppress the recordings. So it is now standard practice to use dexmedetomidine and propofol preferred to other inhalation anesthetic agents. So you can easily regulate and BIS, which is also a EEG based monitoring. And that's a good work, dear. Good
yeah, nice presentation, and definitely this will help in the outcome of epilepsy surgery patients. Yeah, nice study.
And BIS monitoring is now a standard in anesthetic practice in most hospitals, so it should not be difficult.
Yes, especially in epilepsy surgeries where we have to monitor or reduce the dose so that there is no interference with the ECOG. So BIS comes to be very handy, sir.
Good presentation.
Yes, thank you, sir.
Does that conclude our session, or any speaker left? I think the time is over.
Dr. Bhanu Pratap, sir.
Sir, I am here, sir. Dr. Bhanu Pratap.
If we are having Dr. Bhanu, we can.
Yes, sir. I am here, sir.
But you are late, I think. Your session was the first session.
You can make it quickly. Okay.
There was connection error when I was connected, sir.
Respected chairperson, with your permission, we can allow him to have his session in short.
Yeah, we can allow.
Yeah, we can.
Plus,
it's quite an interesting talk. Please, Bhanu Pratap, go ahead.
Good
finish
morning,
in
sir.
time, please. Yeah.
Good morning, all of you.
Good morning.
So my topic is role of SOC17 gene in the genesis of intracranial aneurysm. This is an institutional study. There are many risk factors which have been established in the role of genesis of the aneurysm, like age, gender, hypertension, cigarette smoking, and there are many more factors. So genetic predisposition of intracranial aneurysm formation and rupture is considered as one of the major factors for formation and rupture. So in 1995, Shiving et al. Established a fourfold risk of SAH in aneurysm among the first degree relatives which were harboring the aneurysm. So genome-wide association studies conducted between 2008, 2010, 2012 has identified various loci responsible for aneurysm formation. One of the loci was on chromosome 8 on short arm on loci 11.23, which harbors SOC17 gene, which is a SRY related homeobox transcription factor, which encodes a transcription factor required for vascular maturity. So in vivo studies have been conducted. Deletion of the SOC17 gene can induce vascular malformation resembling aneurysm, like vessel wall dilatation, tortuosity. There is no Indian study as of now conducted on SOC17 gene, whether it has been associated or not, sir. This is our first Indian study, which was conducted on Indian population, sir. The aim of our study was to study the association of SOC17 gene with the intracranial aneurysm. We conducted study between 2020 to 2021. 50 patients were included, which were diagnosed on the basis of CT angiography or DSA, and 50 controls were taken. We conducted a data analysis with SPSS version 23, and we took the peripheral blood, which was sent for genetic expression. First, we extracted the RNA. Then we extracted from RNA, we synthesized a complementary DNA with the help of reverse transcription process. Then the complementary DNA was put in RT-PCR machine, polymerase chain reaction, which indicates the cell cycle threshold of the particular gene, and we compared our particular target gene with the housekeeping gene. Our housekeeping gene was beta-actin gene, which was present in all the individuals, and we calculated the delta CT. We calculated the delta CT. Delta CT is CT, cycle threshold of gene of interest, minus cycle threshold of housekeeping gene. Housekeeping gene is beta-actin gene, which is present in all the normal individuals. And we calculated gene expression by the Lievak method, which is expressed in the form of fold change. 2 raised to power minus delta CT. Delta CT is delta CT of sample and delta CT of control. If the delta CT is less than 1, then the gene is underexpressed. If it is more than 1, then the gene is overexpressed, sir. This is the graph showing the cycle threshold value in the PCR gene. We have on x-axis we have CT value. On the y-axis we have RFU value. The RFU is relative fluorescence unit. These are the samples we on the test was done. Relative quantification of our gene of interest, sir. That was SOC17, and we got in cases we got 6.56 delta CT, and in controls we got 1.17, and p-value was statistically significant. 5.39 times overexpression of SOC17 gene was present in the cases of aneurysm as compared to healthy controls, sir. In conclusion, we conclude that with respect to beta-actin gene, SOC17 gene is significantly associated and is overexpressed in patients of intracranial aneurysm. There is role of genetics in the genesis of aneurysm, sir. Our limitation was it was a single center study, and the sample size was only of 50 patients and 50 healthy subjects, sir.
So I think that's an interesting study, Dr. Bhanu Pratap. Definitely there has been some correlations with the aneurysm formation. We are yet to pinpoint on one particular specific reason. And this genetic predisposition is also long thought for, since we have some families which have a lot of predilection for aneurysms, and it runs in the families. So this will be an interesting finding in Indian population, and we definitely need a larger study. So I invite questions from the audience. Yeah. Your comment, please, Dr. Bhanu. Would like to add something?
Korean and Chinese studies has been done, sir, on this particular gene, sir.
Okay.
Yes.
Any questions from the audience?
I think we don't have much time now. We have to move to another session, Chairperson.
Okay.
So if you can conclude.
Dr. Basin, sir, please. So I think that was an interesting session, and we had 6 presentations from the budding neurosurgeons and 1 from the neuroanesthetist, and all the presentations were very good. And thank you, Dr. Sudhir.
Yeah, kindly send the marks for the award papers.
Yes, sir. We'll send it across. Yeah.
Thank you so much. So we move. So
we end this session.
Split session of neurosurgery. Session is on trigeminal neuralgia. And the chairperson for the session will be Dr. Alan Gupta and Dr. Manmohan Singh. Dr. Gupta is a alumni of KGMC Lucknow, the prestigious college, and right now he's heading the Department of Neurosurgery at RML Hospital, Delhi. Dr. Manmohan Singh is alumni of AIMS and is right now working as the professor of neurosurgery in the Department of Neurosurgery, AIMS. I invite both of the chairperson to conduct the session. Dr.
Hello, good.
Manmohan Singh.
Good morning, Dr. Sudhir. Thanks for the kind introduction. Can you hear me?
Yeah, I can.
Yeah, sure. So thanks. And now we will be having a good session of split session of trigeminal neuralgia. So we have 4 speakers today, and our first speaker will be Dr. DAY-2 Devnath. He'll be talking about the basics and the clinical aspects of trigeminal neuralgia. So I think we will have a combined discussion at the end of the session. I think it is okay with the other chairperson. Hello.
I think Dr. Alan Gupta is not.
Okay. Okay, fine, no issue. I think we'll have common discussion at the end of the session. So that will also save a little bit of time.
Okay.
So our Dr. Dyapan is available?
Yeah.
Dr. Dyapan, kindly carry on, please.
Good morning, sir, and happy Sunday to everyone. Myself, Dr. DAY-2 Devnath. I am attending consultant at Indraprastha Apollo Hospital. Our team comprises of Professor Ravi Bhatia, Dr. Sudhir Kumar Tyagi, Dr. Sunit Mediratta, Dr. Aditendra Singh Bhati, and obviously me, myself. Before starting my slide, I want to take the blessing of my mentors, my gurus, Dr. Professor A.K. Banerjee, under whom I was trained, and Professor Ravi Bhatia and Dr. Sudhir Tyagi. And presently, I am working with Professor Ravi Bhatia and Dr. Sudhir Kumar Tyagi. It is my privilege that I am being trained under all 3 of my mentors. So before going to my topic, just a simple definition of what is neuralgia and what is neuropathic pain. Neuralgia is a pain in distribution to a particular nerve distribution without any focal neurological deficit. On the contrary, neuropathic pain is
DNA में अरे DNA में चल रही थी अरे नहीं कॉन्फ्रेंस में 8 से 9 वाले में वो जब खत्म तो मैं जा रहा हूँ कह रहा हूँ
neuropathic pain on the contrary associated with some focal or profound focal neurological deficit. So it will be injustice.
रिसेंटली केस किया था उसमें मैं नहीं स्क्रब हुआ था जूनियर कर रहा था तो मैंने रोक दिया उसको ज्यादा करने से तो थैलेमस वाला निकला नहीं पड़ा हुआ था निकाल देना चाहिए.
Look, organizers, can you just switch off the everybody can switch off, please? Thank you. Except the speaker.
हाँ नहीं पड़ता मेरे को तो है ना कि मुझे ये होता है ना ऑलरेडी
Hello. I think a lot of disturbance is here. So
मैं कोई पीछे नहीं हटता मैं भी देखता हूँ चलो मैं होल्ड करो.
It will be injustice if we don't give the privilege to the great physicians, the neurosurgeons, the doctors who had contributed in trigeminal neuralgia. Just a brief history of trigeminal neuralgia. Sir John Locke was the first physician to describe. John Locke was the first physician to describe trigeminal neuralgia. Nicholas Andre.
अगर पेशेंट का न्यूरोलॉजी तो बहुत इंपॉर्टेंट है. अगर पेशेंट M5 है तो जरूर करना है. अगर पेशेंट कॉन्शियस है तो नहीं करना है. इसमें मैं क्लिनिकल जाता हूँ इस वाले साइज में मीडियम साइज है.
Hello. The audio visual, can you just switch off everybody?
हाँ. You can mute them.
Nicholas Andre gave the name of tic douloureux. Tic douloureux is a French word which means sudden painful situation. Professor Peter Janetta, who introduced a microvascular decompression for trigeminal anesthesia, and Lars Laxell did the first SRS for Gregorian ganglion lesion. So this is Professor Peter Janetta, who was an American neurosurgeon. As per my knowledge, he did the first MBD for hemifacial spasm. Correct me if I am wrong. And later on, he introduced the MBD for trigeminal neuralgia, which we a neurosurgeon do routinely for trigeminal neuralgia. So my topic will be divided in these contents: what it is, epidemiology, distribution, diagnostic criteria, subtypes, anatomical knowledge, and presenting complaints. Now, what it is? The International Headache Society had defined trigeminal neuralgia. Every word in this definition is meaningful. It is a recurrent, brief, electric shock-like pains, abrupt in onset as well as termination, limited to one or more division of trigeminal nerve, often triggered by innocuous, that is harmless, tactile stimuli over the distribution. This condition is highly debilitating disorder. It impacts the basic function of the every trigeminal neuralgia patient, that is talking, eating, drinking, touching, shaving. This results in poor quality of life to the patient, and it also impacts the psychosocial part of the life, that is increase in anxiety and depression with increased risk of suicidal tendency. Now coming to the epidemiology, in US, the annual incidence in female, it is little higher, 5.9 per 1 lakh population. In male, it is 3.4 per 1 lakh population. Overall incident is 0.03% to 0.3. The female is to male ratio is 3:2, and same is the right is to left ratio. The peak incident, it is little higher in the elderly peoples, 50 to 60 years. And usually the trigeminal neuralgia are unilateral. Bilateral cases are usually less, approximately less than 5%. If there is bilateral trigeminal neuralgia, the incidence of the association of multiple sclerosis should be thought. So this is a picture taken from Ravi Ramamurthy and Tandon book. They are based on the data of 16 series comprising of 8,124 cases. It is seen that elderly people at the age of 51 to 70 comprises the highest percentage, approximately of 57%. Now coming to the distribution, the same data of 16 series comprising of 8,124 cases. If we take the combined of maxillary and the mandibular, they comprises the highest number, that is the 32%. If you take isolated branches, the maxillary is having the highest, 17%, followed by the mandibular, followed by the ophthalmic division, which is far less. And the combination of all three is approximately 17%. Now coming to the diagnostic criteria, there are various diagnostic criteria which the physician follows, the neurosurgeon follows, but I will highlight only two, which helps in our clinical practice. International Classification of Headache Disorder Edition 3 diagnostic criteria. Criteria A, B, and C. The criteria A says recurrent paroxysms of unilateral facial pain in the distribution or distributions of one or more divisions of trigeminal nerve with no radiation beyond and fulfilling the criteria B and C. What are these B and C criteria? The B criteria is the pain lasts for few seconds to maximum of 2 minutes. It should be severe in intensity, and the type of the pain should be electric shock like shooting, stabbing, sharp, lancinating quality. And it should be precipitated by harmless stimuli within the affected trigeminal distribution of the face. Now another criteria, this SWIT criteria. Basically this criteria is more followed by the neurologist colleagues. It is more or less same as the international headache criteria. The criteria are 5. Number 1 is paroxysmal pain. Number 2 is pain provoked by light touch. Pain confined to trigeminal distributions. Pain is usually unilateral, and on examination there is no sensory deficit. Earlier, trigeminal neuralgia was classified as trigeminal neuralgia 1, which is typical, and trigeminal neuralgia 2, which is atypical. Now, in a recent classification given at BMJ journal, they had divided it into 3 types: idiopathic, classical, and secondary. The classical is more common, approximately 75%. The rest 2 share the same incidence, 15% and 10% consecutively. So what is the classical type? The classical type, there is a demonstration of MRI or intraoperative vascular compression with morphological changes in the trigeminal nerve root. What are these morphological changes? Distortion, indentation, or atrophy. So this is very important. Earlier, it was just a neurovascular bundle shown in relation to trigeminal neuralgia was considered the culprit, but it has been updated that associated there should be some morphological changes, that is the distortion, atrophy, and indentation of the root. Now, what are the secondary types? The secondary types are the underlying disease. There should be some space occupying lesion. It can be a cyst, it can be a tumor, it can be a infective pathology, it can be granulomatous pathology, it can be an aneurysm also. In idiopathic, if we don't find any such type of culprit, no vascular compression, no SOL, then we classified it as the idiopathic type. Now, this is a simple pathological changes in the trigeminal nerve. The basic change is the focal demyelination, which results in hyperexcitability of the nerves. This is the main culprit for the episode of the pain. So this is MRI picture. It is a real T2 weighted T2 heavy weighted image. On the both side, we can see the trigeminal trunk as well as the root entry zone. On the left side, we can see a vascular lobe, but more importantly, there is an indentation on the trigeminal nerve. We can see it clearly. There is indentation on the left side, which is more important. Same, it's a image on the right side where we see the trigeminal nerve is distorted. This is very important. Either there should be distortion or indentation, or there should be reduced bulk of the trigeminal nerve due to the vascular compression. Now, coming to the anatomical aspect. Earlier, it was believed that the root entry zone is the main culprit. The root entry zone is the nerve that exits the brainstem. Later, it was found that typically 3 to 4 centimeters distal to this root entry zone is the area which is known as the transition zone. So this zone is the area where the central myelination ends and the peripheral myelination starts. That is, the oligodendrocytes gives away to the Schwann cells. And this area approximately measures 2 mm in length. And this transition zone is found to be more vulnerable than any part of the nerve root. So for a wide acceptance, they had taken the root entry zone as well as the transition zone should be the main culprit. And for this reason, they had taken approximately 4 mm to 5 mm distance from the root entry zone as the area where there will be the maximum vascular compression. Now, coming to the presenting complaints. Obviously, it is a clinical diagnosis as according to the diagnostic criteria, which I already mentioned. The imaging is only to support the diagnosis to classify whether it is idiopathic, classical, or secondary, and plan the management accordingly. If it is a vascular, we will go for the MBD. If it is a tumor, we will go for tumor decompression. The pain is a typical trigeminal pain, which I already described: sharp, stabbing, electric shock-like. And the characteristic that it resolves as suddenly as it starts. It will start sudden and it will resolve immediately. There are some trigger points which will exaggerate the pain. The wind, chewing, talking, washing, shaving, brushing, any light touch in the trigeminal distribution will trigger this pain. So any patient entering the OPD with a facial pain, the characteristic will be the unshaved, halitotic, cachectic area. It's a hallmark of unremitting prolonged spells of trigeminal neuralgia. We can diagnose it just by seeing the unshaved, halitotic, and cachectic appearance. The frequency, it is variable from few episodes and maximum up to 100 times a day, and even there can be a prolonged period of remission. On examination, there is usually no evidence of any sensory involvement, but if we examine carefully, sometimes subtle sensory impairment can be seen. But if we found there is profound sensory impairment or absent corneal or continuous dull aching pain, it is a red flag sign that it is not a classical trigeminal neuralgia. It should be investigated to find out some space occupying lesion. So coming to my last slide, it is a 45-year female presented with 1-year history of left panfacial continuous pain, having left facial hypoesthesia with shuttle cerebellar signs on careful neurological examination. So this is the MRI showing a space occupying lesion on the left side with distortion of the trigeminal neuralgia. It's a meningioma on this area and it was being operated. So take home message, it is a clinical diagnosis. Imaging is just to support your clinical diagnosis, to classify and plan the management. The transition zone is the more vulnerable. Typical pain in trigeminal dystocia is the main criteria to diagnose the patient, and the red flag is the constant pain with associated neurodeficit. So if we examine the patient properly, take the history and manage the patient, both the doctor and the patient will smile like the smiley. Thank you.
Hello. Thank you, Dr. Dwapan, for your excellent presentation. And actually, you have clarified many points which are very, very important and very valid for our students also, so that they come to know that how to differentiate between the different varieties of trigeminal neuralgia, their etiology, and how to manage that. So we will go to our next speaker. So our next speaker is Dr. Nidhi Goyal. She'll be talking about the radiological evaluation and dilemmas in trigeminal neuralgia. Dr. Nidhi, please. Sir, call. I know. Please.
Hello. Good morning.
Hello. Yeah, Dr. Nidhi, you carry on, please.
Okay. Good morning, everyone. Good morning, Dr. Tyagi. Good morning, Dr. Devnath. Today, I'm going to cover the radiological aspect of the trigeminal neuralgia. Dr. Devnath had made it very easier for me that he has introduced the basic concept of trigeminal neuralgia already. He has also covered a bit part of the radiology, but I will just elaborate that part of radiology, how to evaluate trigeminal neuralgia. So I will not go into the definition of trigeminal neuralgia that has already been taken care. We know how it is, what are the presenting features. So we will directly come to the main part, that the radiology part. Once the clinical diagnosis of the trigeminal neuralgia has been made, we need to confirm the findings. I completely understand that it is mainly a clinical diagnosis. Radiology is only helpful to confirm the diagnosis and to rule out other causes of trigeminal neuralgia, where we know microvascular compression is the most important cause. It is important to understand for the clinician as well as the radiologist specific imaging technique, and along with what kind of a compression that the vessel is causing on the nerve and which part of the nerve is involved. These are the three most important things that we need to learn when we're talking about the radiological evaluation of trigeminal neuralgia. To understand these three things, we need to revisit the anatomy of trigeminal at the fifth nerve once again. Dr. Devnath is already... Sorry, can you... help in the management of various diseases. Can we please mute the rest of the people? So that... Thank you so much. So Dr. Devnath has already shown this schematic diagram, but I will go through it once again. I do understand that he emphasized the transition zone is the most important component, which is responsible for the vascular compression on the trigeminal nerve. But just to elaborate it a little more, the fifth nerve starts from the root entry point, which is the part from the pons where it takes off. Then there is a short cysternal component, and then it enters into the porous trigeminus, where it gives the three sensory nerves. So the cysternal component in the root entry point is further divided into two parts. This is not a radiological division. This is a structural division depending upon the myelin sheath which is covering the fifth nerve. The myelin sheath, if it is the central myelin sheath, that it is covered by the oligodendrocytes, this is a proximal part. And if it is covered by the Schwann cells, it is the distal part. Practically, we divide the cisternal component into two parts, which is almost the mid part of the cisternal component of the trigeminal nerve. The proximal part, which is covered with the thin myelin sheath, is more prone to microvascular compressions and is less capable of regenerating itself. It has also more prone to demyelination. That's why any kind of microvascular compression happening before this transition zone, has been emphasized in already, will be more symptomatic as compared to any kind of microvascular compression happening in the distal half of the cisternal component of the trigeminal nerve, which we call as the peripheral zone. So if we see this schematic diagram in the radiology, because this is what eventually we have to see in our daily day-to-day practice, is this is the entire thing is the fifth nerve. This is the root entry point where it is taking off from the bones. This entire thing is the cisternal component, and this is the porous trigeminus, and this is the Meckel's cave where it divides into sensory components. Once we this is again an anatomical division, not a radiological division, structural division. The cisternal part is divided into two parts by the transition zone. This entire thing, the root entry point and the proximal part, is actually the central zone, which is more prone to be which is more prone to cause symptoms if it is being compressed by microvascular structures, because it is less capable of regenerating itself. It is more prone to demyelination because of the thin myelin sheath it is covered with. And these are the corresponding axial images showing the root entry point, the cisternal component, and the porous trigeminus. So what exactly is the vascular compression? Vascular compression is when a vessel arising from basilar artery, like superior cerebellar artery, which is the most common culprit, touches the trigeminal nerve either on the superior part or the inferior part and irritates it. It irritates, causes demyelination, as already been discussed in the previous talk by Dr. Devnath, but just emphasizing on it again. This is how it looks on intraoperative table. This is the fifth nerve complex. This is the 7th, 8th nerve complex. And this is the superior cerebellar artery closely abutting the fifth nerve complex and irritating it, being the cause for the symptomatology of the patient. And this is the MRI picture. As we have already seen, the sagittal images shows the fifth nerve like this. And this is the artery which is in close contact with the nerve. Now, what as a radiologist you are supposed to tell, what is the vascular compression? These are the two things we will cover now. The vascular compression is mainly happens by the superior cerebellar artery, which is a branch of the basilar artery. The other two vessels which can be responsible are the anterior or the inferior cerebellar artery. Sometimes the vein can be responsible for it, which can be transverse spondyline vein in the Meckel's cave. The aim, the imaging protocol, the main imaging protocol will remain to delineate the trigeminal nerve and the adjacent vessels. How we will do it? A normal MRI image will never be able to delineate these structures very well. So a very heavily T2-weighted images, which will enhance the CSF space and enhance the vessels running into the CSF space and the arteries in it, will be the stay point for all the MRI images. These heavily T2-weighted images are usually volumetric sequences. We don't do these images in a sagittal, coronal, and axial images separately. We take a volumetric data from the base of the skull, reconstruct these images into the sagittal and the coronal images. Along with it, we take the whole brain, T1 weighted and axial flare images as well. How these T2 weighted images are look like? Can we see that this is a heavily T2 weighted images, which shows us the CSF absolutely wide, and all the structures running through the CSF will get highlighted. For example, this is the fifth nerve complex, and there is a structure that is supposedly an artery which is crossing the fifth nerve. How we will confirm that it is in close contact with the fifth nerve is by looking at the sagittal and the coronal images. We can see the superior cerebellar artery is traversing on along the surface of the fifth nerve. This is the cisternal part and the root entry point of the fifth nerve, where it is abutting the fifth nerve and probably responsible for the clinical symptoms of the patient. So what we are supposed to tell? We as a radiologist are supposed to first confirm, identify the cause if the patient has clinically presented with the classical features of trigeminal neuralgia. Whether the compressive vessel is an artery or a vein, please go back and trace the vessel. If you can trace the vessel to the parent vessel, you know it is an artery. There is no other way you will be able to differentiate whether it's an artery or a vein. The name of the vessel, you have to know the anatomy, and you have to see whether it is arising from the basilar artery or the vertebral artery to see which particular vessel it is. Whether the vessel compresses the proximal and the distal half of the cisternal segment, as we have already discussed, and whether the vessel is abutting the superior aspect or the inferior aspect of the nerve, And the last most important thing is the degree of vessel compression. What we mean by saying the degree of vessel compression? If the vessel is only abutting without distorting the nerve, it is called the contact. Deformity is that when the vessel is actually causing a appreciable concavity of the nerve, it is causing the deformity. So this is how the MRI images look. These both are the sagittal images. This is the fifth nerve. There is no CSF space between the vessel, culprit vessel, and the fifth nerve. And this is where it is causing a deformity, appreciable concavity of the nerve. Okay. So this is my first case. This is already the case, I think so, also shown by Dr. Devnath. This is a vessel which is running on the surface of a thinned out fifth nerve on the left side. See that there's a difference in the thickness of the fifth nerve. And if we see the volumetric data of the sagittal images, we can see the artery is closely abutting the fifth nerve, the cisternal component of the fifth nerve. And this is how it looks. And we make the diagnosis that if the patient is clinically symptomatic, then this is actually the culprit. Why I'm going on the treatment? Because the radiology we sometimes have to also evaluate the post-treatment MRI of the patients. I will tell this in my further slides. The most important treatment is the microvascular decompression. Other ablative procedures are available, but MVD remains the most durable because it has the lowest risk of sensory deficits. I think so. The next speaker, Dr. Chaudhary, will going to take care of MVD. I will not go much in detail about MVD. So this is how it looks. This was our case. This was a patient who presented from outside India to us, and Dr. Pranav operated on this patient. This was an obvious deformity and thinned out fifth nerve. This is how it looked in the intraoperative images. This was the fifth nerve. This was the superior cerebellar artery closely abutting and causing the thinning of the fifth nerve. This was the second step where the nerve and the artery were released from each other. And this was the final step where there was a mesh placed between the nerve and the artery to release the contact between the two structures. And this is how it looked in the post-operative image. The artery was now no more in contact with the nerve, and there was a clear CSF space between the two structures. This was a post-operative scan of the same patient. This is the next case. I have deliberately put this volumetric data in this image, in this case, to make you understand how we acquired this data. So I will just go through this. This was another case, again operated in our institute itself. I will just stop here and will show you. This is the fifth nerve on the left side. This is the fifth nerve on the right side. Now clearly see what this structure is doing to this nerve. If I just move ahead, and now you can see this artery is coming in close contact of the medial and the inferior aspect of the fifth nerve on the right side. So this is how we analyze our volumetric data. And we then reconstruct into sagittal and corneal images to confirm the space between the two structures and whether there's a CSF cleft between these two structures or not. So these are intraoperative pictures of the same patient. This is where they were closely related to each other. This was when the adhesions were removed and they were separated and put separate to each other. And this was when the mesh was placed between the two structures so that the contact point between the two structures is completely removed. So after talking about the vascular compression, which is the most important cause, as Dr. Devnath has already told, we have to also look in the MRI for the other causes, which are categorized under the secondary causes of trigeminal neuralgia. Secondary causes of trigeminal neuralgia can be many, depending upon the point where they are arising. They can arise from the root entry point, means from the brain structure. The secondary point will be the brain structure. That is at the level of the brainstem. That can be the multiple sclerosis. That can be the mass lesion, infections or the infarcts happening in the pons and the medulla. Then comes the cisternal space. Cisternal space is a potential space where all the tumors from the 7th, 8th nerve complex or the 5th nerve complex will grow into and will cause a secondary compression on the other nerves which are running into the similar space. That will involve the schwannoma, meningioma or the epidermoid tumors. Other infections like leptomeningeal diseases, which includes the carcinomatosis, sarcoidosis, or even the meningitis, can involve the fifth nerve and cause the secondary causes of trigeminal neuralgia. Along with it, skull-based tumors arising from the petrous bone or from the clivus can also come into the prepontine systems, cerebellopontine systems, and causes secondary compression. So I'm sorry, I missed one slide. And these are the most important causes, but sometimes few tumors within the cavernous sinuses arising either from the nerves in the cavernous sinuses like schwannoma, meningioma, or inflammatory procedures like Tolosa-Hunt syndrome, or infections, or few things arising from the arteries which are running into cavernous sinuses like carotid cavernous fistula aneurysms can also be responsible for secondary causes of trigeminal neuralgia. So I will just run through few of the cases to make you understand how we'll see these particular cases in MRI. This was a patient.
Your time is already over. Let's conclude fast.
Okay, sir. So I will just run through 2 or 3 cases. I will just skip few cases out of this. This is a case this is a patient who presented with right-sided trigeminal neuralgia. The plain scan didn't show us anything. However, the post contrast scan shows us the enhancement along the 5th nerve. In the Mackel's case, this was a case of infective/inflammatory neuritis of the 5th nerve. I will skip this case and will just show the few examples. This was an epidermoid cyst which shows a restricted diffusion and was causing a compression on the cisternal segment of the 5th nerve. Similarly, an infarct in the Pons area can cause the similar symptoms. These are 3 cases from the 3 different patients. This is a carcinomatosis, and this is a tubercular meningitis involving the 5th nerve bilaterally, and this was a perineural spread of the disease along the 5th nerve. I will just show this how a tumor like a schwannoma of the 7th and 8th nerve complex causes a compression over the 5th nerve. And this is, I will show as a last case. This is a case of multiple sclerosis. As we can see, the dorsal fingers running perpendicular to the corpus callosum, and similar demyelinating plaque can be seen at the base of the root entry point of the 5th nerve and in the proximal part of the 5th nerve, making one of the causes for the reasons of trigeminal neuralgia. So just the last thing, nowadays, along with the plain MRI, we have started doing the functional MRI images. This is a case that we did just a week back, in which we're doing the diffusion tensor imaging, calculating the fractional anisotropy, which assesses the microstructural neural changes. And the decrease in the functional anisotropy will tell us this much is the damage that has happened to that particular neural structure. So thank you so much. The take-home points, of course, are already being covered by Dr. Devnath. I will not waste my time on this. I will conclude my talk here. Thank you, sir.
Thank you, Dr. Nidhi, and for your wonderful talk and very lucid talk about the radiological aspects of trigeminal neuralgia. So our next speaker will be Dr. Kj Chaudhary. So is Dr. Chaudhary is around?
Yes.
Yeah, Dr. Chaudhary.
I'm trying to share.
Yeah, Dr. Chaudhary will be speaking on the interventional management techniques and management. So, Dr. Chaudhary, please.
I'm just sharing my screen. Good morning, everyone. And I'm going to speak on the pain interventions in trigeminal neuralgia. No need to go to the details that has been already discussed. So what options you have when the medical treatment fails? So you have local radiofrequency treatment. These are the usually patients who are refractory to medical treatment, are developing side effects that we can't continue with the medications anymore. You have so many options, both invasive and partial invasive or non-invasive techniques. And I'll come to them one by one. So different things are used: local anesthetics, steroids, chemicals, cryotherapy, Botox, and radiofrequency. I'm going to deal one by one. The first non-pharmacological options, I will straight go to the gastrin ganglion. And they are all destructive procedures that I'm going to tell. And they include radiofrequency thermocoagulation, percutaneous glycerol rhizolysis, balloon compression. And usually all these procedures are very high success rate. Gastrin ganglion radiofrequency is one of the common procedures that we do. It involves buying an equipment which is over 20 lakhs rupees. So institutions which can't afford, they have to see other options. The benefits of this gives a very precise, reproducible, and effective treatment. It has the advantage of stimulating the division that you want to ablate. So there is hardly any chance of getting the wrong division ablated. This has actually highest rate of pain relief, though it varies from person to person. After the radiofrequency ablation, it takes about 3 to 4 weeks before the full effect comes. Initial pain relief is 98% as much as MVD, and it may theoretically it can recur anytime after 6 months. It is based on the regeneration of the nerves, which you cannot predict. But if it happens, then you can repeat it again and again. And this is better because this is a minimally invasive procedure. It's a better option, better compared to MVD in case of high risk medical issues. The patient, the aim is to reach the foramen ovale entry point. The patient is positioned with the standard monitors and IV and in provision of anesthetic sedation like fentanyl propofol. To visualize the foramen ovale, the fluoroscope arm is positioned in the mento-orbital plane. And after local anesthetic infiltration, a 10 centimeter long 22 gauge radiofrequency cannula with 5 mm active tip is advanced from a point about 3 centimeters lateral to the ipsilateral angle of the mouth in a coaxial or tunnel vision till the X-ray beam reaches the foramen ovale. That is the most important part of the technique. And when it is observed from the front, the needle trajectory appears to be in the ipsilateral pupil. You can see that it is as if it is going to pupil, but in the lateral plane, it is as anterior to the external auditory meatus. So in this plane, you go as if you are reaching the pupil, and in the lateral plane, you can see that it is in the external auditory meatus. You can see the foramen ovale, and when you reach the foramen ovale, you try to reach the lateral part of the foramen ovale where the mandibular branch remains. As the tip of the cannula reaches the foramen ovale, the depth is ascertained by a fluoroscopic image on the lateral side. So this is the way it is done. And when it reaches the foramen ovale, you try to reach another 2 to 4 millimeters further in the foramen ovale until finally the electrode is placed at the junction of the petrous and the clivus. Excuse me. If you reach this junction, you are reaching the mandibular nerve division. It's just below the petrous junction. Sorry. Just short of the petrous clivus junction. But if you reach the clivus junction, then it is the maxillary one. And you usually don't use radiofrequency for the ophthalmic division, which is there is a risk. Excuse me, just a second. Sorry. Though you're using fluoroscopy, most of the time, recently introduced using a 3D image with the CT scanner, and it comes out very good. You can see the pictures down, and they gives a better picture of that. So I'm not going to the details. Once you reach the foramen ovale, how do you conform it? Do you use contrast? And if you are going for they need to stimulate before you do ablation. So the stimulation is done at 50 and 2 hertz frequency, and this is localized. When the paresthesia is less than 0.5, then you have to actually increase the intensity. And when you do ablation, which is around 60 to 70 degrees for 60 to 120 seconds, you need to sedate because that's a very painful part of it. These are the common complications with radio frequency. Now come to glycerol. Glycerol is an age-old technique. It doesn't involve any much of cost. The procedure is same. You reach the foramen ovale, and even once you reach the foramen, the patient is made to sit up, and the head flexed. And as it enters the foramen ovale, it is the most painful part, and it can have arrhythmias like bradycardia and can be hypertension also. Tip of the needle should not cross beyond the level of the clivus. Once the needle is in the trigeminal cistern, the stylet is removed and the CF should flow. If no flow is observed, then you can advance bit by bit by 1 millimeter increments and until the cistern is entered. Sometimes there is no egression, but if the patient develops hypoesthesia, I will consider that it is the final location. And once they are there, you can use a contrast to confirm that it is in this, it's a cisternography. Then you inject 0.3 ml of freshly prepared anhydrous glycerol. Actually, it is prepared freshly prepared just before the procedure. And it causes both neurolysis and as an osmotic effect. Then to block the mandibular division, you place the needle in the lateral and middle part of the foramen ovale. If the needle is advanced through the middle part of the foramen ovale, then you go to the maxillary division, the ophthalmic division, when you go and further go up. But of course, you confirm that it is the right location. Then, as the glycerol is hyperbaric, it will try to sink and produce discrete neurologic lesions in the third division. So this is mainly used for second and third division, and the results are very good. Cryotherapy, this is used to cool the nerves, and these are usually performed in the peripheral divisions of the trigeminal nerve. The tip of the cryo unit is placed, and some of the equipments have got a stimulator which you can confirm and stimulate the nerve to confirm that you are in the right place. Then you do using either nitrous oxide and carbon dioxide, that is the which causes the liquid to freeze, and you do the lesioning. And after the lesioning is done, then you wait for it to thawing before it is, because if it is frozen and you remove it, you can damage the nerve. So that is about cryo. Botulinum toxin is a very simple procedure. It is botulinum toxin works at the neuromuscular junction by inhibiting acetylcholine, thereby decreasing the muscle fiber activity. The subcutaneous injections are given at the trigger points in the area representing the most significant pain. 3 international units per square centimeter of pain area is injected. And initially we thought that if it goes to the muscles, it can produce weakness or paralysis of the facial muscles. But another study recently, they said that even it deliberately used in the masseter and temporalis muscles can improve the outcome. Gamma knife surgery, you are going to, this is in the stereotactic procedure that is usually confirmed in the radiological department, and where radiation is focused on the similar to the microvascular decompression. And instead of going to the Gasserian ganglion, we can use the peripheral nerves, and it is much easier to do blocks in the peripheral, like mandibular and maxillary division, where you can enter through the coronoid process, the what we call the transcoronoid approach, under the zygomatic process and the mandibular notch, go perpendicular and hit the pterygoid plate. Once you hit the pterygoid plate, then you direct inferiorly and posteriorly, then you will hit the mandibular division of the trigeminal nerve. if you have a stimulator, you can stimulate and confirm that it is you get mesenteric spasm or irritation. Then you confirm. If you are doing a diagnostic block, you use a local anesthetic and steroids. In case you want to do radiofrequency ablation, you can still do that in this procedure by stimulating just as in the gastric ganglion. Similarly, maxillary nerve is also easily accessed. You have to reach in the same way to the pterygoid plate, and you go anteriorly and superiorly, then you reach the maxillary nerve. And then you stimulate, confirm the location, and do a local anesthetic steroid or radiofrequency ablation depending on whatever you want it. There are superficial blocks, sometimes particularly for B1, you have supratrochlear and supraorbital divisions which can be easily accessed, and you can block them. Finally, I want to just mention that there are ultrasound-based therapies are there, in which case that works like low intensity, low frequency in surface acoustic waves. These are available. These are totally non-invasive. Patient wears these. This is the electrode here covering this area, and usually they wear all throughout the night. And this is can be hired also. If it is useful, you can use it. You can buy it and use it. Thank you very much.
Thank you, Dr. Chaudhary. And it is a very wonderful presentation. So I have got a question. So many times, for example, in case of trigeminal neuralgia, where you have done either glycerol rhizotomy or even radiofrequency ablation or other procedures, and the patients usually they do not respond for a longer time, around 6 months or 1 year, and they keep on coming. So at what time you say that this therapy may not be beneficial again? So when you are not going to repeat it?
No. Most of the procedures, the optimal effect comes in a couple of weeks. You have to wait for 2-3 weeks.
True. That is true. Patient has initially responded well, and he has remained well for a few months or maybe a year or so, and it has recurred. And many times we have seen that the patient's recurrence, that the period of the response has shrunken significantly, and the further injections or the ablations, so they may not work. So how many times you are going to repeat in these situations?
No, it will work. See, the best thing is when you are stimulating, if you are localize the division, then what used to go, we were a little cautious in using stimulation, the ablation. So what I do is, with the experience now that you have similar experience we had before, so what we do is we do lesioning for longer period. And you are using 60 to 70 degrees. Beyond that, it is actually maybe harmful. So not beyond 70 degrees, we use 120 seconds, 180 seconds. Then I rotate the cannula to 180 degrees, do the ablation again, and so that it covers the most of the areas. So it is actually rotating the cannula 2-3 directions within that division. That gives a better result. But you can't do more than that because you have complications like dysphagia, then corneal weakness, and so you don't like to take chance. So in that, recurrence is after this, what I described now. Beyond that, you can't do anything in the RF. So what the regeneration is that you cannot predict when it starts regenerating. So
that is true.
That is the problem. Theoretically, you can regenerate within 6 months. But we get an average 2 to 3 years of relief.
Okay, because we have come across many patients, many times these procedures that either rhizotomy, glycerol rhizotomy, or radiofrequency ablations. So the patient's response rate is maybe around 6 months to 1 year, and many times they recur, and they come for surgical procedures also, or maybe for radiosurgical. So that was my question, that how many times you are likely to repeat if there is a recurrence?
We see, I don't know whether they've lost to follow up or something, but to very few times that they come back. So, and if it remains pain-free for 2-3 years, they still continue with medications. So probably they last very long. But my emphasis is to do more ablation in different directions so that it covers the division completely. And
okay, that is fine. So which are the patients which you will not consider for rhizotomy?
See, rhizotomy is to me is the best choice. See, this simplest if it is a single division, and if it is a mandibular division, we can do it in the palatine fossa, which is much safer.
Right.
And because you stimulate and become very specific, and you can increase the intensity of ablation in peripheral mandibular divisions. So that gives good result. And also sometimes on the top of it, you can add alcohol, 0.2 or 0.3 ml of alcohol after doing ablation, so that it gives you, it partly answers your question because it can prolong the effect.
Okay. Thank you, Dr. Chaudhary. And our next speaker is Dr. Aditya Gupta, and he's a dear friend, and he is a wonderful surgeon, and he's also doing the radiosurgery also. So he'll be speaking on microvascular decompression. So Dr. Gupta.
Hi, Manmohan. Morning, everybody.
Hi.
I see a lot of friends here today morning. So thank you to the organizers for this very kind invitation. I'll just present some of my thoughts on MVD, which, as we know, is the best option for trigeminal neuralgia. So I hope my slides are visible.
Yeah.
Thank you. So I completely agree with the first speaker that, the diagnosis is predominantly clinical. And post that, of course, we've seen an excellent presentation on the radiologic diagnosis as well. And basically, what I would also like to highlight is MVD, though it is an invasive procedure, but it is a procedure which has probably the highest success rate and the long-term durability. So that is the single fact which keeps the patients still coming to us and agreeable for doing an MVD, because there is a general consensus and a general agreement that this is the most effective technique for dealing with trigeminal neuralgia. One other classification of the kind of procedures that we do is that if we consider them as ganglion level or central procedures and peripheral procedures. Now, just a brief slide about the history. I think the anatomic observations by Dandy was basically the first piece of information that we got about, in general, about neurovascular compression syndromes. And really, Janetta popularized this technique, and that is why this procedure still goes by his name. There are very few contraindications to a MVD procedure.
Slides are not moving, sir.
Sorry?
Your slides are not moving.
Are you sure? What?
It is not on slideshow.
No, it's on slideshow.
Not coming like that.
Are you seeing my slide, which is titled Trigeminal Root Entry Zone?
Yeah, I can see your 15 slides together.
I just give me a second. Just give me a second. I will share again. I have put it on slideshow. Are you seeing one slide now?
No.
No, multiple slides. It is not on slideshow.
Okay, let me just get out of the slide shorter. That is strange because I did click the slideshow. Are you seeing one slide now?
Yeah.
Yeah?
Yes.
Okay.
Yes.
Okay. But I agree with you, the slide is not moving. Now is it moving?
Yeah.
Yes.
Okay, so I just wanted to share that Dandy is the one who had the anatomic observations, and then later on Janetta popularized this technique, which we know by Janetta's name. Now, trigeminal nerve has the longest central myelin zone, and therefore you see the vascular compression syndromes that we see are much more commoner with the trigeminal nerve than it is with the other cranial nerves. Now, the basic surgical technique all of us are aware of. I will not go into that in detail, but I will just highlight some intraoperative pearls to achieve a good outcome in these patients. So the most important thing is to avoid retraction, which is actually the single most source of complications in this procedure, although the incidence of complications is very low. Second is a very careful incision of the arachnoid over the 7th, 8th nerve complex, and that actually helps in easing off any retraction that may be needed. So once the arachnoid is nicely incised along the 7th, 8th nerve complex, and then you go towards the superior petrosal vein, a sharp incision of the arachnoid actually is very, very important before you start any kind of retraction, even though personally I don't use a retractor in more than 90% of my cases. Now, cranial nerve 5th is deeper in the field and further away, so some work has to be done on the arachnoid there, and correct identification of the cranial nerve 5th and dissecting of the arachnoid over the superior petrosal vein. I think these are very, very important steps. Now, when we advance the cotinoid, that is also a point at which you can injure the veins. And the most important thing is to inspect the 5th nerve in entirety. And the commonest fallacy is to miss a loop which may be hidden away behind the nerve. And at times I've seen a loop hidden away between the divisions of the nerve as well. So the entire nerve right up to the apex from the root entry zone, the entire nerve has to be visualized. And also the part which is hidden away from us has to be visualized from all directions. Now, there can be many, many kinds of neurovascular conflict which sort of can be there. And this is what I've highlighted in this figure. And if there is superior petrosal sinus bleeding, the most important thing is not to panic. Try to identify exactly the source of the bleeding. Coagulate always as close to the cerebellum as possible, because then you need not coagulate all the divisions of the superior petrosal vein, which drain into the superior petrosal sinus. And some degree of head elevation. And I think most important is to have some degree of patience so that you don't really make too many unwarranted movements in the surgical field where there is already a lot of bleeding. Now, to show you a couple of videos. So this is a typical classic case of trigeminal neuralgia. And you can see that I'm incising the arachnoid. Now, the important thing to note is there is no retractor. There is just a cotinoid, and the instruments are carrying out what we call as a dynamic retraction. Now you can see very nicely the 7th, 8th complex. And you can see the 5th nerve now behind the 7th, 8th complex. And you can see the classic indentation by the offending vessel. Now, what I'm doing here is that I am delivering the entire loop of the superior cerebellar artery away from the trigeminal nerve. So once you do this maneuver, the nerve is completely free. And then, of course, it is the standard practice of placing whatever material you care to place and then insulate the nerve from the offending vessel. But the entire loop has to be displaced away from the nerve. Otherwise, if you just put some material there and try to create some space between them, that will not work very well. Now, this is a case in which the cistern was not very wide. So you can see the retractor there. And what I'm doing now is with the retractor, you can see the space is very, very limited. There is a very prominent overhanging ledge of the petrous bone, and the cistern was very narrow. Now with the Jacobson dissector, I am dissecting off this vascular loop from the 5th nerve. And here you can see the main problem is the cistern is very narrow. So in these cases, of course, one does have to use retraction. So this is another example of a classic case, and this is not an unusual situation to come across a case in which the cistern is actually very narrow and you have very limited space despite using a retractor. Now the final case is a MVD because of dolichoectasia, but it is not a trigeminal case, rather it is a hemifacial spasm case. But we can learn from this technique, which can be used even for trigeminal when you're doing MVD for dolichoectasia of the basilar artery. So this is the sharp dissection of the arachnoid, incision of the arachnoid, 7th, 8th nerve complex. And you can see now the basilar indenting on the 7th nerve. In fact, the vertebro-basilar junction could just be seen inferiorly. And this is the 7th, 8th complex. And this is the ICG injection showing you the basilar artery indenting on the 7th nerve. So what I first did is I fashioned a muslin sling over the blood vessel, which was the basilar artery. Then I passed a suture through the basal dura. And subsequently, I tied off the suture after bringing in the muslin sling into position so that you don't have a suture digging in into the basilar artery. So now bringing the muslin sling into the position and finally tying the suture over the muslin sling. So that was able to displace the artery away from the nerve and able to displace the basilar artery medially. So you can see now that the basilar artery is displaced medially, and ICG done later shows you that the nerve is no longer stretched by the dolichoectatic basilar artery. Now, just a little bit about the long-term outcomes of MVD surgery. So a good long-term outcome has been associated with several factors that have been studied. And these are just a few factors which I would like to point out. Now, arterial compression, if you find it has a much better long-term outcome compared to venous compression. And also, as was mentioned in the clinical talk, if you have a type 1, which is the classic paroxysmal pain, then these patients have a better outcome compared to those having constant pain with exacerbations, which is called as a type 2 trigeminal neuralgia. Now, duration of symptoms, if you have a patient who has actually symptoms for a lesser duration, then the percentage of freedom of pain is much higher. This is very important to note. So that's why in the best to do MVD in the first 5 years of having the onset of pain, rather than having 3-4 other procedures and then doing an MVD after 10 years of trigeminal neuralgia. And of course, classic trigeminal has a much better outcome. And post-op, if there is facial numbness, so it is, yes, common sense that these patients will have a higher degree of pain relief. But that is not to say that we should create a facial numbness by undue handling of the 5th nerve. I think one of the most important values of this procedure is that we save the facial nerve function. So a similar review in 2019 actually found exactly the same findings, that disease duration of 5 years or less, arterial compression, and superior cerebral artery involvement, and a classic type 1 trigeminal pain really were the markers of a good long-term outcome. So complications in this procedure are actually quite rare, although they are rare, but they basically arise from undue retraction and undue handling of the nerves. At times, the superior petrosal vein bleeding creates the situation in which you do undue handling of the nerves and you have to retract a lot more. So basically, retraction to me is the #1 source of all the complications in this surgery. And as we know, a number of reviews have highlighted that there is an excellent degree of long-term pain relief. At the end of 10 years, for example, 65 to 70% of the patients will continue to enjoy excellent pain relief. So with this, I'd like to end my presentation. Thank you.
Thank you, Dr. Aditya. Really good illustrations of trigeminal neuralgia, and especially this basilar artery manipulation. And in fact, these basilar artery aphasias, which compresses the 5th nerve, is really challenging. And many times, even if you try to move it away, and sometimes it may not be successful, but it is really one of the most challenging aspects of treating MVD in such scenarios. So this debate is now open for discussion. Any questions and comments are really welcome from the house.
I want to, I missed one slide, that balloon compression also is a very good technique, particularly for ophthalmic division. It is quite safe and the same procedure. And balloon compression is getting popular actually these days in overseas, but not in India as much.
Definitely.
Dr. Manmohan, I want to
Yeah.
experience about the radiosurgery because we could not adjust the session for the radiosurgery here. But
yeah,
a little bit about the radiosurgery, which part of the trigeminal nerve you would like to prefer to radiate by the SRS?
Dr. Sudhir, the situation is that, in fact, radiosurgical procedures, especially at our center and especially me, it is not a very preferred treatment of trigeminal neuralgia, especially if the patient has the classical presentation. So we always offer them for surgical intervention. So that MVT is always preferred. So we reserve radiosurgical procedures only for patients, those who are not opting for surgery or they have medical debilitating procedures, or sometimes in cases of the atypical neuralgia.
This is not my question.
Yeah, exactly. So our target is especially the root entry zone, just beyond that this origin of the fifth nerve from the brainstem. So that is the target, so that the radiation spillage to the brainstem is not much. So that is the situation, and we always target at that level, and especially the cisternal part.
No, I think, Manmohan, you are basically saying that you target the anterior cisternal portion, isn't it?
Yeah.
Yeah. So what Manmohan is saying is that he targets the anterior cisternal part of the nerve as it comes out from the ganglion.
Right.
Yeah, exactly.
That's what my question.
So that is the situation, and so that gives a lasting result, because the radiation dose where actually the patient has got the pain relief is to the tune of around 90 gray. That is a point dose. So it is a very huge dose of radiation. So we have to use it very judiciously, and many patients, they have the dysesthesia or sometimes numbness over a period of time. And overall 5-year release rate is less than nearly around 50%. So many patients, they have got a relief, and many patients, they keep on complaining some sort of abnormal sensation of the face in the long run. So that is a scenario, and this is the reason that we do not prefer over this majority of the patients, especially those patients who are young and with the classical presentation. So
incidental finding of a vascular loop. We have seen patients with an incidental finding of vascular loop without any symptoms. Can you explain?
See, many times the vascular loop may not be visible on MRI. Once you operate, so you will always find that lesion. So few of the vessels, especially the small vessels or the veins, they are hidden along with the nerve. So once you handle the nerve a little bit and coagulate those veins, so that will take care of the trigeminal neuralgia and most of the patients. That's why even if you don't find any radiological evidence of compression, so MVD is likely to help them also.
No, my question was different. Patients with a MRI finding of vascular loop without symptoms.
Yeah. Okay.
So how do you?
No. If there is no symptoms, it may be a normal association, because there are a lot of vessels into the cisterns which are in close proximity to the 5th, 7th, and in the lower cranial nerve. So we are not going to do anything for that. If only the patient has got the symptoms, only then we have to treat. Otherwise, there is no way.
You mean the pressure of the vascular loop is not adequate, so there is no symptom?
Yeah, exactly. So because all the nerves will have with some sort of vascular relation. So all nerves are in a very close association. So you can in other way say that many of the patients have a significant indentation of the nerves, because once we operate, we open up the basal cistern in majority of the other tumor patients. So there are vessels in relation, and many times they are indenting the nerves also, but they are not symptomatic. So I think that the only patients, those who have symptoms, they need treatment. Otherwise, no.
Correct.
And I think another aspect we did not discuss here is the neuralgia associated with tumors. The most common tumor which actually has the presentation of neuralgia is the epidermolysis. But in our clinical practice, petrous apex meningiomas, small schwannomas of the fifth nerve, or even the cavernous sinus lesions, they also present with trigeminal neuralgia. and treating those small lesions, especially the small peterocephalus meningium or the cavernous sinus tumors. So many times the tumor is treated, so they are not growing, they shrunk in size, but the neuralgia continues. So that we have to warn these patients that it may not get treated, and many patients, they keep on coming for the management of neuralgia. So upfront, the surgical decompression of these nerves may be indicated at the first go rather than treating with radiosurgery. So this is our long-term evaluation of these patients, that small tumors presenting with neuralgia, so we need to warn patient that neuralgia may not disappear. So you may be a better candidate for surgery.
Can we conclude the session because we're running little late?
Yeah, Dr. Sudhir, thank you.
Yeah, thanks, Manmohan.
Thank you.
Thank you.
Sudhir.
The next session. We don't have time for taking a break. So we are moving to the next session. The session is on compressive cervical myelopathy. And we have the chairperson, Dr. S.S. Kale and Dr. Daljit Singh, very well-known personalities in the neurosurgical field. So can I ask Dr. Kale and Dr.
I'm already here. Is Kale around?
Hi, Dr. Kale, please. You can. I just take over and you can start the session.
I think it's still 4 minutes left to start the session.
Really?
Still 4 minutes left.
Yeah, no, I just talked to Kale. He's still logging in, so he will.
Okay, fine.
I thought you want to have a tea or.
Meanwhile, there's some change in the schedule because of Dr. Sudhir. He has to catch up a flight. So Sudhir will be the first speaker. I think just for the organizers, just make a note of it. Till Dr. Kale joins, we would be waiting because still 3 minutes to 10:30. So you can have a cup of tea if you want.
I like such tea breaks. सबको अपनी अपनी चाय पीनी है.
True.
यार कितने दिनों के बाद देख रहे हैं एक दूसरे को.
Thanks to COVID.
Physical meeting has its own, Absolutely.
Recording in progress.
Has Kale logged in? Hello? Has Kale logged in? Oh God. Can you hear me? Oh.
We still 1 more minute. So.
Can you hear me?
Yeah, everybody can hear you.
No, I mean, there was coming a bandwidth is low. My voice was not going. So I switched on from mobile to laptop. So suddenly I found this was, now it's working. No more such signal.
Hey, Shankar, how are you?
Fine, sir.
After a long time.
Everyone out there, sir.
Why? Sudhir Dubey, why are you wearing mask in house?
He's at airport.
Oh, he's in airport. Achha, okay. Okay.
I think it's 10:30. Let's start.
Hello. Hello. Hello.
Yeah.
Am I audible, sir?
Now, who is this? Who is speaking?
Dr. Shankar.
Yeah, of course we can hear you.
Thank you, sir. Thank you.
Right. No, this is a wrong paper being projected, pituitary microadenoma. Whose paper is it? We'll have to.
I have told Akash to make the change. So, Akash, can you listen?
Yes, sir. Yes, sir.
So, make that presentation on.
You are showing Sudhir Tyagi's Sudhir Mendi Ratna, but the paper is by Sudhir Dubey. Has Dr. Rajendra Prasad logged in? Sir, are you there?
Yes. Yeah.
Good morning.
I'm listening. Hi, good morning.
Morning, how are you?
Good, thanks. I'm just waiting for my turn. Patiently.
Yeah, some little change because of Sudhir's rearrangement.
That's okay.
Dr. Kale, are you there? Can we start?
Sudhir, why don't you share your slides?
In the meanwhile, Sudhir, can you share your slides? Good morning, everyone. I think we will start the session. Let Kale log in between. I mean, let's not delay it.
Hello.
Dr. Sudhir Tyagi, do we have permission to start?
Slide है ना जो मैंने change की थी.
Whose sounds is it? Omnicurious, can you log in?
ये वही वाली चलाई है मैंने तो.
Sudhir Dubey. Or Sudhir Dubey, can you share your screen? Sudhir, can you hear us?
Yeah, I can hear you, but the presentation he has to start.
Okay, so he has to upload. Just give him a time.
Or you can ask Dr. Rajendra Prasad to start and we
Just
can
a few
after
seconds, unless they surrender.
Yeah. Otherwise, it's better that we don't waste time.
So then I'll share my screen then.
Yeah, you start then.
Your slides are here.
Oh, yeah, his slides are here. Posterior approaches to cervical myelopathy. Can you mute the rest of the people and then let him start his presentation?
Cervical spine, which can be from front and from the back, anterior or posterior. The anterior approaches are arthroplasty, anterior cervical discectomy and fusion, or corpectomy. Anterior approaches are preferred when there's a short segment disease, more pressure from the ventral side, and absence of major deformity. Posterior options have increasingly been used. Initially, this history of cervical spine surgery started with laminectomy, but it used to cause a lot of deteriorations. So laminoplasty or laminectomy with fusion came into vogue. The posterior approach can attack the number of levels is increased, and also it causes better deformity corrections. This is a posterior approach where fixation is done, and these are the approaches of laminoplasty where you cut the bones in different ways. And then you can ensure that and increase the canal space with this technique. Cervical spine surgeries, if you look over the decades, started with posterior approaches, and they have reduced in the form of laminectomy use has decreased. This is prior laminectomy data which is there. Anteriorly increased, they peaked in around 2000, and slowly there is a clinical equipoise between posterior fixation, which is increasing, and deformity correction, which is increasing in the past decade. Posterior approaches are two. One is laminoplasty and second is laminectomy and fusion. Most studies will show that both procedures are very safe and effective. Laminoplasty is a short segment surgery, so it gives us better results in the terms of operative time, pain, as well as decrease blood loss. Laminectomy and fusion is much more extensive procedure, but it leads to better neurological outcomes, and also it leads to better canal diameter and better deformity correction. These are the studies which emphasize the role of laminectomy with fusion in the posterior approaches. And the most important things, if we compare both the things, will be the neurological outcomes, which will be better in laminectomy with fusion. Comparing them both, if you look at it, the cost of, because of fusion, they use a device, it becomes increased. Range of movement becomes less, but then the arthrodesis also becomes better. Adjacent segment involvement is more in laminectomy and fusion, but more because you are doing an extensive procedure, it fares better because you don't leave any amount of adjacent segments to deal with. Outcomes are better. Pain is slightly more in the immediate term, long term it is same. Deformity correction is more, less incidence of backaches and knee pains. And for more than 3 segments, laminectomy and fusion is the most important procedure which we use. Now, what has become, it is also reflected in my practice, that all cervical spine surgeries are becoming more of a deformity surgery. Importance of sagittal and coronal balances is very important in long-term pain-free quality of life indices for the patients. This is my experience of over 900 surgeries in the past 2 decades. And as you can see, the posterior approaches have been increasing over a period of time. Anterior approaches have slightly peaked and then they have fallen down. And deformity is gradually becoming more. So this is the graph which shows the laminectomy approach which was there, so which is quite less in number. Second is the anterior approaches which were quite in use and gradually have fallen down. Then this is the posterior fixation which has increased and then tend to taper off, but deformity, number of deformity cervical spine surgeries have gone on increasing. The concept was given by Rastomoli about the sagittal and the axial balances, which is important. Having a curved spine like this doesn't help anybody's purpose and causes long-term pains. The important thing is that you should have a straight line and you should be oriented in that straight line. And your plumb line should be at the C7 junction. The more the distance it becomes, the more deformed you become. One more concept was of chin-brow vertical axis. The chin-brow in some people, because of forward stoop, becomes really bad, and this you have to also make it from 0 degrees to 30 degrees for a person to be able to move and ambulate well. This is the C27 sagittal vertical axis. In this, you draw a line between the C2 vertebra and the center of the hip joint, and you see how much the difference is there. Even slope is also to be taken into consideration whenever you are doing these kinds of surgery. So what is the decision making in cervical spine surgery? I will take you through some cases and how you decide. The most important things are it's a flexible or fixed deformity. The pressure is from anterior, posterior, or circumference, and what happens to the global and the cervical balance. If it's a fixed deformity but no bony fusions have formed, you do an anterior release with grafting with or without posterior fusion. This case is an interesting case because of some old surgery. They had put some rods here, and now the patient developed neck pain and myelopathic features. So you can see absence of lordosis. Taking away this rod restores, when you have taken off the rod, it restores the lordosis, and an anterior procedure is ideal for this. This is also a straightforward anterior procedure where the disease is anterior to the cord. You just go and put a cage and a screw and this, and it will take care of it with very good results. Even such deformities, if they are soft, you can do a good job. Now, if there's a fixed deformity ankylosed anteriorly, and anterior osteotomy and grafting with posterior fixed instrumentation can be done. This is a patient where you had a deformity because of laminectomy done long back. Now you can see there was cord edema and cord compression over a period of time. In this, we approached anteriorly, we put expandable cage, and we were able to restore the balance. And he had good results and all his parameters became good. If you have a fixed deformity which is really tight posteriorly joined together, you do a posterior osteotomy, anterior release, and then posterior fixation. So this is a deformity which is like this. It is an old untreated fracture which formed a kind of a deformity which was C-shaped. In this, we could approach from both anterior and posterior and achieve a good lordosis for the patient. Similar case, C2 over C3 subluxation. It was a ankylosed because it was an old injury. It was ankylosed posteriorly. We did an osteotomy release and we fixated this procedure. Now, these patients who are fixed deformity and you have to do sometimes a circumferential fusion, and sometimes you can get away with a posterior fusion. So these are certain cases which failed and you had to do revision surgeries with further screws and plates. This is a patient which was done elsewhere, and you can see that the deformity is quite large, though they have put the screws, and there was persistent, there was some loosening of these screws, and there was persistent edema over the cord. In this, what we could do is we could release slightly anteriorly, give the space to the cord and fix it. Over a period of time, it formed a bone between the two joints, and patient had a good outcome. Now, if a deformity is ankylosed, means it is ossification has occurred all along, a pedicle subtraction osteotomy is done for this. So if you look at this, this is a great kyphosis. There is ankylosis on all the sides. So in this, what you do is you put all the screws from cervical spine to the thoracic spine and tend to reduce the lordosis. Now, fixed deformity, which is again ankylosed circumferentially, in this kind where there are small sections where you have a lot of ossifications and in between you have areas which are rarefied, you have to do a circumferential from both anterior and posterior fusions. Now, there are some flexible deformity in which you have 3-level compression. These can be done minimally invasive, and you don't need to really do anything except doing a decompression of the cord. In certain cases with this minimally invasive techniques, you can also put screws and the rod. Flexible deformity like this with the ventral compression, you will do a ventral approach and you will do a decompression and fixation with a cage and a plate. Similarly, this deformity at C3, where you have destruction because of tuberculosis, you can put a C2 to C4 screws. This is a cervicothoracic junction where you will modify your approach by going, opening the manubrium slightly and putting the screw and cage. Flexible deformity, which is...
Sorry, Sudhir, your time is up. You'll have to conclude.
Posterior decompression and fixation. So this is
I think you need to stop
deformity.
because
There was movement at the CV junction and bone formation. So you removed everything endonasally.
This is a recorded version. Can you stop it?
It's a recording talk, so we can stop
and you
it.
fix from top to bottom.
Omnicurus, please stop the presentation.
Again, a similar case where you did a posterior decompression and a fixation. Now, if there's a flexible deformity, you can do a combined anterior and posterior, as will be illustrated in
Are
this
you there? Are you listening?
neurofibroma, which has slowly increased from 1980s, has been operated multiple times, and had got a deformity at 2004, like.
Yeah, okay. Thank you, Sudhir. I'm so sorry because of the time constraint, it had to be stopped in between. Are you there with us?
Yeah, I'm there with you, sir. The
Yeah,
video has
okay.
been stopped from the main lobby, so I don't know.
Okay, fine. Now, no, it was stopped because of it has exceeded the time allotted. Any
No,
question?
video, my video, I cannot see you, but it's fine. Yeah.
All videos are, even my video is stopped. What is this timing coming from? Is it for discussion?
Answers, I think.
Hello?
Yeah.
Okay, any
This is for
question?
question and answers. Yeah.
So any question for Sudhir from the audience? Sudhir, you tried to show the slide of, revival of posterior approach than the anterior. My assessment actually has been, if we take collective data of orthopedicians as well as of neurosurgeons doing the fixations, more of orthopedics guys are toward posterior fusion and fixations methodologies than the neurosurgeons. Possibly that's more simpler to do than doing anteriorly and preserving the cords and the dura. What is your comment on that?
Sir, I have shared my slide of from beginning when I used to do the surgery. So my cases, which I'm doing anteriorly, also have fallen down because now I get more of long segment diseases, which are not at one segment, and they have a deformity which extends from top to bottom. So that's why for the past 2 years, my posterior approaches have become more than the anterior approaches. Previously, my anterior approaches were much more than the posterior approaches. The simplicity, if you are doing a deformity, the posterior becomes slightly more difficult than the anterior approach.
Okay, fair enough.
Okay, Daljit, both of you are right. When you said the orthopedic surgeons tend to do more posteriorly, you are right. They do very few patients anteriorly. And so that is where the decision making comes in. We as neurosurgeons, when we do both the anterior and posterior procedures regularly, we decide and choose which is the best for the patient. But orthopedic surgeons just tend to do more posteriorly.
Yeah, that is what I was trying to say. All the Sudhir cases were indicated more posteriorly because
as Sudhir said, I have also seen in my practice for last 6-7 years, the number of posterior procedures is kept on increasing. And as he rightly said, we see now a lot more long segment diseases. So where posterior approaches are definitely much more easier and beneficial to the patient than only doing anterior.
Okay. Thank you, Sudhir. Dr. Kale, are you there?
Yeah, I've just joined.
Okay,
can you
good
hear
morning.
me?
Yeah, I can hear you. Meanwhile, I'll invite the second speaker.
Please go ahead.
Sandeep, please, it's your turn, I suppose. You are already logged in. So it's talking about OPLL, Sandeep.
Okay. So can you see my screen?
Yes.
Yeah. Okay. So Sudhir has made my talk easy because practically whether you're talking about OPLL or cervical spondylotic myelopathy, the decision-making process is quite similar in many of these cases. So
your slide is of infection in the spine. Is it the
sorry,
same?
No. Just 1 second. Just give me 1 second.
So meanwhile, he does the correction. Kale, what is your view of posterior approaches while listening to this talk?
Yeah, actually, I missed the earlier part of Sudhir's talk. I just heard the last little bit.
Okay.
But yes, I think the fact that we are dealing more with multi-segment, it's always better to go posterior.
So let Sandeep come on OPLL, please.
Yeah.
So basically OPLL is...
Sorry, stopping you.
Yeah, it is a hyperostotic condition that results in calcification of the PLL. Incidence is highest in Asian populations and more in males. And so this is just a study where somebody did 112 patients natural progression of the disease, and they found that in 24% the length and in 13% the thickness of the OPLL increased over a period of time. But that didn't mean that everybody was symptomatic for this. So the earliest presentation is tingling, numbness, and when myelopathy is there, there will be gait disturbance and spasticity. There will be pain and limitation of neck movements. In late onset disease, bladder and bowel may be involved. And sometimes they present with acute spinal cord injury after a trivial trauma. So these are the type of OPLLs which Hirabayashi described. One is continuous, where you can see that it is continuous along the multiple segments. It is segmental behind the vertebral bodies. This is a mixed form, and this is a focal where it is only at the disc level. These are the radiological examples of continuous, segmental, mixed, and this is localized. You can see calcification at the local level of the disc. So X-ray is in neutral flexion and extension is a must to see the flexibility of the spine so that we can decide upon the procedure. And then CT of the cervical spine to look at the calcification, and then of course the MRI to look at the cord changes and the number of levels involved. Hida et al. Describes CT findings in two different CT findings. One is a double layer sign where there is an anterior and posterior rim of calcification, which is separated by a hypodense layer. And there's a single layer sign where there is a single layer of ossification. The importance is that in 50 to 70% patients with double layer sign, the dura would be involved. And once you remove that segment, then there will be a defect in the dura. While only 5 to 10% patient with single layer will have the same issue. So this is an example of a single layer. You see that there's a dense calcification here, while this is a double layer. So this indicates that this part of the calcification is involving the dura. And there's another thing which has been described as the occupancy ratio. It is the ratio of the normal spinal cord versus the whole diameter of the spinal canal. And more than 60% occupancy ratio will have higher chances of myelopathy. Another lines that have been described as a K line, which is drawn from mid C2 spinal canal to mid C7 spinal canal. And if the calcification is in front of this line, then it is K line positive, and in those patients, posterior approaches are more beneficial or can be easily done. While if it is posterior to that, then the anterior approaches are indicated. Similarly, effective lordosis is a similar kind of line which is drawn from C2 to C7 dorsocaudal aspect, and if the calcification is behind this line, in that case, anterior approaches are better. The MRI is a must to see the extent of calcification and cord compression. T2 images will show the cord changes. So management can be conservative or surgical. So those patients who are accidentally diagnosed with OPLN with no significant symptoms can be managed conservatively, or those patients with mild symptoms can be managed with muscle relaxant and gabapentin and neck exercises, etc. So this was a study which, these were two studies where they evaluated patients over a long term, and they found that in one of these studies that 30% patients would progress to myelopathy. And in the first study, they found that the patients who presented with myelopathy will continue to progress, while those patients who did not have any myelopathy at the time of presentation, very few are likely to progress. So preventive surgery in such patients is controversial because of the inherent risk of the surgery. Although some of such patients can, with significant stenosis, can develop severe acute neurological deficits in association with relatively minor cervical trauma. Oh, can everybody else keep their mic closed? So the primary indication of surgery with in these patients is progressive myelopathy, and patients presenting with spinal cord injury in the setting of trauma and OPLL are also surgical candidates. Surgery can be decided upon by the number of involved segments, degree of myelopathy, location of primary pathology, sagittal balance of the cervical spine, and more importantly, experience of the surgeon. It can be anterior, posterior, circumferential. So anterior versus posterior is a topic of perennial debate, though there are certain indications. And as Sudhir mentioned, that he also described where to do anterior or posterior. So these are simple cases where the compression is anterior. Short segment disease can be dealt easily with anterior. And again, this is a case where there is a compressive myelopathy at 3 levels, but the lordosis is maintained. So depending on the surgeon's experience, one can go both anterior or posterior. So anterior surgery where the occupancy ratio is 60% or more, where there is cervical kyphosis, or if the sharp OPLL shape is there, because those are associated with high chances of myelopathy or sudden injuries. It will be difficult to go anteriorly if both C2 and T1 levels are involved. And also it becomes difficult if more than 3 levels are involved. The problem associated with anterior surgery would be a higher risk of neurological injury as compared to posterior, higher risk of CSF leak, dysphagia and hoarseness, particularly in elder people, and implant subsidence, which may require a repeat procedure. Advantages are there is direct decompression of the pathology, there is better contraction of the kyphosis. So ACDF, corpectomy and fusion, floating corpectomy, oblique corpectomy, and ACAF, which has been proposed by Chinese people. These are the possible approaches. So ACDF is normally done for segmental OPLL, while most of the patients with continuous MUX OPLL will need corpectomy and fusion. So when OPLL is densely adherent to the dura, a variation is floating corpectomy, where you do most of the corpectomy and you disconnect the attached bone to the dura from all sides so that it does not compress. ACF is a very cumbersome procedure where you make gutters on both sides by doing osteotomies at all the vertebral body levels, and then with the plate you pull the complex forward. So there was this Chinese study which they had excellent results in 15 patients, but this is a very cumbersome procedure. Posterior surgery, either you can do a laminectomy, laminoplasty, laminectomy and lateral mass, and or facet joint fusion, as has been described by Dr. Atul Goyal, but there are no takers right now till there is more evidence for that. So I won't go in details because Sudhir has already talked about this. Laminectomy alone is rarely done because of further future deformity. But in those patients with dish where the anteriorly it is completely fused, one can simply do a laminectomy rather than putting in screws also. So again, there are various techniques of cervical laminoplasty. Posterior procedures by and large have a higher rate of post-operative C5 root syndrome. Circumferential surgery is indicated in patients where there is significant kyphosis and a long segment disease. So you do anterior surgery to correct the height and sagittal balance of the column, and then you do posterior decompression for the long segment disease. Occasionally, it can be an add-on procedure in a patient who has already been operated anteriorly or posteriorly before. In any patient having a 3-level corpectomy, a posterior fixation also is recommended because then it is potentially unstable spine. I'll just show you an example of a circumferential surgery. This patient already had a 2-level surgery anteriorly, but still had significant posterior compression. So we did a laminectomy and lateral mass fixation. Complications of these surgeries are cord injury, C5 root palsy, which is one of the commonest complications seen, CSF leak, dysphagia and hoarseness, sometimes hardware failure in form of implant subsidence, incomplete decompression leading to neurological sequelae, and rarely hematoma. So this was a patient that I had operated many years ago, and in a routine X-ray 6 months later, we found that there was subsidence of the implant. So we supplemented it with C3 to C7 fixation. There is another patient who you see he was operated elsewhere. You can see there is a multi-segment disease and there's a kyphotic spine. So surgeon went anteriorly, did a single-level corpectomy. Post-operative, the patient's quadriparesis worsened. And at that time, we had seen the patient. So we did, this is a post-operative scan. You can see there is some decompression there, but there are significant cord changes. And in axial cuts, you can still see there is a lot of compression. So we did a lateral mass fixation and patient did well. Again, this patient was actually a cabinet minister of a country. And so he had this C5-6 discectomy and fusion. It was done in England, and you can see at the level of the surgery itself, there is a huge osteophyte complex, so which was not removed. And the patient came on a wheelchair, was unable to walk for 2 years. So, and you can see there is significant compression at multiple levels. So we did a 2-level corpectomy and fusion. Again, this is an example of a patient who underwent a laminoplasty. But as you can see, what the surgeon did was he just cut the lamina and just fixed it in the same position, which is pretty unusual without raising the lamina. So the patient continued to have symptoms, and then later on we converted that into a laminectomy and lateral mass fixation. So to conclude, an initial trial with non-operative management should be attempted for all patients without myelopathy. Most of the patients with myelopathy will need one or the other surgical procedures to decompress the spinal cord, and surgery is by and large quite safe with relatively few complications. Most surgeons will choose the approach they are most comfortable with, and generally 1 to 3 levels are involved in anterior, and if more than 3 levels are involved, then posterior decompression is indicated. And whether laminectomy and fixation is done or the laminoplasty is done, in most of the meta-analysis, the results are more or less the same. So thank you.
Thank you, Sandeep, for finishing well in time. Paper is open for discussions or any comment. If none, Sandeep, what is your, I'll say, in the last 1 decade or maybe say 1.5 decade, 10 to 15 years, in what way your practice of OPLL has changed from what you used to do about 15 years ago with basic knowledge of when to do anterior and when to go posterior?
Yeah, so
I mean, does these lines and all those things which were not existing about a decade ago has made any significant change, or do we still take decision based upon the clinical observations and our skill?
See, frankly speaking, we don't actually put in these lines. You just go by your experience and you can just visually see how much kyphotic spine is there and how many segments are involved. One major difference has been there. I was seeing very few OPLLs before, like 15 years ago, I would hardly operate any OPLL, maybe not more than a month or 2 months a patient. Now I'm operating 5, 6 every month. Particularly all these patients coming from outside, I'm seeing a lot of OPLL. So, as I said, my practices are also evolved. Initially, I was doing more of laminoplasties, but I now personally prefer to do more of laminectomy and lateral mass fixation. Unless C2 or T1 are also involved. In those cases, I prefer to do a laminoplasty. And for short segment disease, of course, my choice is anterior procedures.
Fair enough. Kale, over to you for your comments and Kate taking it forward. Dr. Kale.
So, can you hear me now?
Yeah. Yes.
Yeah. Okay. So I think I would just like to make one small comment. A few years ago, we had done a study for AO spine, a really extensive study, and we had published a small booklet for this very problem, whether to go anterior or posterior. And if I remember, we had studied about 1,100 articles and did meta-analysis and this and that and everything. And I think in the end, what we found was that there are 2 or 3 guiding principles which hold true even today. One is kyphosis. If there is kyphosis, I think you need to go anterior. There is no confusion and there is no conflict in the surgeons in various parts of the world. They all agree that if there is kyphosis, you need to think about anterior approach. The second thing was the levels. 3 or more levels, it is safer to go posterior. Of course, the longer your anterior fusion is, the more the difficult the fusion is going to be. So again, there was unanimity in the approach that more than 3, you think about posterior. And the third was age. If the age is more than 75 years, almost everybody in the world thought of going posterior as a more safer operation. So I think to conclude, these 3 points would still be significant and relevant even today, even after different surgical techniques and better techniques have come, that if there is kyphosis, whether there is kyphosis or not, how many levels are involved and what is the age of the patient. So I think if we keep these 3 things in mind, we will still 9 times out of 10 do the right surgery for the right patient.
So that's exactly what I was trying to say. We still hold what the ground was about a decade ago, these cardinals. Dr. Prasad, any comment from you on this aspect?
No, I agree totally with Dr. Kale. I think, a lot, and I heard Dr. Dubey also, a lot of orthopedic surgeons look at alignment and deformity. Of course, kyphosis is important, but is deformity itself, I wanted to ask him, a reason to operate? Often when you go in for myelopathy, then deformity correction is important. But I look at the thoracolumbar spine and the time deformity correction and the way it's corrected, it seems like deformity correction. So does the same hold true for the cervical spine? I ask myself. I normally rarely presented with just deformity as a symptom requiring or sign requiring correction. But maybe that will change. In Dr. Dubey's practice, there's so much deformity, and we generally don't tend to see that as a presentation. Otherwise,
no, I don't think he meant that deformity correction is the indication for surgery. I think what he meant was that the approach depends upon the kind of deformity, and then of course when you are operating it, then you correct it.
Sudhir Tyagi wanted to say something.
I think I agree with Dr. Kale's principle of the surgery in the OPLL, and very nicely by Dr. Sandeep Vesh. But I think the surgery we have to design patient to patient. Every patient is different, and sometimes we try to follow the principle and doesn't work, and we have to go sometimes to the both the second anteriorly as well as the posteriorly. So I think patient to patient we have to make the design the surgery according to the.
Good. Now, Sandeep made another interesting observation that more and more cases of OPLL are coming these days. And that's true. Is it because they are getting picked up more because of the MRI being available in every corner of the country now? Or is there any change in the lifestyle or the pathophysiology in Indian subcontinent also? So what is the comment of the house on this?
I think they are just being picked up more.
You think it's more being picked up? Kale?
Yeah. So I think earlier minor symptoms used to get ignored. People used to not bother much about minor symptoms. But nowadays, the patients themselves are getting more aware. Okay. And the easy availability of MRI also contributes.
Fair enough. Thank you so much, folks. Let me invite, Kale, please go ahead.
No, please go ahead.
No, go ahead. It's your turn now. You have to invite Dr. Rajendra Prasad.
Okay. Thank you, Dr. Daljit. So may I now invite Dr. Rajendra Prasad, a very senior neurosurgeon from Delhi. And for the next 12 minutes, he is going to tell us about cervical spondylotic myelopathy and when to intervene. Over to you, Dr. Prasad.
Hi. Can you hear me and see my screen?
Sir.
Yes, sir.
Okay. So, there's so much said about anterior or posterior, and I thought I'm going to talk about when to intervene. And recently, I'm seeing a lot of patients where, they present with lumbar symptoms, lumbar radiculopathy, and you have an extensor plantar, and then you go and look at the cervical and routine. Present with lumbar symptoms when they present with myelopathy, or do you delay it later? And how late is late? And how late is too late? So that is my talk. So when you talk about timing of surgery, age is important. If it's an early age patient, a young patient with myelopathy, obviously you would operate early. In the elderly, very elderly, how elderly is elderly? And then comorbidities, how much? Everybody has diabetes, hypertension beyond an age. And does that come into a factor? And it does in deciding. Then the severity, mild, moderate, severe. How severe is the myelopathy? That may determine the timing of surgery. And I will discuss that. And for how long? Has it been less than 1 year or more than 1 year? That also has an impact on the timing of surgery and the result, and the rate at which myelopathy is progressing. So if you have a very rapid progression, like a fall causing a central cord syndrome, obviously that will be determining the timing of surgery. Now, MRI findings are important. Is it just edema that's reversible or cord atrophy? And will determine time of surgery, and history of trauma, as I mentioned, and the complexity of surgical approach and the surgeon's experience would also determine and should determine timing of surgery. So often it's a combination of all these. And then when you decide upon surgery, then obviously a little time needs to be worked up in the planning. And whether it's a soft disc or a hard disc and OPLL and the segments involved, and often in my own practice, and the obvious one acquired at 1 level, 2 levels, or is there a more generalized congenital? Like in this case, you can see by C6, there's a bit of narrowing, and then you say, okay, let's do anterior or should we do posterior? So a little bit of thought has to go into that. And then I mentioned signal changes. And then you have to decide anterior or posterior. And often in my own mind, sometimes there's oh, should I have done that or should I have done that? But I do tell the patient that if you don't get enough improvement after one procedure, you may need to have a second procedure posteriorly. And most of the time they don't come back, because if the choice is correct, they do get better. And it's important to do a JOA scale and a Neuric scoring, because post-operatively, there has to be something scientific to follow them up at 3 months, 6 months, 1 year, and beyond. And then you decide at 3 levels, whether you want to go anteriorly, like I did here, or at these 2 levels is just discectomy and undercutting enough with peak cage. Is that enough? Or is a corpectomy required? So a little bit of time in planning saves you doing 2 procedures, or with fixation, without fixation. Sandeep has already discussed that. Now, traumatic central cord syndromes is the commonest myelopathic syndrome, generally upper limb more than lower limb, and generally an injury precipitates that in a stenotic patient. Now, the problem of timing is that the patient has significant improvement most of the time between the injury and by the time they come to the neurosurgeon. And therefore, you have to decide the timing at that point. And you have to remember that many of them will functionally become independent and ambulate with control, whatever we do. Not all patients presenting require surgery. There is a selective bias for surgery of those patients who have plateaued. So, once they plateau, they say, chalo, let's get surgery done. Or after initial recovery hasn't been enough, they get referred. So there is a bit of bias. But the spinal trauma study group, they looked at the vast literature, risk, benefit, burden, and their early surgical decompression was recommended on low quality evidence. So surgery, if the initial impairment was significant or failed to develop rapid recovery, or there is significant cord compression. Those were for early surgical decompression. The group recommended non-surgery if the improvement was non-surgery, if the improvement was really good, or if there wasn't enough cord compression, like here, maybe recovery would have been spontaneous. Now, looking at the literature, most of the evidence is level 2 and level 3. And based on that, 2 level 1 study said there is no significant difference in outcome. Level 1 study, no significant early surgery or late surgery. Whereas level 2 and level 3, there were better outcomes with early surgical decompression in myelopathy. Now, this AO spine, Dr. Kale would be aware of this large study, North America AO spine study by Dr. Feelings on the efficacy and safety of cervical spondylitic myelopathy surgery. They had 278 patients, 1/3 mild, 1/3 moderate, 1/3 severe, and they were followed up for 1 year and showed significant improvement. There were 2 timelines. Those who had symptoms less than 4 months did better than over 4 months. And if they were followed longer, those who were less than 12 months symptomatic, they seemed to be better on all scores. So all disease categories, they all did improved by early surgery at less than 1 year. And the mortality was the same, morbidity was the same. Then another paper, cervical spondylitic complications after spinal fusion of 50,000 cases. We have to remember when we operate, mortality is less than 1%, but the complication in certain series is as high as 30%. But let's say on an average, when we consent our patients, we say, okay, 5% to 10%, but the series may be higher up in published series. Then just simple discectomy, a large series of 3938 patients of the American College of Surgeons, again, it says single level ACDF in the elderly patients, generally they had higher perioperative morbidity, and but the mortality was the same. One other paper, very good paper, which explains that when they looked at 76 patients, the power had improved, but the spasticity, because it hadn't improved, the patient was not happy with the functional outcome. So you have to tell them that your power may improve, but you may not walk normal for a long time. This is that level 1 study which showed at 3 years, no significant difference between early or late surgery. So what are the extra factors that you have to factor in? Some people rely on EMG, MRI I've mentioned, compression I've mentioned, comorbidities I've mentioned. Now, if you have SCP and EMG and MEP preserved, there are better outcomes. Whereas if you lose all of that, you have to first make sure you're like with that hand, is the diagnosis correct? Is something else going on? Or if you've lost your potential, you've lost the power of intraoperative monitoring. So that again, you have to think of early surgery. MRI, as I said, is it, we have found in papers that pre-op and in our own practice that pre-operatively, if there is a signal change with less neurological deficit, they do best. Whereas if the deficit is fixed, they don't do so well, whether you do early or do late. And patients with cord compression, obviously everybody would agree, early or late, the sooner done, the better. So various studies I've mentioned already. In my own practice, I looked at the records I had for 70 patients. Most of them came within a year. So now with early diagnosis, myelopathy is picked up, and they come with Neuric 1 and 2 generally. And symptoms may be for 2 days after trauma, or it can even be 10 years. But average, they tend to do better if they are early. So in conclusion, patients with a hyperintense cord signal, but without significant deficit, they have the best outcomes. Long-term myelopathy and fixed deficits have poor outcome. And only 40% of patients, as I said, less than half, will show improvement in their significant improvement in their spasticity. There is, when you're planning surgery, and especially there was this paper recently of sportsmen, and they had come and they were found to have cervical compression, but they were still active in sport. Do you let them get back to sport, or do you operate, remembering that there will be a 10% morbidity? So the main objective of surgical treatment is prevent deterioration. So when a patient asks me, will I get normal? I said, no, we are operating to stop you getting worse. Thank you.
Thank you very much. Thank you, Dr. Rajendra Prasad. Now this paper is open for discussion. Anybody in the audience or my colleagues in the chair, any questions, please go ahead.
I have a question. If somebody,
please.
No, let
please
me
go
first
ahead.
ask about the audience. Someone has a question, they have a priority. If not, then sir, very nice presentation. I just wanted to have your opinion on 2 things. One, you said that changes in MRI, cord changes in the MRI is associated with a better outcome with a neurological deficit. Okay, that was one of your paper, you cited it also, and that was one of your conclusion also. Presence of neurological deficit with the MRI changes results in a better outcome following the surgery. On the contrary, I mean, have you actually seen if a patient has improved and these MRI changes have reverted to normal in the follow-up? Have you actually followed up on those lines?
No, I had.
I can't hear.
Changes with severe myelopathy, they don't tend to be do very well. That is what I meant. And your second part, do they see a reversal? Actually not. I haven't seen a reversal of that. There has always been, as long as I've followed, and they generally, as you know, they come for 1 year, 2 years. there are still signal changes. So I haven't documented within 3 years follow-up disappearing changes. No.
Okay. Anybody else's opinion on that? Right. And the second thing was, you said about the spasticity in the pattern. My own observation is, this is the first of all the complaints which patients say, that the spasticity has improved following surgery, anterior approaches. Okay. Now, but this appears, I mean, that's we take it always, and it's a constant observation by us over the years that the spasticity is the first symptom to improve in patient after anterior approaches. So what's your take on that, sir?
No, I mean, these are the patients who post-op. I mean, I have one recently, a guy who's walking around, a 70-year-old walking around. He had paresis, and I said, "Listen, you're walking around, you're normal." He said, "Nahi, mera leg stiff hai, mera leg stiff hai." And
okay.
and these are the people who benefit from physio and lyoresal. So there will be that group of patients that, you know, we can't ignore their complaints. They're saying, "Hum chal rahe hain, par ye maza nahi aa raha, stiff hai leg." And I find that, yes, I think a little bit of lyoresal baclofen and a little bit of therapy does help. So it seems to rapidly improve, but not entirely completely to make all patients happy. As I said, more than 50% of them can be helped further with medication and exercise.
Sure. Kale.
Yeah, any other questions from the audience?
I just want to make a comment when we were discussing about anterior and posterior. So Ghogawala et al. Started conducting a study in 2014, and it is from 11 US centers, and they were going to recruit 250 patients and randomize. It's a very extensive randomization with opinion from 10 different spine surgeons whether to do anterior posterior. They are absolutely matched group of patients, and the result will be out in 2023 after a long-term follow-up. So I think that is going to be a very interesting point in anterior versus posterior debate. So,
yeah. Any other questions from the audience? Okay, none. So may I now go to the next speaker, Dr. Dalji?
No, the next speaker is Dr. Kb Shankar. He'll be talking about intramedullary tumors. Shankar. He was there.
Dr. Shankar, are you there?
Yeah, I'm there, sir.
Please share your slides.
So they have to be done by the by Omnicurus.
So Omnicurus, we are all very curious about his slides.
Hello.
Some problem with the control room?
Hello.
Sudhir, can you check with your team?
Yeah, I'm checking.
Yeah, please.
Omnicurus.
Akash, are you there?
Hello.
Akash, are you there?
Mr. Akash.
Akash. Hello.
Yeah, Akash, please share Dr. Kv Shankar's slides.
Okay, sir.
Kindly unmute me and start the video also. Mr. Akash? Mr. Akash?
Sir, just wait.
Yes, sir, please.
Yes, sir.
So while the slides get uploaded, it reminds me my MBBS days when I watched one of my orthopedic senior surgeon operating intramedullary tumor in our hospital. And I actually saw him, Kale, are you there? I actually saw him using finger enucleation of intramedullary tumors. Okay, so I was little, I thought maybe this is the right way of doing it. And that was during a 3rd and 4th year of our MBBS. So he opened, he showed this is dura, and he just made a mylotomy and put it finger, and tumor was actually out. So I really don't know whether it was intramedullary or it was actually a neurofibroma which he had taken out and showed us the tumor is out. So over the years, and that was somewhere about 83 or 84. So things have moved significantly from what it used to be on the spine, which was, and the patient became paraplegic after surgery as expected. So things have moved. So Shankar's slides are still not up. So that is all. I mean, things significantly, the advances.
Yeah, one thing, the last, I think Dr. Rajendra Prasad's talk, after that we had a question that what is the relation between the MRI changes and clinical improvement, right? Yeah. So I just remember one paper which we had published from AIMS.
Yes.
It was regarding this, the MRI changes before and after, comparing MRI changes before and after to the clinical improvement. But unfortunately, that was in CV junction problems. And I remember it got published in Neurosurgery or Journal of Neurosurgery somewhere. It also won an award. It also won an award as best paper somewhere. And this was in 2013. So quite some time ago, in which we had actually studied these changes and come to the conclusion that if it is just a T2 weighted image hyperintensity change, and there is not much change in T1 weighted images, then there is still hope. But if there is a T2 weighted hyperintense signal and a T1 weighted hypointense signal, and then there is definite cavitation, and then there is very little chance of improvement. So the red flag is T1 and T2 both. T1 is hypo and T2 is hyper. If that is the change before surgery, then you can expect that things are not going to improve much, or maybe none at all, no improvement at all. However, if it is just a T2 weighted image change intramedullary, what we now term as myelomalacia, but the T1 weighted image does not show a cavity, then there is a good chance that there might actually be improvement. And in such cases, early intervention may actually help. So what we had concluded was that if there is such a change, then you should intervene early and try and get your surgery done early.
Yes, I remember that paper very distinctly, and that's the reason I thought we continue as for the part of discussion, rather than sitting silently. Some discussion should keep on going.
Yeah.
Yes. So finally, he is up.
Finally, we have it. Okay.
Shankar, you can start now. The slides are there. You unmute yourself. Shankar, you have to unmute. Yeah.
Am I audible now?
Yes.
Yeah, sure. Thank you very much, sir. I start off with the anatomy of the spinal cord, located within the spinal canal, 42 to 45 centimeter in length and 1 centimeter wide in adults. Average weight of 30 grams, and there are two enlargements, one in the cervical and one in the lumbar region. It ends at the level of L1-2 displaced as the conus and continues as the filum terminal. Next slide. Now, studying the cross section, it consists of the gray matter surrounded by the white matter in an H-shaped fashion, and within it is the central canal. The pia matter of the spinal cord is thicker than that of the brain and is attached to the dura by dentate ligament. This is significant from surgical point of view also. And within the spinal cord runs the various ascending and descending tracts. Next slide. Akash. Yeah. Now coming to the blood supply of the spinal cord, the anterior spinal artery arises from the vertebral arteries in the upper cervical region.
The artery of Adam-Kivitz is located in the T9 to T12 region and is the main artery of the lumbar enlargement. The posterior blood supply is smaller, discontinuous arteries, and the territory, the anterior spinal artery actually supplies the anterior 2/3 of the cord, and the remaining posterior third is supplied by smaller dorsal vessels. Next slide. Now coming to the intramedullary tumors, see the chunk is formed by two main pathologies, the ependymomas and astrocytomas, and they make up the large chunk, making up near about 90% of the tumors. Apart from these, we have malignant glioblastomas, dermoid, epidermoid teratomas, hemangioblastomas, hemangiomas, neuromas, metastasis. Next. Then there are vascular lesions, the arteriovenous malformations, and infective lesions. These could be abscess, tuberculous granuloma, and hydatid disease. Next. Now coming to clinical presentations, pain is the predominant presentation that patients usually come to us with, making up 62.5% of the total patient population. Neurological deficits may be motor, sensory. Sphincter disturbances are also important. The other clinical presentations could be scoliosis or torticollis, depending on the level of the tumor, subarachnoid hemorrhage, a visible mass over the spine. Next. Coming to diagnostic studies, MRI is the mainstay of diagnosis, but when we come to pathologies which point towards vascular lesions like AVMs and hemangioblastomas, spinal angiography helps us in the diagnosing the lesion and planning for the treatment. Next. Now, most of these intramedullary tumors are benign and slow growing. They have variable growth rates and they rarely progress to anaplasma. And surgery is the primary treatment for the majority of such lesions. Next. Now, coming to the principles of surgery, actually, this is the topic that I have been assigned. Now, early detection is the mainstay in the era of MRI. Since MRI has come in, it's been, we see patients coming to us diagnosed at some other clinician with an MRI, and we have to correlate that with the clinical picture that the patient has. But then, all said and done, MRI is the mainstay. But one thing that we need to understand, this is what I normally tell my patients. See, over the years that I have been in this field, I have been changing my perception about intramedullary tumors. Initially, I used to be aggressive. But then one thing that I found out was it's very important to counsel the patient, because these, try to understand when a patient and a relative comes to us, they don't know what a tumor is. So telling them about the tumor in a better way will at least prepare them for what lies in store for them. So, and one thing we should understand is, see, if you do not make the patient better, at least try to keep him at the level that he has come to. That's very important. And that is what I usually tell my juniors and the colleagues that I have in my department. At least try to keep him at the level that he has after removal of the tumor. Another thing, post-op posterior deficits are expected, but these improve. Next. Early surgical intervention is recommended for good surgical outcomes. Next. Now, surgical approach depends on the anatomy of the cord and its vessels. Now, we usually go posteriorly. Now, this is because anterior approach is blocked by the anterior spinal artery. Posterior approach is not blocked by the arteries or veins, but then there is a problem. There is no open fissure on this side. So we open the median sulcus by separating its edges without damaging the dorsal columns and vessels. Next. One more thing before I move on, like Daljit sir had told about his experience in the early part of his career about some orthopedic surgeon fingering a intramedullary tumor. Now, it may sound very fashionable and maybe a few cases may get through, but the mainstay of treating intramedullary tumors is microsurgical decompression, going very slowly, understanding that it's a patient in front of you. You are not treating the tumor, you are treating a patient. So with all of these precautions, I think the success rate improves. Now I would be discussing the further slides under these headings. Positioning, exposure, the spinal cord and tumor axis, tumor cord interface. One thing is very important. The more the assistance, it's better for the patient. 3 hands are better than 2 for the suctioning, counter traction, for dissection, cautery, cutting and debulking, and internal decompression. And then monitoring has a definite role in treatment of intramedullary tumors. Next. Positioning is very important. The patient should be as flat as possible, parallel to the floor. And it is propounded that head immobilization should be done with a 3-pin head fixation for lesions above T6. Next. Incision, midline incision, it should be centered at the level of lesion, and it should extend preferably 1 level above and below the margins of the tumor. Next. As far as bone removal is concerned, sufficient access to the tumor should be done. It's better to have a bigger exposure, because what happens is sometimes when bleeding comes about, it becomes really messy. So some people going for keyhole surgeries, or there have been papers propounding endoscopic removal. But normally in my practice and in my department, this is what I tell my colleagues, that at least your exposure should be sufficient so that you don't mess up with the case. Whether it's laminectomy or laminotomy, it's the surgeon's preference. But most important, proper hemostasis should have been achieved before opening the dura, because sometimes what happens is if you go by this step, then as you approach the tumor and start with tumor removal, then all of this adds up. Next. Myelotomy, the dura is opened in the midline, extended cranially and caudally to expose the whole spinal cord enlargement. Care should be taken not to open the arachnoid. Now, one of the guides is there might be a subpile color change on the spinal cord, and as I said, there might be an enlargement which gives you an indication that the tumor is there. Now, how do you identify the dorsum lumen sulcus? Basically, you can identify in some cases by convergence of vessels towards the midline. In some, it is easily, but sometimes it's very difficult because of distortion of the tumor. In such cases, it can be evaluated in relation to the posterior roots on either side. Now, extend the surgical field along the entire length of the tumor. And as I had said, because the pia of the spinal cord is thick, you can use pile sutures to improve the surgical exposure and reduce trauma due to dissection. Next. Expose the portion of the tumor to obtain biopsy with forceps and scissors without coagulation. Preferably send for frozen biopsy if you have a facility. Reduce volume of tumor by CUSA. Tumor developed before looking for the dissection plane. Dissection is performed from inside to outside. Color is helpful in recognizing the tumor and the tumor interface. Final objective is tumor total removal, because most of these are low-grade tumors. And if there is an absence of plane, kindly be cautious, because it's better to not to go in for more deficits. You might, if you feel that there is no plane and you are not able to distinguish between the tumor and the cord, it's better to stop. After the tumor removal has been done, the dorsal columns are removed from pile fraction and reapproximated. Arachnoid reconstituted originally preserved. Watertight neural closure is a must, and bone placed back if laminotomy is performed. Next. Now, this is just to show whatever I have talked about. Next. the steps being shown pictorially, how the dura has been opened, how the tumor is removed. Sometimes, if you are lucky and the plane is good, you might do it in one go, but internal decompression is the standard. Next. Now, I included this type of AV malformation, even though it may not qualify to be a tumor, because these can be surgically extirpated. These are glomus malformations, high flow intramedullary lesions with multiple feeding vessels, less responsive to embolization. When feasible, resection is the mainstay of treatment. Initial steps of myelotomy similar, so they are circumscribed by interruption of arterial supply before the venous drainage. Approach from arterial side and cauterized with copious amount of saline. Sharp dissection is preferred over blunt, and closure is in the same fashion. Next. Next. Role of intraop electrophysiological monitoring, a few points, both SCP and MEP can be used. Pre-op analysis is helpful because you may end up with a legal case. They can also help in predicting the occurrence of post-op neurological deficits, and intraop changes can help you where to stop. Next. Next. Going back. Next. 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 Now, these are a few changes which help us to tell whether you should stop temporarily for a few minutes and then start off, because I see that my time's up. I'm just
please conclude.
And whether to stop or not. Next. Next, please. So these are a few cases in my department. A 30-year-old male who presented with deficits prior to surgery. And this is actually a video. I will not go because the time's up. But
can you conclude, Shankar? I mean, the time is over. Let's come to the last slide of his.
Yeah.
Please go to the last slide.
Yeah, sure. Next, please. Another case. Next. This was a child we had operated in our department, had a good recovery. Next. Now, just the take-home message. Medico-legal angle is a pitfall. Usually, the senior-most surgeon in the department should handle these tumors. High-end operative microscope and good equipments should be done. Neuromonitoring is an integral part of the surgery. And very important is proper pre-op consent. Kindly do this before any of these cases are taken up. Next. A surgeon exploring a spinal cord for a suspected intramedullary tumor must be prepared to face a formidable problem and also have courage of conviction to make every attempt to remove the tumor. Anything less than this, with a cursory inspection of the spinal cord, aspiration thereof can only create problems of a more complex nature for the subsequent surgical effort to remove such tumors. Next. A few differences. Next. Thank you, sir.
Dr. Kale.
Thank you very much, Dr. Shankar.
Thank you, sir.
Now this paper is open for the audience for any questions. Please go ahead.
Do you use any method of myelotomy closure?
Method of myelotomy? Sir, I couldn't get the question.
I asked, do you use any method for myelotomy closure? Do you close the cord after?
Yeah, basically what he means is that whether you close the arachnoid. Yeah, he mentioned that they close the arachnoid. I also do close the arachnoid, but that is a very controversial topic. So recently I was in an international meeting on intramedullary tumors, and I was surprised. Half the people were vehemently against closing the arachnoid for various reasons. So,
sir, we try to do it in every case, but we may not be successful. But in case we are able to do, we should try to do.
There is a question in the chat box. Do you rely upon the D wave on electrophysiological monitoring? If I read it correctly.
So we use electrophysiological monitoring in every case. We have an assistant.
Is that true for all
who helps us during the surgery? So we use it in every case, sir.
Okay.
No, he specifically asked whether you use D wave or not.
Sir, usually it is the technician who directs us that there is a dip or it's a temporary or a permanent dip. That is how we stop or.
Okay. Right. Sachin
Okay.
Borkar had asked. Sachin, what is your own opinion on that? D-wave electrophysiological monitoring. What's your call on that? You asked this question.
Yeah, so actually, sir, I think D-wave is more reliable to predict long-term deficit. So MEPs can be transiently deranged, especially in intramedullary surgery. But if the D-wave is intact, then you can progress with the surgery. And if the D-wave is gone, then I think then we should stop. So MEP have a problem that it can transiently get deteriorated, but D-wave usually predicts long-term integrity of the corticospinal tract. So we usually use the D-wave.
So it says dare not, huh? The D is dare not. Dr. Kale, over to you.
Yeah. Any other questions, anybody?
So I have a question. Can you hear me, please? This is
open go ahead.
This is open for the forum as well.
1 minute. Identify yourself.
Sir,
And then go ahead.
I'm Dr. Sunit Medirata. I'm a consultant neurosurgeon at the Apollo Hospital. My observation was that a statement was made by the gentleman saying that these intramedullary tumors should be operated by only the senior most faculty in the institutes. Now, just my question is that being practiced everywhere in all institutes, that only the senior most faculty or the most experienced person operates on intramedullary tumors? Your thoughts on this, sir?
Is that directed to me or to my seniors and colleagues?
Sir, generally to all senior faculty members on the panel. Is that being followed at your institute, sir?
In my institute, generally the assistant professors or the people who have just joined in are not given these cases. But then, see, when I said senior most, I didn't just mean the senior most in the department. Now that will put the whole burden on the head of the department or the senior most faculty. But what I meant was at least the person should be comfortable. No, I think my senior teachers would be better to answer this question.
Okay, who wants to take it first?
I think you should
always take it first. But let's see. Let the senior most, Dr. Rajendra Prasad, try to answer. Let us come from those ends. Sir, are you there?
How can one be senior and experienced if one isn't taken through this in training?
Okay.
And I think in the latter part, obviously you don't start in neurosurgery with doing this. When you're comfortable to that stage at the latter part of training, that's how I was given that. And then you become senior and progressively, so each department would have its own policy of who is competent enough and done enough years and to be able to do that. And there's some in the department that even after 5 years, Dr. Tyagi and myself and Sunit don't feel comfortable to let them loose. So, and there are others who are. So you have to go through that system and be comfortable. It's not about how many years you've spent, it's how much time you've spent in actually, anyway, in apprenticeship.
Sandeep,
for the senior,
your call.
Obviously.
I think anybody who's capable enough should be doing it. It's everybody has to decide it for himself. It is, see, there are two separate.
No, his question was like he's pointed out whether Shankar said the senior most person. So possibly he was trying to address that means senior most takes the cake. He doesn't want the junior. There are a number of other places aneurysms are not even given to the second in command or third in command. So that's a very valid question he's asking.
I know. So that's where there will be a disparity between the private hospitals and the government hospitals. So what he meant was only the government hospitals. In private hospitals, whatever comes to you, you operate by and large, right? Mm-hmm. So there is no question of senior or junior there.
Okay.
If you're talking about the government hospitals, yes, I do agree to a certain extent that the person, it is ultimately dependent on the seniors. Like, for example, when I was at AIMS, Dr. Mehta was our unit chief and he would allow a person to do kind of surgery what he was capable of. If a person is capable of doing it, whether he's junior or senior, it doesn't really matter. But one should not harm the patient just to learn on him.
Exactly.
Okay, Kale?
Yeah, absolutely. It depends upon the individual capability. I mean, we in our departments, neurosurgery department in AIMS is quite big. We have 25 faculty. So there are at least 10 people who can very nicely do an intramedullary tumor. At least 10, probably more. But then everybody doesn't get a chance here because of different reasons. So it depends upon your individual capacity, your individual capability, and your skill. If you are skilled enough, yes, why not?
Sudhir Tyagi.
Yeah, I agree with Dr. Kale and Dr. Sandeep. I think it depends on the individual capability, and I can vouch for Sumit Mendiratta, he can do it.
So that was the question. That was the question.
So Sunit, do you get the answer, or you want some more?
Thank you so much, sir. One last question, if may allow me time be allowed. If you do not have a scenario wherein you've been able to remove completely the intramedullary tumor, do you advocate doing a duroplasty or still want to do a primary closure?
Sir, most of the time in such a case, we go in for primary closure. But it also depends on the bulge. See, if the dura can be approximated without tension, go in for a primary closure. But there are certain cases where sometimes what happens is, while removing the tumor, certain vessels, if sacrificed, a bulge comes about, there is edema. In such cases, you go in for duroplasty.
So the answer is very clear. You must try to close the dura. The aim is to prevent the adhesions of non-closed dura with the underlying muscle. It will be a very intense adhesions. And if you want to revisit for some reasons of a recurrence of a tumor, you will be in a hell. Okay. So try to close the dura as much as possible. Even if it is technically difficult, try some maneuvers. Either you use membrane or use some biological tissue to close it. I mean, I'll always prefer it should be closed in all circumstances.
No, I agree. I agree, sir. It must be closed. My only question was, if you leave a residual tumor, would you do a facial graft and do a duroplasty, or you still want to do a primary closure?
Sunit, I will take that question. So in most of the intramedullary tumors, even if in those rare patients where you are not able to remove it completely, still you have removed enough that you can close the dura comfortably.
Sure.
The only lesions where I put in a facial graft and do a duroplasty electively is intramedullary lipomas, because those are the tumors which are very bulky and which may progress over a period of time. So those are the patients where I do a duroplasty.
Okay, I think, how are we for time? Is there enough time?
Much over time.
Much over time.
No, that has to be told by the library.
Yeah, we already exceed the time.
22 minutes over time.
Yeah.
Then I think we should bring this to an end. Or if, I think Shankar was the last speaker, right?
Yes. Yes.
Okay. Okay. So with the permission of the organizers, can we bring this session to an end?
Yeah, please.
Okay. So thank you very much, Dr. Daljit, co-chairman. Thank you to all the speakers.
Thank you, sir.
Dr. Sandeep Vash, Dr. Rajendra Prasad, Dr. Sudhir Dubey, Dr. Shankar.
Thank you.
And enthusiastic questions, I must say, even of small presence online, but they were good discussion. So thank you very much, everybody. And thank you, Dr. Tyagi, for having us here and having this nice session. Thank you.
Thank you very much.
Thank you.
Okay, bye-bye.
Bye-bye.
So we'll be moving to the next session of neurosurgery, that is on the pituitary tumors. Somehow Dr. Kj Chaudhary is not able to join because of some personal reason. The chairperson for this session will be Dr. S.K. Sugani, Dr. Satnam Singh, and Dr. Sachin Borkar. Dr. Satnam Singh is a very well-known name in the endoscopic surgery for the pituitary tumors and the spines, and heading the unit in the Gangaram Hospital. And Dr. Sachin Borkar is a faculty in Indian Institute of Medical Sciences. And Dr. S.K. Sugani, who is a very well-known, one of the oldest private person in the private practice, and renowned neurosurgeon, Dr. S.K. Chaudhary is right now with Apollo Hospital, New Delhi. So I ask the chairpersons to take over from here. We have only one lecture in this session, and next will be the special session. Maybe Dr. Satnam Singh is here. Yeah, please, sir.
Yeah, good morning, everyone. So let's start with the session on pituitary tumors. The first speaker is Dr. Sumit Mendiratta. May I invite Dr. Sumit to speak on management of microadenomas, pituitary microadenoma. Dr. Sumit, please.
Thank you. Sir, am I audible? Can you hear me?
Yeah, we can hear you and see you.
May I request the omnicurious people to share my slides, please? So, good morning, respected chairpersons, senior members of the fraternity, colleagues and friends. I'm going to share with you our experience of having treated pituitary microadenomas over the last 2 years at Apollo Hospital. These are the patients who were managed surgically, and it's going to be a review of 5 cases who were operated at our institute for the last 2 years. Next slide, please. So in all, there were 5 patients who were operated. There were 3 females and 2 males, and they were all within the age group of 25 to 45 years of age, and they were all operated within the last 2-year period. Next slide, please. They were all functional adenomas, and most of these, there were 3 of them were growth hormone secreting. There was 1 patient who had a ACTH secreting tumor, and 1 presented with a prolactin secreting tumor as a prolactinoma. Next slide, please. Next slide, please. So the clinical presentation in the patients who presented with growth hormone secreting tumor was basically with acromegalic features. They presented with thickening of lips, nose, palms, digits, and toes. And the females complained of the rings not fitting into the digits. That's how they presented. And the ACTH secreting tumor presented with weight gain, easy bruising of skin, ecchymosis, and uncontrolled diabetes. They presented to the endocrine colleagues initially before they were referred to us. And the lady who presented with prolactinoma, she had profuse galactorrhea and amenorrhea over the period of 2 years. And the galactorrhea was so profuse that she was complaining of, the undergarments getting wet and requiring frequent change in a 24-hour period. And she had been put on cabergoline. The tumor was resistant to cabergoline over a period of 1 year after she had been on this medication. And none of these patients had any visual issues. Next slide, please. Next, please. So this is one of our patients. The gentleman on the right is the son who is a patient, and this gentleman is the father. He's a tall 6'2" gentleman. You can see thickened nose and frontal bossing with thickened palms and digits. Next slide, please. Next slide, please. No, go to previous slide. You jumped 1 slide. Previous, please. This is another lady presented with acromegalic features, thickened lips and nose, broadened feet, and the toes thickened. Next slide, please. You can see the thickened toes here and broadened feet. So they were all investigated with normal hormone profile was evaluated. They underwent serum cortisol, prolactin, T3, T4, TSH evaluation. And for the acromegalic features, they all underwent growth hormone and IGF levels evaluated. And the lady presented with galactorrhea amenorrhea also had FSH, LH levels checked. And prior to, I'll get to these dexamethasone suppression tests later on. And all patients underwent MRI contrast studies with dynamics. There's some background noise. You can just next slide, please. So the patient presented with acromegalic features. The growth hormone levels on patient 1 was 10.5 nanograms per ml when the normal range was 0 to 4. Patient 2 presented with 40 nanograms and patient 3 was evaluated with IGF levels, wherein the levels were 844 nanograms compared to a normal range of 60 to 220. Next, please. So the patient who presented with prolactinoma, the serum prolactin levels were 160, and the patient who presented with Cushing's disease, the serum cortisol level at 8 a.m. in the morning was 42 mcg per deciliter, normal being 7 to 25. This patient actually was initially presented to the endocrine colleagues who were evaluating her for uncontrolled diabetes, and they did a low-dose dexamethasone suppression test where it showed that there was failure to suppress the serum cortisol levels. And thereafter, once a diagnosis of ACTH secreting tumor was made, we did a high dose dexamethasone suppression test to make sure that the source of ACTH was a pituitary adenoma and not an ectopic source. So when we did a high dose dexamethasone suppression test, the cortisol levels reduced by 50% of the baseline. That's how we confirm that because it reduced by 50% of the baseline value, we confirm that the ACTH source is pituitary and not an ectopic source. Next slide, please. Next, please. Come back to this later. Next, please. So this is the dynamic scan of a pituitary microadenoma. You can see as the contrast is injected, the normal gland picks up the contrast initially, and the adenoma remains hypointense relative to the normal gland. And as the scan progresses further, you can see later on the later images, the gland also starts picking up the contrast. This is how we differentiate a microadenoma on a dynamic scan. So another slide, wherein the T1, T2 shows almost an isointense homogeneous structure wherein you can't really see a tumor. When you see a dynamic scan, you can see a relatively hypointense area which is well defined compared to the normal gland. This is how a dynamic scan helps us identify a microadenoma. And also, it is important to figure out where the septum in the sphenoid sinus is, because this really helps you identify the location of the tumor intraoperatively, and this really guides you in your surgery. So a significant note should be made of the septum if present and see its relation to the microadenoma. Next, please. Here another slide wherein T1, T2, you really don't see any significant lesion, but on a dynamic contrast study, you see a well-defined lesion, which is the microadenoma here, sitting right on top of the sphenoid septum, again a guiding source for intraoperative identification of the lesion. Next slide, please. Next, please. So I'm going to start a video of, next slide. When you see the video, please. Previous slide. Yeah, when I have the video. So this is a small short video of for 50 seconds, wherein this is a, can you play the video, please? No, we haven't played the video. Akash, can you hear me? Can you play the video, please? Previous slide. Can you play the video, please?
सर इसमें वीडियो प्ले नहीं हो रहा.
Which are not usual in terms of migraine prophylactic drugs. But I was just trying to highlight that we have.
Yeah, so this is now the video. This is an acromegalic patient. They normally have a more vascularity, kind of bleeds a little bit more than normal tumors. This is the sphenoid transnasal transsphenoidal approach. The Hardy speculum is in place. We're trying to remove the keel here. Now the sphenoid mucosa can be seen. Acromegalic patients normally have a little bit more oozing than the normal other patient. So we entered this sphenoid mucosa, that's going to be removed now. And thereafter, we nibble the cellular floor is being nibbled now. You can see the dura here. This is the cellular floor. That's the dura. And the incision is made based on where the sphenoid septum was to identify the tumor. In two cases where there were no septum was seen, we had to use intra neuronavigation. And you can see now the dura has been opened, and with the curette it comes out really nicely and soft, and lobulated chunk will come out. So that's how it comes out. It's yellowish, soft, and it's really different in feel from the normal tumor. So this is a post-operative scan. You can see the tumor here, pre-operative. This is the post-op. You can see the complete excision of the tumor, and also you can also appreciate the fact that the pituitary stalk has shifted ipsilaterally to the side of the tumor after the tumor has been resected. Next slide, please. So post-operatively, all patients in their course were symptomatically much better. 2 patients received post-op radiotherapy. These were the growth hormone secreting tumors, because the growth hormone levels did not come down to normal levels. And one lady received injection octreotide 30 milligrams once every 4 weeks for 6 doses, because she continued to have some joint aches and pain, and hormone levels, growth hormone levels were still on the higher side. The lady with the prolactinoma, the galactoria improved within 24 hours remarkably, and the prolactin levels dropped to less than 14 compared to a previous level of 160. This was within 24 hours. And the Cushing is in the Cushing's patient, the serum cortisol normalized within 1 week of the surgery, and the diabetes was controlled well. Next slide, please. So these are the levels of the growth hormones of the patients evaluated at 6 months post-operative. Patient 1, the growth hormone dropped from 10.5 to 5.4. Patient 2 has just recently been operated 2 months back, so we don't have a 6-month follow-up. And patient 3 was the lady who received injection octreotide. Even then, her IGF level continues to be on the higher side, presently 320, but the normal range is 60 to 220. But her symptoms are much better now. So she was earlier complaining of her rings not fitting into her digits and the fingers being thickened, or which now doesn't have that complaint, and she feels the digits and toes have become normalized. Next slide, please. So in our experience, post-surgery, the functional tumors which have secreting prolactin and ACTH, they show a dramatic and remarkable response, and the symptoms recover very quickly. And even before they can be discharged, the patient can feel clinical symptoms are much better. And the growth hormone secreting tumors have the ones who are generally required radiation post-operatively, and also growth hormone inhibitory factors like octreotide, because we figured out that the growth hormone secreting tumors are a little bit more resistant, and the hormone levels do not drop down as dramatically as patients who secrete prolactin and ACTH. And this has been our experience over the last 2 years. Next slide, please. Thank you, sir. That's about it.
Thank you, Dr. Sumit. Any question or comment from the audience?
Yeah, Dr. Sumit, I have a question.
Yes, please.
What is your protocol for post-operative cortisol/GH or IGF level in such cases? When do you get it done, and when do you declare that the patient is cured?
So the protocol for growth hormone level evaluation is, once the patient has been operated, we follow up after 2 months to check the growth hormone levels if the patient is symptomatically improving, and then follow up the patient gradually, because if in our patient the growth hormone levels haven't been dropped to normal levels at follow-up, so we've had to give them radiation, and post radiation also we've had one patient who required octreotide injection, and they are being followed up on a monthly basis. If the symptoms subside, 2 patients who did not complain of any fresh symptoms and showed symptomatically better, we did not follow up with further growth hormone levels. Only one patient who had joint aches and pains, who still was symptomatic, we continued to follow up with growth hormone levels and advised injection octreotide. The patient with prolactin and ACTH secreting tumors, like I said, the level dropped down dramatically. The prolactin dropped within 48 hours, it dropped from 160 to 14. So that, and the patient improved even symptomatically. Her breast discharge completely subsided from having to change her undergarments at least 6 to 8 times a day. She was not changing even once in 24 hours. So that was the dramatic improvement in her breast discharge. Now, once the prolactin levels have dropped down, we do not need to follow up with serial prolactin levels to be examined. The ACTH tumor also, since the ACTH level dropped down and diabetes was controlled, after the first 2 months, we have not evaluated for hormone levels. The endocrine colleagues who follow up for the endocrine dysfunction have basically been following up these patients, and they've realized that if the serum cortisol levels are normal, they don't even require post-op hormone replacement. So as a protocol, we do not give hormone replacement if post-surgery, the T3, T4, TSH, serum cortisol, the level are normal. We do not put them on supplements. So basically, for first 1 week, they give supplements. Thereafter, it is stopped, and the serum cortisol and T3, T4, TSH are normal. We stop all hormone replacement therapy.
Dr. Sumit, I have one comment. I do see many cases of prolactinoma, pituitary tumors, but I've never seen such a situation that a prolactin level of 160 not responding to cabergoline and patient is symptomatic, so symptomatic. And this is the first time I'm listening. I don't know. What is the comment?
Sir, there is sufficient literature to provide evidence that there are certain group of patients who are resistant to both cabergoline and dopaminergic bromocriptine drugs, and this patient was on cabergoline for 1 year under the treatment of an endocrinologist, and after having tried for 1 year, he figured out that it's probably resistant to cabergoline. That is why it was referred to us.
What was the level before the cabergoline was started? What was the level of prolactin? Maybe it was very high.
No, sir. It was never very high. It remained between 160 to 180. It never dropped below 150.
And you have discontinued cabergoline after surgery?
Yes, sir. Completely. Within 48 hours, the hormone level dropped to 16, less than 14, sir, from 160. So that's a remarkable thing. And clinically, also the patient who was having repeated.
Oh, Sudhir, you were saying something?
Recently, I had a patient. Usual phenomena is we operate these patients and we hand over it to the endocrinologist and we follow it with the MRI, the dynamic MRI, and the hormonal profile, depending on the deciding by the endocrinologist. And accordingly, we decide if the patient is responding to the treatment, no need to do the radiation. If the patient is not responding to the cabergoline, then only we go for the radiation. Recently, I got a patient who had above 15,000 prolactin level. After the surgery, it dropped down to about 300 and was further dropping with the cabergoline. But after some time, it stopped going down and the tumor was existing, and rather after 6 months or so, tumor started showing some increase in the size in the next MRI. So we decided to give the radiation, though the optic nerve was free, but we were worried that definitely if it's going up now and not responding to the cabergoline, better to do the radiation.
That is okay. Yeah, levels are very high, 15,000, and there, of course, it is okay. Dr. Sanjay Bopar, do you want to add something, say something?
Yeah, Dr. Sunit, if on a GH microadenoma you find that the levels hasn't dropped in significantly, would you consider imaging the patient again and consider re-surgery rather than subjecting the patient to osteopathy? Because as you know, it's a costly treatment and obviously the results of surgery are far better. It may happen that a part of the tumor is left and you may be, will you like to go in again and take that out? Because functional tumors are not very good. Yeah.
So functional tumors, in growth hormone secreting tumors, it is well established in literature that the hormone levels to normalize may take up to 2 years, even after radiation. As long as the patient is not symptomatic, just going by the growth hormone levels, it is not an indication to go in again and do another surgery. Because anyways, you're not trying to debulk the tumor. You have already got a histopathological diagnosis. The hormone levels have dropped down compared to pre-operative levels. It doesn't make sense to go in again and remove the tumor if the radiation can take care of it.
Okay. Thank you, Dr. Sumit.
Thank you, sir.
Dr. Sachin, can you please invite the next speaker?
I think Dr. Kj Chaudhary is not there, and this will be only talk in this session.
Okay,
so,
okay.
With the permission of the Dr. Tyagi and Dr. Ranjan, we can close this. Thank you all the audience who have joined this. And thank you, Dr. Sapna, for co-chairing this session along with. Thank you very much.
Thank you.
A very good afternoon to all of you. Our next session is a special session on deep brain stimulation. Our chairpersons are Dr. P.N. Ranjan sir, Senior Consultant Neurosurgery Department, Apollo Hospital. Next chairperson are Dr. Sudhir Kumar Tyagi sir, Senior Consultant in Neurosurgery Department. Now I am requesting to our chairperson to take charge and proceed.
This special session on DBS, our speaker is the renowned Dr. Guru Prasad Hasarkar, who has a large experience on the DBS therapy. I invite Dr. Guru Prasad, kindly go ahead and start your.
Thank you, chairpersons. Am I audible?
Yes, yes, very much.
Yeah. At the outset, I would like to thank organizers of DNACON-2022 for inviting me for giving this lecture. I'll start by sharing my slides. So are my slides visible, sir?
Yes.
Okay. So here are my disclosures. I, along with my neurosurgical colleague, Dr. Raghuram, have rich experience using various DBS systems, starting from Medtronics, both active, initially Kinetra, then Activa PC and RC. The Boston Scientific one, Versailles, the initial Versailles, and then the Versailles GV, the recent directional lead. And we also use few cases, we use St. Jude's Abbott Infinity directional leads. And we also used Sindre systems for a few of our patients. Our experience has been predominantly in ST and DBS. So my talk will mainly focus on ST and DBS in Parkinson's disease. I want to disclose that I've received assistance in making this talk from Boston Scientific, scientific material and educational material. Previously, I've received honorarium for educational course and proctorship. We run DBS Connect last 1 year during this pandemic, and proctorship free from both Boston Scientific and Medtronics. Regarding this talk, I have no financial disclosure to make. So what do you have to say about the current standing of deep brain stimulation at what we stand now? It's been effective and approved therapy for Parkinson's disease. We have a complete approval from FDA for Parkinson's disease. We have humanitarian approval for dystonia. Essential tremor has been approved. Various studies have shown long-term effectiveness, 5 years, 10 years. The efficacy of deep brain stimulation in Parkinson's disease and essential tremor has been seen, and we ourselves have 10 years of experience, and a lot of centers in India have almost 20 years of experience, and everyone vouches for its efficacy. But there are challenges. The disease progresses, so we all understand that it's not a cure. Unlike in dystonia, DBS is not a cure for Parkinson's disease. The disease progresses. We have a lot of challenges, whether it is cognitive, motor, loss of efficacy, axial symptoms. I think a lot of limitations are there what DBS can do, but still, when it comes to certain clinical phenotypes, the quality of life improvement seen post DBS is really unbelievable, and we really look forward to offer this therapy for a lot of patients who have advanced Parkinson's disease. We are also looking at extended indications like epilepsy, pain, obsessive compulsive disorders. There are certain indications who are under investigations like addictions. Some of the centers in China are closely looking at alcohol addiction. Some of the centers have done a couple of cases in India as well. Depression is one thing. And then we are looking at different targets for these indications as well. Alzheimer's, some of the studies have not completely shown benefits, but yeah, the studies on clinical trials are on, and coming to Tourette's and anorexia as well. So looking at the time, then as we have famous saying that Rome was not built in a single day, a lot of background research, technological advancement happened before we had the clinical approval for DBS, starting from Spiegel and colleagues who developed the stereotactic frame in 1940s. And then next, we have significant improvements in the cardiac pacemakers. So that made a difference to the DBS therapy as such. Then we have some of the inventions in terms of wireless, devices which can be controlled externally. And in 1970s, DBS was mainly used for treatment of pain, and The external DBS was used with handheld radio frequency transmitter in the 1970s. In 1980s, the fully internalized DBS system were made available with the lithium batteries extending the battery life. And the major breakthrough came from Grenoble, France, where Professor Benabet reported successful treatment of tremors with the DBS. That actually ushered in a modern era of the DBS. And since then, we have seen so much of technical advances in DBS therapy. And we have been witnessed since my neurology days in in 2001, 2004, we have seen dual channel IPG, that the Solitra, and then came the Canetra, the Medtronics one, and then we have the newer devices coming from various other companies, and the competition is growing. So the leads also have undergone significant amount of technological advancement, and it has become much more safer now for the therapy as such. And we have the closed loop responsive DBS system coming up. It's still not been approved. There are some clinical trials showing good results. Now we have the Percept PC, which is now available in India from Medtronics, which senses the thing and gives us the local field potentials. And we have one more scope of programming according to the discharges. So, but my focus of this talk will be on the MICC and the directional lead, which has been made available by the Boston Scientific. So what is the need for new DBS technology? Basically, for any technology, there should be, the scope of safety and efficacy has to be continuous, and it's never stop. So the essential of any kind of DBS technology is that you need to constantly research to improve the safety and efficacy. In this, the location, as we understand, STN nucleus and the GPA nucleus is very small. We need to improve the stimulation, the scope of stimulation, the area of stimulation, and that needs to be regularly studied and looked at. And also important is the patient is an awake surgery. We need to know, we need to make sure that the duration of surgery is minimal. And nowadays, we also know that there are centers which the patients are undergoing, sleep DBS under the guidance of MRI, MRI guided, stereotactic frames using, MRI compatible frames and all. And also the need for new technologies to ease the precision of trajectory planning. We understand that the outcomes of surgery is mainly dependent on the accurate placement of the lead, and slight deviation, either the angle or the depth of the lead may give unwanted results. And you also want to make the post-op programming much more easier, user-friendly for both the clinician and the patient family. And as we look at different indications, as I mentioned earlier, for different targets and indications, the lead and the stimulation per se has to be done according to the different targets and all. Because we understand in epilepsy, for example, we're targeting anterior thalamus. We had a few cases done for that. You enter the ventricle. So we use the same lead what we used for Parkinson's disease, but in future, we may have a different lead for different indications. So because if the nucleus is too small, then you don't need 4 contacts like we generally use for STN targeting. So the technology has to give us that type of solutions going forward. And good thing is we have multiple players in DBS now. We have at least 4 or 5 companies, and each one will compete to get the new technology getting in. And that becomes a selling thing for them and for us also to adopt the new technology and in showcasing it to our patients and then make them available to them. So what are the challenges of DBS? As I mentioned, GPI and STN, which are the standard target for Parkinson's disease, are very small structures. Very small error of 2.5 degrees is enough for the trajectory to miss the target. And there can be errors in various things. It's a very highly hardware-driven surgery. The precision in each step is very important. Be it pre-surgical planning, the working out the coordinates, the copying the coordinates. Recently, we had a patient where everything was fine. We have planned it well, and just taking the copying the coordinates from the planner to the sheet, we made a small mistake, And that again, for us, it took at least an hour or two to rectify it. So every step is important, as we all know who do this type of procedures. So there can be errors in various steps, whether it is radiology imaging, static registration, anatomical factors, and all. So the technological advance should make sure that there are no ifs and buts during the planning and the surgical steps. At least few contacts of the 4 contact DBS electrode is expected to be within the target for better results. And we know that there are important structures adjacent to STN which can cause side effects, be it capsule, be it thalamus, be it within STN itself. There are limbic areas in STN, very ventral, and that can cause psychiatric side effects. So the targeting should be very precise, and we make sure that we get a good outcome post-op. So this is the traditional lead what we used to 4 contact thing, and then the Versailles Boston the World generation 8 contact lead. But the newer ones will come to that in more detail. So what is the traditional DBS system? The ring mode, 360 degrees stimulation around. The traditional DBS had only single source battery. That means all the contacts used to be driven or stimulated using a single source battery, and that had its own limitation. We come to that, and it is mostly voltage limited, I think, voltage control. So the current can depending on the impedance resistance, the current used to be spread, and we couldn't control the stimulation area very well when you have a single source battery. And with traditional DBS or ring mode stimulation, cannot get away from side effect. If we reduce the stimulation area, you may not get therapy. You may not get the off scores down, and at the same time, when you increase the current, you will get with the side effect. So the threshold used to be very difficult to manage with the 360 degree stimulation. And you have a limited frequency and pulse width options. The traditional ones, we couldn't reduce the pulse width. Some of the things like gait and speech, you want to reduce the side effects. We couldn't do that because there is a limit which you can come down. The pulse width especially, you can't come below 60. But the newer ones give that option of reducing the pulse width, especially the MICC one. And as we all know during our physics days, that the current follows the path of least resistance. So when the impedance changes across different electrodes, no matter how you regulate the current, it will follow the least resistance pathway, and that leads to side effects. So what are the new technologies in DBS happening? As I said, the battery technology has improved. The size of the battery has come down very to a very smaller thing, and we are looking at where the battery size will be too small and it can be implanted in the skull. That will come in near future. Stimulation methods, various waveforms. We'll talk about the MICC in more depth. We have the option of using lesser pulse widths, differential frequency for right and left. Earlier, we used to have only standard frequency, but now we can use different frequencies for different sites, and even vertical, when you're doing vertical steering, we can use different frequencies. And the limit is gone beyond 240, 250 now. Various programming technologies have improved now. We have automated algorithms on computerized models created by the patient imaging using MRI and DTI imaging, and you can look at the stimulation area, what we call volume of targeted activation. We can see that on the programmer, and we can using that along with the clinical assessments, we can steer the current accordingly. And we has now all tablet-based programming platforms, which has become very visibly appealing. Even the patient programmers have developed over the years, and we can use it. Different groups can be used for different activities of daily living. For example, the gait requires less frequency, less pulse width and all. We can program in such a way that they can use different groups for different activities. So that has also helped us in managing such patients. And all these now devices have now taken FDA approvals for MRI compatibility, because all these patients are elderly. They may require imaging for various reasons. They require MRI compatibility, and then most of them are all MRI compatible now. The new leads, the directional leads, the recording LC of the sensors have come up now. We'll focus now on MICC and directional lead mainly. So when you talk about constant voltage, you can understand from this picture is that the current delivered is equal to voltage by resistance. So when you have the ratios are equal, then the current delivery will be equal. Whereas when you have a increase in resistance, the current delivered will be less. Same thing happens if the resistance comes down. the current delivery will be more, which is not desirable. Whereas in a constant current type of the batteries, you have a constant current irrespective of the resistance. So the voltage is varied, whereas the current is delivered equally, so that the tissue damage doesn't happen and it is consistent. So when you talk about constant current, there is a minimal changes in the voltage distribution irrespective of the resistance offered from the tissue around the lead. It eliminates the effects of progressive decrease in impedance. That means increase in the volume of tissue activation. That means stabler control of symptoms and less adverse effects. Various studies recently have shown that constant current is not inferior to constant voltage in various studies. Talking about the Versailles IPGs, which the Boston offers now with multiple independent current control, they have dedicated power sources for each contact. It's not single source, it's multiple independent current control sources, which is designed to accurately target and precisely control stimulation independent of changes in impedance. So I'll just show you one video. So you can control the percentage of each thing. So we can do vertical steering using this Versailles technology where you have MICC. So that's the advantage of MICC. So you can alter the percentage of each contact, current delivery to each contact, and like for 60-40 or 75-25, and so that you can create a different waveform of the stimulation area. We also have interleaving, which is offered by Medtronic. So what is the difference between interleaving with MICC and current steering with MICC? Whereas interleaving is like simultaneously in between the pulses, two pulses, there is one more pulse. For example, we have seen that some patients after 2 years, 3 years of DBS therapy, the efficacy of the stimulation goes down. The on period is not as effective as it was done earlier. So we want to increase the stimulation. And so what we do usually is then the Medtronic's Activa or Activa PC or RC is use interleaving. It is also available in Boston Scientific. Then we use interleaving where you give one more pulse in between the pulses. That sometimes we have seen that increasing the thing either right or left, we can use it twice. Definitely there is a battery drain because the interleaving, because you are giving two pulses almost simultaneously, one after the other. But the difference with that is that interleaving with single source systems to generate some stimulation field options with alternating current. It is different than, I'll show you on a video. Current steering with MICC allows precise control of each and every contact, so that amplitude specifier for each electrode is the actual stimulation delivered. How it is different, I'll just concentrate on this video.
Deep brain stimulation can
Just
treat movement disorders, but approaches to treatment where the contacts can be configured with different amplitudes and pulse
So
widths.
this is one side of stimulation, and in between there are a few more
the two settings in an interleaved manner. Note the region of overlap between the two stimulation fields may receive double the rate of stimulation.
So this is one type of pulsation, and there is another pulsation in between the things. That's interleaving.
Precisely controlled.
But you will have this overlapping area, which can cause sometimes tissue damage and can lead to
However,
side effects.
Interleaving is not the same as current steering with multiple independent current control and
Yes.
every contact. So the amplitude specified for each electrode is the actual stimulation delivered. No other DBS system has this precision and accuracy. Therefore, each contact powered by the Versailles DBS system can be used to generate millions of unique fields, each area or setting having different amplitudes, pulse widths, rates, and contact configurations, which are not possible with interleaving.
You can see the different waveforms.
In addition,
the percentage of less
Versailles
here,
system can use current steering to refine the field
and you can do interleaving with
and
MICC as well.
interleave the fields if clinically desired.
But there's no overlap.
Some
You can
power
see that
source
there's no
systems
overlap happening. So that's the advantage of using a MICC thing.
The Versailles system.
And was it proven? What is so there was a study done in simulation at Valencia, the Boston Scientific Center in US, and what they have shown is accuracy of energy efficiency of two steering paradigms in directional deep brain stimulation. What they've shown is that when they used interleaving with multi-stim set interleaving MSS versus MICC, they measured the volumes of tissue activated. When they compared both, what they have shown is that the intersection VTS accounted for 26% of interleaving MSS VTS and were exposed to higher stimulation frequency. What they concluded in this study is that MICC achieves a significantly better stimulation field steering accuracy and has a significantly higher energy efficiency than interleaving MSS type of stimulation. What it means that the steering accuracy is good and there is no overlap, because that can cause tissue damage and cause side effects at a later stage when you are using for chronic stimulation. I'll just show you one example before going for directional lead. This is one of our patients we operated 4 or 5 years back. This gentleman was from Iraq. I'll just fast forward his thing. Tremor predominant Parkinson disease, nothing very unique. He had tremors in both hands. He had slowness in walking, quite advanced. He had 5 levodopas per day with some of the dope agonist. C is walking. This is pre-DBS. So this is the off period. And this is him post DBS. This is why within 1 week, usually we give a gap of 1 week or 10 days to overcome microlesion effect. But if you can see that the right hand is slightly going into very early part of the stimulation, so he started having a little bit of posturing on the left hand. And when it came into multiple sessions, that the contract of the left hand became more and more as we increased the amplitude. This is his lead placement post-op. You can see that the right thing is little lateral. And if I play the video, so slightly light, maybe 1 millimeter little lateral as per the planned trajectory. So we had to reposition the lead. After the reposition of the lead, this looks like. So now it's accurate. And this is him after repositioning. It's been, we did it within the first few weeks. 3 weeks within the first surgery, we repositioned the lead. Now there's no much of thing. There's little tremors, so we adjusted the frequency and thing. So the threshold improved and he did well. And that was almost now 4 years prior now. So he's doing well. So what I wanted to say, that slight deviation of the trajectory itself can lead to this type of side effects. That's where the directional lead comes in. We didn't have that access to the directional lead at that stage, and they were also short of funds, so we had to go for the traditional one. So now coming to the directional lead, what it does is that the advantage of directionality is that the middle through contacts are segmented and we can steer the current. So we in this patient we probably would have steered the current away from the lateral and anterior aspect, and we would have steered the current towards more medial and posterior. We could have had we could have gotten away without repositioning. That's just a speculation. I'm just telling that could be a possibility. So let's look at this video.
Boston Scientific is proud to introduce the Vercise Cartesia directional lead, powered by the Vercise PC DBS platform with multiple independent current control MIC-1331.
So the middle two is labeled as
and a robust multi-lumen lead construction,
2, 3, 4,
and precise targeting.
and 5, 6, 7.
The directional lead design is only part of the solution to greater
The
precision
lowermost
and
and
fewer
the
side
uppermost
effects.
will be ring electrode.
It is what powers the lead that truly differentiates outcomes. Let's explore what happens in single source versus multiple source systems.
Just fast forward the
Tract
video.
has its own power source. This allows for precise control of the size and shape of stimulation at each electrode, steering current to the desired therapeutic target while avoiding side effects regions. Leads that are powered by conventional single-source IPGs are also vulnerable to impedance changes based on their environment. When current is allocated to 3 adjacent electrodes for standard ring stimulation, in the presence of varying impedances, current will follow the path of least resistance, resulting in unintended or inadequate stimulation. Ring stimulation may not be achievable. Unlike single-source systems, the Vercise Cartesia directional lead is powered by a multiple-source IPG, where each and every contact has its own power source, allowing for precise control of stimulation at each contact, so that what is specified is the actual stimulation delivered and maintained. Ring mode stimulation is achievable. Furthermore, when powered by the Vercise PC-DBS with MICC, the Vercise Cartesia directional lead can be used to generate seamless unique fields along the lead and around the lead. This high.
So what is the value of the directional system? As I mentioned, there are very important structures around the STN. We have a capsule, both anterior and lateral. If you are too ventral, then you can get psychiatric side effects within the STN. If you are more posterior, then you may stimulate medial lemniscus, can cause more sensory symptoms. And if it is too medial, then you can have visual symptoms in the form of diplopia or ataxia. So it has to be very precise. And by the nature of the directional lead, by steering the horizontally the current, you will be able to avoid if you are slightly even if you are placed accurately, sometimes you have a poor threshold because of the various factors, because of the resistance, because of the impedance. You can have a very low threshold, and you may not be able to get the desired result, and actually also causing adverse side effects. So you can have this type of advantage when you have a directional thing. So this is how it is divided. So the middle two are segmented, 3 segments. It's labeled as 2, 3, 4, and 5, 6, 7. And then there's a marker which usually when we place the lead, when the neurosurgeon, functional neurosurgeon puts the lead, this marker is shown anteriorly, and this corresponds to the fifth on the upper second contact and second. So these are the contacts which are aligned with this marker, and usually placed anterior. Just quickly go over thing. So how do you rotate? So every time you do a rotation, it will increase the increment by 10%, the current horizontally. And speaking about rotational steering in quadrants, one way to quickly identify the best direction circumference is to divide the cross section of the leads into 4 quadrants. Even though you have that marker, sometimes you have to go clinical. You'll have to check all 3 quadrants segments and see which is giving less side effects and which has a better threshold. So you just give an example comparing the single source IPG versus multiple independent current source.
You'll have to wind up, please. We are running short of time.
Sure, sir. A few more slides, sir. So when you have multiple independent sources, you can steer the current away from the side effect area and then give the benefit. So when you know that it's the same amount of steering causes both, then you can steer away by using multiple sources, independent sources, and getting the percentage divided, and you can achieve a good benefit area and then leaving out the side effects. So these are the couple of the articles where they studied in 2016 how the directional leads, the initial 35 patients where they studied in Germany, where they showed that it may be a little difficult to place the directional lead using the fluoroscopy, but over the time the experience has been that it's not so difficult as compared to a traditional lead. And the same group from Europe, Germany, and other centers in Europe showed that they have a registry now versus DBS registry. They have done almost like 283 patients were enrolled with the implantation of directional lead, and they have concluded that enabling fractionation of current using MICC can permit application of well-defined shaped electrical field, and definitely that offers an advantage in terms of reducing the side effects. Just our patients, I think there's one patient we recently operated, and we used Vercise GVA directional lead, where we have done the vertical steering for both. This is the left side STN, and this is the right side ST. And you can see that we have not used any segments. We used complete segmental. So what I mean to say is you don't need to do always horizontal steering. If you're getting a good result, then you don't need to do that. So we did a vertical steering so that we made this type of vertical steering and had a best benefit. And this is the patient within 1 month of thing doing well. His tremors are less, doing well. Has come for a couple of follow-ups and doing well. I'll just quickly wind up my talk. Another patient, Mr. P, who was operated in March, had a lot of difficulty. We had to do a lot of multiple sessions of programming. For the left side, it was okay because this is the right STN stimulation. We used ring electrode, the topmost contact, which was fine. No issues for the right side. Upper limb and lower limb, but for the left side, he was for the right upper limb, he was getting tonic posturing as we increase the current. So we had to steer. You can see that we are using much more. We are leaving away the lateral part of the stimulation. We're only doing the medial thing. So we steered. We used the second, that is contact 2, 3, and 4, and 3 we are not stimulating. Only 2 and 4 we are stimulating, and it's giving good results. And now he's very stable. So the StimView simple advanced programmer gives us that much options now, and we can capture the clinical effects on that, and we can also use the same directional lead in tremor thing. And what they have shown that when after a chronic stimulation in essential tremor, people develop side effects like dysarthria and ataxia that can be minimized using directional leads in the long run. So speaking about the overall thing, what MICC offers is that its current steering facilities individualized programming, control the stimulation delivery, its independence of any impedance changes, directionality offers a more optimum programming without losing the traditional ring mode options. And the advanced intuitive clinical programmer gives that much more options and visual thing about the stimulation area. So summarizing the attraction of the new technology is that it gives us sophisticated shaping and sculpting of the stimulation and the software for computational modeling, that is the closed loop thing. And it is all useful for when you are targeting multiple sites, both STN or zona incerta or thalamus and STN sometimes, and you can use useful for avoiding side effects. But challenges are that you need to be constantly updated with the changing technology. You need to relearn everything. It's sometimes leads to lengthy surgery and programming sessions, and the worst part is it sometimes reduces the physician and patient interface. So I need to acknowledge my neurosurgeon, Dr. Raghuram. This last year's Parkinson Day celebration we gave an interview, and it speaks about the social distance and the times we live in. And I also want to acknowledge my colleagues in Department of Neurology and Neurosurgery of Manipal Hospital, Yeshwanthpur, the team of psychiatrists, neuropsychologists, because it's a whole team effort which gives you the best outcomes. Thank you.
Thank you very much. Thank you very much for the beautiful presentation. Thank you very much for the beautiful presentation. Are there any questions? We can just take one question, please, because we are already short of time. If there are no questions, please. Thank you very much for the excellent talk.
Thank you, sir. Thank you, sir.
Thanks a lot.
Thank you, sir.
We all will be joining in a hall A for Dr. S.P. Agarwal oration. Please join in hall A, and we will reconnect after at 2 p.m. So wait.
Yes, Rahul. Yes.
Can you just put the slide?
Yes, Rahul. We'll just.
Yeah. We will be joining in hall A for Dr. S.P. Agarwal oration.
Rahul, now we are projecting hall A out in hall B and C.
देखता हूँ। लाया डांट लाया।
વાત કરું છું આઈએ કાલ कितना है
रोटी नहीं खाती बोल।
रोटी नहीं खाती री
गलाई में निंदा जोरा ने।
हैं अच्छा निम्मल साबर खातो लगी ya ketika aku
metabolite gets deposited. The diagnosis was confirmed here by the enzyme analysis and gene testing. And after starting the definitive treatment of enzyme replacement, the pain episodes were nearly nil. So this sort of emphasizes the need for genetic diagnosis and targeted treatments as well. So here again, I've just highlighted the list of disorders that amongst the neuromuscular group, which are highly genetic, almost all of the hereditary spastic paraplegias, the spinal muscular atrophies, a lot of amyotropic lateral sclerosis now in the familial cases particularly are getting diagnosed to be having genetic etiology. And metabolic myopathies definitely, which are the potentially treatable forms. Thank you very much.
So thank you, Divya, for giving us a glimpse of variety of cases and highlighting the important point which one needs to remember while using such techniques. So maybe we can have one question because we're already running behind the schedule.
Just one comment, Dr. Divya, very well spoken about use of genetic studies, and Dr. Devender. I agree that the topic was quite big and covering in 12 minutes is quite difficult. So maybe in next kind of versions in next year or so, we can plan some full session on genetic studies in epilepsy specifically and other neurological diseases.
So one message I would like to give, that just doing an ordinary biopsy, muscle biopsy, is no use unless either you do the antibody staining or you know the fluorescence or something, because only it will tell you that there is muscle atrophy. So it doesn't give you anything. What is the type? So just doing muscle biopsy, the age is gone. You have to either do the immunostaining or you have to do the antibody staining. Is it dystrophin? Is it calpain? Is it sarcoglycan? Whatever. So I think this is one message I would like, because I see a lot of neurologists do a biopsy in DMD and all that they come back is muscle is atrophic. But that I knew even without putting the knife. Okay.
Okay. Thank you. Thank you all the chairpersons and all the speakers for this informative talk. And for the next session, which is a common session of Dr. SP Agarwal oration session, I, along with Dr. Sudhir Kumar Tyagi, who is a senior consultant neurosurgery in Post-Apollo Hospital, is likely to welcome Padma Shri Dr. V.S. Mehta as a chairperson for chairing this session. Over to Dr. V.S. Mehta, sir. Dr. V.S. Mehta, sir, please unmute your mic. I will introduce Dr. V.S. Mehta. Good afternoon, sir.
Good afternoon.
Over to you, sir.
Good afternoon, sir. So, this oration is a very important oration. As you all know, that Dr. SP Agarwal and I were together in MCH. So, let me ask Dr. Anshul Rohatgi to introduce Dr. SP Agarwal's oration. Dr. Anshul.
Dr. Anshul, sir. Please unmute you, sir.
Doctor, you are not audible.
Yes. Hello. Yes, sir. You are audible, sir. Anshul, sir, you are audible.
No, I can't listen to him. Hello.
Anshul, sir, you are not audible.
Hello. Hello.
Maybe Dr. Anshul's mic is not working, or there is some connectivity problem.
Doctor, can you log out and log in again?
Am I audible now?
Yes, sir. Yes.
Okay, I think there was some. Sorry for the. Just give me a second. I'll just relaunch the PowerPoint. Is my screen visible?
No, sir, your screen is not visible. You have to share.
Yeah, I'll do that. I'll share it. Is it visible now?
Yes, sir.
Okay.
Sir, do it in the slide.
Yeah, I'm doing it. I'm doing that only. So good afternoon, everybody. Sorry for the technical glitch. So we are all welcome to Professor S.P. Agarwal oration. Dr. Agarwal was born in Nakodar, Punjab on 21st October 1945. His family moved to Delhi in the early 50s. He completed his schooling from DAV School, Chitragupt Road, New Delhi. He did his MBBS in 1968 and thereafter MS General Surgery in 1972 from Maulana Azad Medical College and subsequently in MCH Neurosurgery in 1980 from AIIMS. He got a WHO fellowship in neurosurgery in 1984 from Mass General Hospital, Boston. His Inventions Award was given by National Research Development Corporation or CSSR-IR for developing multipurpose self-retaining new brain retractors in 1992 and modified trephines in 1987. He received a gold medal for inventing modified trephines at the International Exhibition for Inventions held in West Germany, where about 250 inventions from more than 40 countries were exhibited in the INA 1987. He helped the revised National TB Control Program, the DOTS program in 1997, the National Health Policy in 2002, the National Rural Health Mission in 2005. He had delivered more than 20 named orations and had authored about 5 books. He had 32 research publications and 28 chapters in textbooks. He had fellowship of 7 national academies. And his major appointments included, he headed the Department of Neurosurgery at the RML Hospital from 1981 to 1996. He was a medical superintendent of the same hospital from 1992 to 1996, Director General Health Services from 1996 to 2005, and Secretary General of the Indian Red Cross Society from 2005 to 2015. And of course, he was instrumental in institution building. He set up the Department of Neurosurgery at RML Hospital and the Subsing Hospital in New Delhi, chaired the Postgraduate Institute of Medical Education and Research at RML Hospital. He started the PGDM course in disaster management at Indian Red Cross Society. His major awards and recognitions include a Padma Bhushan by the Government of India in 2007, the BC Roy National Award for Eminent Medical Person in 2002, a degree of science by the Punjab University in 2007, the Henry Dunant Medical Medal for the highest honor conferred by the International Red Cross and Red Crescent Movement in 2006. So that was all about Dr. Agarwal, and we are all honored to be present in his oration today. Thank you.
Thank you, Anshul, for introducing Dr. S.P. Agarwal's oration. Now, I may add here something more what he has added, that he was right from the beginning was interested in neurosurgery. So when he was working as a general surgeon in the RML hospital, he used to come regularly for attending the seminars in the All India Institute. And later he became a MCH candidate and we both were together. And once he has passed the MCH and became the director health services, he was always eager to uplift the neuroscience in the country. And I must add here that at the AIIMS, when I was heading the department or chief of the center, I had a lot of help from him to obtain the lot of major equipments like gamma knife, intraoperative MRI, and a lot of faculty posts, and all because of his help when he was the governing body member at the All India Institute. So may I now request Dr. Sumit to introduce the orator, Dr. VP Singh.
Well, good morning. Thank you, sir. With your permission, can I share my screen?
Yes, please.
Can you hear me and see the slides?
Yes.
Okay. Good morning, everyone. I am Dr. Sumit Sinha, and I have the pleasure of introducing today's orator, Dr. Varinder Pal Singh, who will be delivering Dr. S.P. Agarwal oration, the prestigious Dr. S.P. Agarwal oration for the 24th annual conference of Delhi Neurological Association meeting to be held yesterday, which was held yesterday and to be held today itself. So Dr. Varinder Pal Singh, who is popularly known as Dr. VP Singh and affectionately known as VP by his seniors and colleagues, it is an extreme pleasure and immense opportunity to introduce you to the audience. And Dr. VP Singh did his MBBS from All India Institute of Medical Sciences in New Delhi in 1982. And after this, he joined the direct 5 years MCH course in neurosurgery from All India Institute of Medical Sciences, New Delhi in 1987. And after that, he joined as faculty in King George Medical College and Hospital, Lucknow. And from there, he further had training in cerebrovascular surgery and gamma knife radiosurgery in UK, Newcastle General Hospital, Newcastle upon Tyne, and Royal Hampshire Hospital, Sheffield. After this academic career, he had series of illustrious appointments, with the first being appointed in 1993 as faculty of Department of Neurosurgery at the Cardio Neuro Center, All India Institute of Medical Sciences, New Delhi, where he worked till he was promoted as additional professor of neurosurgery and unit head in neurosurgery at the Department of Neurosurgery, All India Institute of Medical Sciences. After this stint here at AIIMS, he went out for more greener pastures. And in 2002, he was there, joined as senior consultant at Wimhens Hospital, then Wimhens Hospital in New Delhi, and started a new department there and set up the Department of Neurosurgery along with Professor A.K. Banerjee there. And there he worked till 2007 when he joined Indraprasth Apollo Hospital as a senior consultant neurosurgeon and academic coordinator there, and worked there till 2018 when he joined the Medanta Institute of Neurosciences in Gurgaon in January 2018. Currently, he is the chairman of neurosurgery at Medanta Institute of Neurosciences in Gurgaon. He has a special interest in brain tumor surgery, aneurysm surgery, and pediatric neurosurgery, and he is considered to be a pioneer in the field of epilepsy surgery and gamma knife radiosurgery. Not to forget, he started these fields at the All India Institute of Medical Sciences and in the country. He is the CME convener of Neurological Society of India from 2012 to 2014. He has been the editor of Journal of Pediatric Neurosurgery from 2009 to 2015. He has been the president of Indian Society of Stereotactic and Functional Neurosurgery and Cerebrovascular Society of India, secretary of Neurological Society of India, and president-elect of Indian Society for Pediatric Neurosurgery. And currently, he is the president of Neurological Society of India. And here he is in his younger days. Well, he is still young, and looking forward to, in this photograph, to achieve more and more illustrious dimensions, which he has done and he is still doing now. And he's a family man. He's been blessed with a wonderful family. His son is settled in United States of America and a beautiful daughter. And ladies and gentlemen, I present before you Dr. VP Singh, who will be delivering the prestigious Dr. S.P. Agarwal oration today, and his topic is epilepsy surgery. Dr. VP Singh, please. I'm just going to share my screen.
Dr. Mehta, my friends, colleagues, the members of the DNAEC, thank you for this honor of giving me the SP Agarwal oration. Dr. Agarwal was very well known to us. He was a senior, a mentor, and he was very helpful whenever anybody needed him. And it's a pleasure and an honor to be offered to do this oration of his, which goes in his name. Thank you, Sumit, for your kind words. I didn't start the department at Vimhans. Vimhans was well established by Dr. Banerjee. I only joined him and worked with him at Vimhans and Apollo. Right. So the topic of my oration is epilepsy surgery, a challenging journey. How we did it, what problems we faced, and how we went ahead. I came across this beautiful quotation about the challenges of life. Smooth roads never make good drivers. Smooth seas never make good sailors. Clear skies never make good pilots. Problem and hassle-free life never makes a strong person. We have to be strong enough to accept the challenges of life. And when something wrong happens, don't ask life, why me, which is what most of us do. Instead say, try me. So coming to epilepsy surgery, this is surgery done for control of intractable, medically intractable, long-standing chronic epilepsy. An AVM of a tumor who comes with one episode of seizure, and surgery for that is not epilepsy surgery. Now, trepanation of the skull has been known since prehistoric times, 3,400, 500 BC. We've found the Peru, in ancient Peru, we got skulls with trepanations in them. Why they were done, we don't know. It was believed in medieval times that epilepsy is related to evil spirits which are trapped inside the head. Possibly trepanation was done to release these evil spirits. In the late 19th century, Victor Horsley and McEwen did surgeries for epilepsy, the brain tumor presenting with epilepsy at that time. At that time, the localization was only cerebral localization based on the function of the affected. Then the EEG came into vogue. Berger described the EEG, and Penfield and Jasper in the 50s took up epilepsy surgery with EEG localization. But even this wasn't accurate enough, and this epilepsy surgery fell into disrepute. This was especially because good anti-epileptics, the phenytoin, was discovered, and that was used. In the 80s, again, there's been a resurgence of epilepsy surgery, and this time it is here to stay. This is mainly because of the better localization of the epileptic focus, the better surgical techniques, and better understanding of the causes of intractable epilepsy. So this is just an illustration of trepanation being done to release the evil spirits and to try to cure the epilepsy. Coming to India, Jacob Chandy and Mathai started doing epilepsy surgery in Vellore in the 50s. They were soon joined by Dr. Ramamurthy and Dr. P.N. Tandon. And then again, for reasons mentioned, this went into was not taken up. And in March 1995, Sri Chitra Institute in Trivandrum did their first case. And a month later, we started our first case at AIMS. So this is where my this study is based on. So what were the challenges we encountered? The first was the initiation, the challenges in the pre-surgical evaluation, and challenges in the surgical issues. These were the type of problems that we faced, and I'll cover them one by one. I joined AIMS as a faculty in December 1993, and very soon after, my mentor, Professor Banerjee, asked me to start epilepsy surgery at AIMS. And at that time, quite frankly, I had no idea what to do. So the department had bought a portable EEG machine, and I was sent to UCLA to learn how to do epilepsy surgery, and this was in November 1994. When I went there, I was a total novice. I did not know anything, but I went to Jerome P. Tengle, who was a neurologist. He was not a neurosurgeon, but he had a passion to develop and promote epilepsy surgery. So my aim was to learn which patients to operate, how to select the patients, who would be a good surgical candidate for epilepsy surgery. And on the side, I also went to the OR to see Itzhak Fried, who was the neurosurgeon, operate on a few of these cases. My total training period was a grand 3 weeks to learn how to do this. And when I came back, I was very depressed. I did not feel competent to start. The reason was what I had seen in UCLA. They were doing these tests for epileptic excitability, EEGs, video EEGs, Icton specs, good quality MR scans. They had PET, they had SPECT, a detailed neuropsychological evaluation, and they were doing the WADA test. So there was an extensive pre-surgical evaluation which was required to get this program going. And these modalities were not available in our hospital. So the dilemma in my mind was, are we justified in starting? It was an ethical dilemma. But then we looked at the figures. At that time, India's population was 1 billion, and there were an estimated 0.5 to 1 million new cases of epilepsy every year. And it's known that 10 to 20% of these cases would be intractable. They would not respond to medicines. So we had a 1 to 2 lakh population of intractable epileptics being added every year. And of these, even if 20% came for surgery, we had 20,000 to 40,000 new patients who could benefit from epilepsy every year. And this was in addition to the existing large number of patients already present. So what really made the difference was this concept of surgically remediable epilepsy. Now, Pete Engen had described this entity, and he had found that there are certain epilepsy syndromes which are inherently resistant to surgery, to medicines. We know that no matter how much medicines you try, they will not get control. And in these, surgery does get good results. So his hypothesis was, in this subgroup of patients, try the first line, try the second line anti-epileptics, and if they are not controlled, evaluate and consider surgery. And in these cases, the pre-surgical evaluation was not so rigorous. So what are these disorders? Mesian temporal sclerosis, which relates basically to hypoxia at birth, which causes damage to the hippocampus. And this was rampant in India because of the poor antenatal and because of the poor natal care during delivery and post-delivery. The second was partial seizures occurring from discrete small neocortical lesions. Next was diffuse unilateral hemispheric disturbances. And this again was something which was not uncommon. We had these infantile hemiplegia seizure syndromes, which again, because of poor antenatal and pediatric care in the early phases of childhood, was quite rampant. And there were disabling drop attacks. And this is, you can see, this is the hippocampus on the right side. Compared to that, a totally shriveled hippocampus on the left side. Again, the same thing you can see in the next cut. So in view of the large number of potential cases in India, we felt that it would be ethical to start the epilepsy surgery program with patients with surgically remediable epilepsy. So we thought, let's give it a start, let us start doing it, and later we can expand. So the first hurdle that we faced, that ethical dilemma in my mind, is whether we should do it or not, was sorted out. The next thing was neurologist cooperation. There was no way this program would get going without the neurologist cooperating with me. And I contacted our neurology professors at AIIMS, and I was met with a lot of skepticism. The first thing they said was, the neurosurgeons are only interested in tumors and aneurysms, and they don't want to do anything else. So if you are serious, leave your department and come and join me. So this was the next thing that we faced. So my answer to him was, sir, I will join you. The day you have enough cases to keep me occupied with surgery every day, I will join. I will leave my department and come to your department. So on that, we started. He was also skeptical. Many people have tried in the past, but okay, you're a young man with young blood. You want to give it a try? Okay, go ahead and let's see what you can do. So having said that, I must also say that once the program, he saw that I was serious and we were able to deliver, he was one of my strongest supporters all throughout the country. So with this in mind, I luckily got two people who became very enthused with the idea of epilepsy surgery, and together we decided to give it a try. There was Dr. Satish Jain, a good friend, a neurologist, epileptologist who was again passionate about epilepsy, and Dr. Manveer Bhatia, who was running the EEG lab, the neurophysiology lab, and she also was attracted by the idea. And together we decided that we will make it happen. And we said, no matter what, we have to make it successful. Now, the epilepsy surgery team is a big team. Besides the three people on the top who are the core members, we needed a lot of support from other departments. We needed a neuroradiologist, a neuropsychologist, a neuroanesthetist, a neuropathologist, and a nuclear medicine specialist. And I was supported by these people, Dr. Ban from nuclear medicine. We had Dr. Chitra Sarkar from pathology, Salesh Gaikwad from radiology, Dr. Harihar Dash from anesthesia, and Dr. Surya Gupta from neuropsychology. And together, we made this multidisciplinary team. Now, the next challenge was how to keep everybody happy. It is well known that these teams fall apart because of ego issues, because somebody feeling that one person is sort of trying to hijack the program. So we decided that there would be no leader. All of us would be equals. We would work together as a team, and nobody should get the feeling that one person was getting mileage at the expense of the others. So very soon we'd established a rule that whatever publications came out, whatever presentations came up, would come with 8 members, with 8 names of every member on the team. And with this spirit of bonding and togetherness, we moved forward. Now, coming to the pre-surgical evaluation, the question which first comes to everyone's mind is, what is intractable epilepsy? So there is no rigid definition. If epilepsy is frequent or severe enough to affect the quality of life of the patient, he should be considered intractable and should be worked out. There was a thumb rule of 2, which is what was generally used. But any patient whom the neurologist felt is not being controlled and quality of life is affected, we would move ahead. So should a neurologist try all the available anti-epileptics? So it is well described in the literature now that if the patient is not responding to the first or second line anti-epileptics, then trying the newer anti-epileptics, which are coming out every day, most of them in these patients describe 50% reduction in seizures. They don't talk about cures or full control. So if the basic 2 or 3 anti-epileptics have not worked, the chance that a newer anti-epileptic would completely control the seizures is very, very low. The second consideration issues were in children. There was a fear of operating on a developing brain as to what damage we could put. But we understood very early that the plasticity of the brain is there in the younger child. So even if you take out a tumor or a lesion from an important area, they would recover as opposed to an adult. So it's worthwhile doing it in children. Also, the deleterious effects of seizures on the developing brain was increasingly recognized. So even though it's a developing brain, it became all the more reason to operate on them before the brain was irreversibly damaged. And lastly, as I mentioned, the concept of surgically remediable epilepsy was something which came up, and we had lots of patients of MTS and infantile hemiplegia seizure syndromes in our country with whom we could say that we would be able to help them. So the aim of the pre-surgical evaluation was to identify the area of the brain which causes repeated seizures, to show that it could be removed safely without causing new deficits, and to assess the function of the rest of the brain. So extensive pre-surgical evaluation was needed with prolonged hospital stay and several tests. It was expensive. In India, we had constraints of equipment and finances, so we had to modify our protocols and customize them so as to go ahead with our program. So what does the video EEG contribute? It gives us a prolonged interictal record. It gives us the chance to study the ictal semiology because the whole thing is recorded. We are bothered about the first thrust or the first tonic posturing which occurs, which helps us to localize. It would exclude pseudo seizures, and we would identify the ictal onset zone because we were having a continuous EEG recording. So we would pick up the initial part where the EEG changes would start, and then as they spread, the clinical manifestation of the seizure would come. So generally people in UCLA would admit patients for 2 weeks and record at least 5 seizures on 64 to 128 channel machines. When we wanted to start a video EEG, a lot of logistic issues came. How long to do, short term or long term, and how many seizures to record, and how much anti-epileptics to reduce, and what if patient does not have a seizure. Mind you, we did not have any specific guidance as to how we could do it. We just had to think and move ahead and see what could be done. So our neurophysiology lab was in the OPD area, which was open from 8 a.m. to 5 p.m. So we could only do a short-term recording. And if the seizure did not come, again, the patient would go to the ward, and next day again, we would start. It would often be so frustrating that after 2 days of recording, when you don't have a seizure, you shift the patient to the ward, and 1 hour later, they have a seizure. And you have to give anti-epileptics. We could not extend this neurophysiology lab to 24 hours because it was in the OPD area. If in the night there is a seizure or a crisis, we did not have a doctor who was sitting there throughout the night. So later on, after a couple of years, we were able to shift the video EEG part of the neurophysiology lab to the neurology ward, and then we could start doing long-term recording. But the initial 1 to 1.5 years, we were doing it in the OPD area with short-term video recordings. And once we had it in the ward, we could also, then the ictal spect also became possible. So we would record 2 or 3 seizures on a 24 or 32 channel machine, and we would reduce the anti-epileptics the day before the surgery. And from the night of the surgery, we would stop the anti-epileptics altogether. And if on these 2-3 seizures which were recorded, the focus corresponded with the other localization, we would stop the video EEG after 2-3 days. If it was discordant, then obviously we had to record more. Also, more than 75% of the interictal spikes should be unilateral. MRI, we know that the CT scan is not good enough for these cases, and MRI is essential. So this was not a problem because the MRI was available, but we had to do a specific epilepsy protocol MRI. We had to do a double oblique sections through the temporal horn, high resolution, thin sections with SPGR and FLAIR sequences. And in some cases, we needed volumetry. Now, I must confess that most of the patients who came to us had normal MRI scans. It's only when we did the epilepsy protocol MRIs that we were able to pick up the small lesions or abnormalities which were responsible for the epilepsy. So in all cases, we had to repeat the MRI, and Salesh would be very helpful in getting proper sections done. SPECT was available in our center. The interictal SPECT was a bit of, not very worthwhile. I mean, it had limited utility because if there is a structural lesion seen, in all probability, the interictal SPECT would show an area of hypoperfusion. Where it would be useful were in children with cortical dysplasia, which was not maybe picked up on the MRI, and that may help us, that there the interictal hypoperfusion would help us to find out where we need to operate. The best thing would be an ictal SPECT, where when the patient has a seizure, immediately you have to inject a radio tracer. Now, this has to be put in the first couple of minutes, and then only it will go and get concentrated in the area where the ictus onset is. So the coordination problems were there, but later on this was sorted out once the video EEG lab was shifted to the ward area. The nurses and the doctors were trained, and the moment the seizure started, the vial which was there in the ward was mixed and was injected. So the injection has to be done within the first 2-3 minutes. The imaging can be done after 6 hours, so that was not a problem. But the injection had to be done in time. Neuropsychological assessment was another hurdle. Trained neuropsychologists are rare, and there wasn't a neuropsych battery which was validated in India. So here, our neuropsychologist, Mr. Surya Gupta, developed a battery of neuropsychological tests which he validated in Indian patients and which we used in all our cases. And as time passed, it became more and more reliable. So what they did was in memory and IQ assessment, they did a lobar localization, and often, even if they could not localize to the frontal or the temporal, they would tell us whether it's the right or the left. And as the time passed, he became more and more accurate. And as long as it was not discordant, it would increase our confidence levels. Now came another dilemma, the VADA test. Sodium amytal is not there in the Indian pharmacopoeia, so its usage is not legal. And some centers were using it. Trivandrum were using it because they had got some personally from abroad and were using it. But we were worried. What if a reaction occurs? How do we defend ourselves? And mind you, it's a very frightening experience for a patient. When you inject the sodium amytal on the left side in the carotid, and the patient becomes aphasic and he's fully conscious, it's a frightening experience for the patient. It's a horrifying experience. So we decided to go ahead without it. We assumed that if the hippocampus is so atrophic and sclerosed to cause intractable epilepsy, its function is likely already severely impaired and transferred. So we cannot make them worse. And with this assumption, we went ahead and did our surgeries, even on the dominant side, without a VADA test. And now, worldwide, it is being used sparingly, and today practically nobody uses it. It's used only in very exceptional circumstances. The next dilemma was if the MRI was negative and we could not find any abnormality of any sort on a MRI, epilepsy-specific MRI. So here, the localization became even more important. So in these cases, the ictal video EEG localization was done, and we wanted to record more seizures so that we wanted to be sure that all the seizures were coming from the same side. So it's possible that a person has multifocal epilepsy and 1 or 2 seizures may occur from one side, but the next may occur from the other side. So in these cases, we had to have at least 4 to 5 seizure recordings to be sure. And in these cases, the ictal SPECT was a must. So we have to have at least 2 confirmatory tests of good quality before we could subject them to surgery. And in these cases, the electrocorticography was also essential. The next is if the video EEG, the patient did not have a seizure on the video EEG recording. So video EEG negative cases. So here, although we may see an abnormality on the MRI, we are not sure that the epileptic that it is epileptogenic. So here we have to fall back on the prolonged interictal recording which is available. We should show frequent spiking from the lesion site as seen on the MRI, with no significant spiking from other sites. In fact, there are certain studies now which suggest that in a classical Mesian temporal sclerosis, the ictal record is not essential, and they can operate based on the interictal study, provided you have a prolonged interictal record. But if there is a bilateral MTS, or if there is a dual pathology, then one cannot compromise, and you have to have repeated video EEGs till you can establish the epileptogenicity and decide which of the two lesions is causing the epilepsy. So once this workup was done, we had regular epilepsy surgery meetings, and we would discuss the patient's threadbare. All the specialists would give their inputs. And before the MRI data was presented, the neuropsychologist and the nuclear medicine specialist were actually blinded to the MRI data, so that they gained the confidence, and we also gained the confidence that the data was not biased in anything. And then only the MRI was shown. So the decisions were taken jointly in these meetings. And concordance of the test is extremely important for a good outcome. And the best result would be if there was an MRI evident lesion, which was shown to be epileptogenic on the ictal video EEG. The neuropsychological assessment should at least not be discordant. And if the interictal spec corresponded, it added to the confidence levels. Now, coming to the surgical issues, temporal resections is a standardized resections. There are anatomical resections. There are a variety of resection techniques. No special instruments are required. All that you need is good microsurgical techniques and clean sections to avoid scar epilepsy. So this was doable. But the temporal lobe, especially the median temporal lobe, has important structures all along. If you look at the uncus and the hippocampus, you're working right next to the brainstem. There are the perforators of the brainstem are there, the third nerve is there, the vessels are there, and one has to be extremely careful. As neurosurgeons, we operate on the temporal lobe, but mainly on the lateral temporal lobe. So the anatomy of the median temporal structures is much more complex and not usually handled by neurosurgeons. And it's only after doing 4 to 5 actual surgeries and reading the anatomy text repeatedly does one understand the anatomy of this region. And what is most important is that when you're doing your resections here of the median temporal structures, you have to remain subpia, because the moment you transgress the pia towards the brainstem, there is potential of vascular and neural damage. So if possible, do cadaveric dissections in the lab, but it takes a little time to understand the anatomy of the median temporal structures. So one could either do an anatomical resection, which is what we did. That was the lateral temporal lobe, and this is the median temporal lobe with the hippocampus here. So we preferred this so that we would get good specimens for pathology. One can also use the ultrasonic aspirator, which is more safe for the medial structures, but you don't get a sample for the pathology, so you don't get a confirmation of what you're dealing with. And also you have to use in very low settings so as to remain subpia and not damage the pia. So the next surgical issues were in the lesionectomies, and there are a variety of lesions which we came across which could be causing intractable epilepsy. There could be tumor or tumor-like, and amongst this we came across this new entity, the dysembryoplastic neuroepithelial tumor. This was a recently identified entity by Christine Dormus-Lupo, and we found it in many of our cases. Vascular abnormalities, biotic things and developmental changes. So most centers work on temporal epilepsy surgery, and then only later on in their transition, they transit to extratemporal. The Sri Chitra people, I think after 3 years of doing epilepsy, 3 to 4 years only, first they did temporal and then they started doing extratemporal. But we transited from temporal to extratemporal fairly soon as we started getting extratemporal lesions. But compared to temporal lobectomies, which are sort of tailored resections, here extratemporal resections have to be done using electrocorticography. So how do we decide the margins? We need to do an electrocorticography, and we need a neurophysiologist to read the electrocorticography. So we do a direct recording from the cortex of the exposed brain and do the EEG recording there. That's electrocorticography. For that, we need grids, which are expensive and for one-time use. And there, the next dilemma came. We had, when we got our machine, we had got about 10 to 12 grids with it. And they were supposed to be one-time use, and they were supposed to be thrown away, which is what I'd seen outside in the UCLA. So how do we, carry a program forward with these expensive items? So we decided, we asked the company people, how do you sterilize them? And they said, we use ethylene oxide. And we said, why can't we re-sterilize with ethylene oxide? And said, that's not permitted. So we decided to override them, re-sterilize them twice, and reuse them, because that was the only way we could go ahead with the extratemporal cases. I mean, if everybody, each case we had to have $200 to $400 of electrodes, US dollars, it would have been extremely expensive. So we took a risk, we re-sterilized them and used it, and touch wood, we did not have any problem. We started doing ECOG in all cases to gain experience. And there again, we had a problem. The first 4 cases, we put the electrocorticography grid and we couldn't get any recordings. We tried everything, the anesthesia drugs, the recordings, but nothing seemed to work. We called the company people, they were equally clueless. It was the first time we were doing it in India. Till we realized that the recordings which were done directly from the cortex, because the bone was not there, the scalp was not there, the voltages which we were recording are very, very high. So when the machine was set to the routine settings, those recordings were going above, far above them. So we had to reduce the sensitivity and the amplitude of the display to much lower levels so that the top of the wave could be seen. And only after 3 or 4 cases did we realize how to go about it. So these were the electrodes we had, the grids we had, which we used. And here you can see the spikes before the resection, and after a resection from the same area, the spikes have gone. So this was the first case that we did in April 95, a 4-year-old girl with intractable epilepsy. And this is what we found on the scan, X-ray, on the CT scan and the MRI scan, a lesion in the median temporal structure. And this surgery was in 2 parts. There was a dural part and an intrinsic part in the cortex. And this turned out to be meningoangiomatosis, a rare disorder which is described for epilepsy. And this was the only meningoangiomatosis we had in a series. This was another small lesion in the median temporal structure, which had been missed in initial scans. This again is in 95, one of the early cases. And this came out to be dysembryoplastic neuroepithelial tumor. It's a cortically located tumor, does not increase in size, is not malignant, and has this floating neurons. And when you take it out, it is almost watery, water sort of seeps out of it. So this, again, we found that whenever we find it, is often associated with intractable epilepsy. It's a benign condition, does not grow, does not need radiation therapy, and gives excellent results with surgery. So again, you can see a lesion here. The gray-white matter of the median temporal lobe is not there. And this was a solid ganglioglioma. Another lesion near the motor strip, we did the function MRI with finger tapping. The recording was posterior. So we approached it from anterior, took it out. It was an astrocytoma. A calcified lesion on this scan on the median temporal structures again, which turned out to be a calcified hemangioma. A cavernoma in the cortex. And this here, to control the epilepsy, the hemosiderin ring has to be taken out, otherwise it doesn't work. A patient who was a post-traumatic patient came with a scar epilepsy, repeated episodes of status epilepticus. We had to excise this scar and he became seizure-free. A congenital lesion, a cleft in the cortex, a developmental disorder, Scheissencephaly. And here, you have to, during surgery with electrocorticography, find out which part is causing the epilepsy, which part is epileptogenic, and that has to be excised. Another lesion here, an abnormal area, turned out to be cortical dysplasia. You can see that the lamellar distribution of the cortex is totally destroyed. There may be heterotopic neurons in the white matter, and the neurons may be bloated with a form of fruste of tuberous sclerosis. So when we are operating lesions, how is it different from epilepsy surgery? We know that, how is epilepsy surgery different from just taking the lesions out? Now we know that most of the lesions do not contain neurons. So they are not the ones which cause epilepsy. It is the changes which it incites in the surrounding cortex, which is the cause of refractory epilepsy. So you have to take out the lesion and the epileptogenic area cortex around it. And sometimes you get a dual lesion. They have a cystic area here, and even the hippocampus is atrophic. You can see how big the temporal horn is. Another case with a anterior temporal lesion and a posterior temporal lesion. So here you have to find the epileptogenicity and find out which of them is causing the epilepsy. Eloquent area lesions, we could do functional MRI, cortical mapping, and a wake craniotomy. Now, we were often criticized by the purist neurologists that we are not doing true epilepsy surgery, we are operating lesions. Now, before the MRI, MTS and cortical dysplasia were called true epilepsy surgery, non-lesion. And only the pathology showed the lesions. But after good MRIs, even they have become lesion, that something is picked up on the MRI. And now, non-lesional epilepsy occurs in less than 5% of surgery patients. So it is likely that all epilepsy surgery is lesional. It is only the sensitivity of a diagnostic test that we are not able to see the lesion. Corpus callosotomy was technically not difficult. We were doing transcanosal approaches regularly. Hemispherectomy was much more difficult to conceptualize. Videos were not available. So I again went to UCLA on a subsequent visit, saw Gary Mathern do one hemispherotomy and came back and started doing. So this is the infantile hemiplegia Caesar syndrome with one hemisphere atrophic. We also tried a hand with gamma knife for radiosurgery. I had been to Marseille and we treated 5 cases of MTS with gamma knife. After 9 to 10 months, the auras would increase dramatically and then the seizures would stop. But they would get very severe radiological reactions with mass effect, which would need months of steroids to control. So 3 of our patients had severe reaction, 1 had a moderate reaction and 1 had no reaction. Those with severe reaction became seizure-free. 1 patient with moderate reaction had a partial reduction. 1 patient with no reaction had no reduction. So somehow that response was related to the reaction. So it's possibly effective, but the reaction was frightening. They would get papilledema, severe need prolonged steroids, and we stopped doing it. We tried it for hypothalamic hematoma in 1 patient, got a good response for 3 years, but then again it came back. Post-operative seizures are demoralizing for the family and the patient. But what we realized is there is a running down phenomenon, that the seizures become less and then gradually disappear. So we informed the family pre-operatively. We would continue the same anti-epileptics post-op and start reducing after 3 to 6 months if they were seizure-free. Pseudo-seizures is another problem we had. Once the patient becomes seizure-free, the family expects the patient to be independent and normal. But these patients have been suffering for so long that they are not psychologically capable of dealing with the situation. So they're starting having pseudo-seizures, some of them. Follow-up was one area where there was no problem. We had very good follow-up. These patients have been suffering for such a long time that when they come for surgery, if they benefit, they are grateful for the surgeon for life. And you are not just controlling the seizures, you're curing them. So very briefly, in the 7-year period I was there, 135 patients operated, 128 focused resections, 66 children. A large number of patients were under, almost 2/3 of them, or more than half, were under the age of 20. Patients, 1/3 of patients had seizures for 5 years, 1/3 had seizures 5 to 10 years, and 1/3 have seizures for more than 10 years because nothing else was possible. So they came to us late. This is changing recently. Most of them were partial complex seizures. The seizure frequency, 1/3 of our patients were having seizures every day. The epilepsy was so severe. So 128 focused resections, 98 temporal resections, and 29 extratemporal, only 1 hemispherotomy. These were the type of abnormalities that we saw. And our complications were there, especially in the beginning, but thankfully most of them were short-lived. In the subsequent, with experience, they had become much less. We had 3 patients who died. One was operated for a temporal sclerosis. He was fine, discharged after 1 week. 3 weeks later, he had a seizure, had aspirated and came with an arrest. 1 patient died of infective complications, and 1 patient was seizure-free for 38 months, and then he had a tumor recurrence. So after callosotomy, seizures are not controlled, only the generalization goes down. With surgery, we had 111 patients with a long follow-up of more than 18 months. And 80% of our patients were totally seizure-free. 11.7% had reduction in the seizures, but did not become seizure-free. And 9 patients, or 8% of our patients, did not have improvement. So the recommendation was that we have to be very selective in choosing our patients. As at that time, a lot of so-called well-wishers were watching us with hawk's eyes. They were waiting for us to fail and say, okay, we told you so. You can't do it. But we had to deliver good outcomes. Otherwise, we would have been denigrated. And with a bit of luck and determination of the whole team to succeed, we managed. Then we started spreading the message. The first 10 cases we presented at the Indian Epilepsy Society annual conference in Calcutta, where we were awarded the Best Paper Award. We went to various conferences and kept presenting epilepsy surgery to the exclusion of everything else. So much so that people don't recognize me for my microsurgery. They only know me for epilepsy surgery and gamma knife radial surgery. Now, several centers all over the country have started doing epilepsy surgery, and they're doing well. In the meantime, at AIIMS, things have moved forward tremendously. Sharath, whom I trained, has taken the epilepsy surgery program to much greater heights. He has started invasive recordings. There's a full-fledged center of excellence for epilepsy with a MEG, cellular electrophysiology studies, and an epilepsy surgery fellowship program is also available at the AIIMS. But we have to develop protocols which are suitable to our needs. We cannot blindly follow the best. We had to cut corners, but we have to cut corners sensibly by trained clinicians so as to ensure that the patient's safety is not compromised and good outcomes can be achieved. So what we
Dear faculty members, sharp 2 o'clock, we will be resuming the afternoon session. Thank you.
Good afternoon to all of you.
Good afternoon.
Hi, good afternoon, sir.
Hello.
Hello.
Yeah, I can hear you.
So I think I'm seeing Dr. Ashish Suri on the screen. So I think this first copy by Dr. Rana Patra is already here. Just wait for 1 minute.
Dear faculty members, day 2 afternoon session will be starting in 1 minute.
A very good afternoon to all of you. Our next session is vascular neurosurgery. Our chairpersons are respected Sir Dr. Rana Patil and respected Dr. Ajit Kumar Sinha Sir. Now I am requesting to our chairperson to take charge and proceed. Thank you, sir.
Is Ajit Sinha around? Not as yet. Okay. Am I being heard?
Yes,
Yes, sir. Yeah.
Okay. So, okay, let's start the session. I think I don't see Dr. Sinha as yet. Is Ashish around? Ashish Suri.
Hi. Oh, right.
Okay. Sorry, what's happening here? Just one moment. Okay. Is Ashish around? Ashish Suri? He was the first speaker. I don't see him around. So we can have the next speaker. That would be Dr. Harsh Rustogi. Yeah,
Yes,
Harsh,
sir.
see?
Yeah.
Yeah, so Harsh will be speaking on the management of vasospasm, what's new. So we can start the session with Harsh.
Okay.
Yeah.
Thank you. So give me a minute, just. Give me permission to share screen.
Share screen. One moment.
Sir, already permission.
It's not coming up.
Doctor, you need any help?
Yes, yeah. You can see my slides?
Yes.
Yeah, yeah, seen very well. Go ahead.
Just a minute. Need to minimize the window. Okay. A part of it is occupied by the images here. All right. Okay. Okay. Good afternoon, everyone. Thank you, Dr. Ranapatir. I'll be talking about management of cerebral vasospasm, what's new. I thank the organizers for giving me this opportunity. And I'll be discussing what is cerebral vasospasm, what is normal cerebral blood flow, biphasic cerebral vasospasm in SAH, and ultra early arterial vasospasm, a little bit of pathology, physiology, morbidity, history, incidence, risk factors. Can we predict cerebral vasospasm, cerebral autoregulation in subarachnoid hemorrhage, which I think is new? And why do we use nimodipine today? Balloon angioplasty as a rescue measure, and finally conclude. So cerebral vasospasm is transient arterial narrowing, which is as usual seen between 3 to 10 days of SAH, and it persists for about 2 to 3 weeks, and it can lead to delayed ischemic neurological deficit. We need to understand the cerebral blood flow when we talk about cerebral vasospasm. Cerebral blood flow, when compared with mean arterial pressure, has a plateau which ranges from 70 to 160 millimeters of mercury. And thereafter, if you increase the blood pressure, it can lead to hyperperfusion. But by lowering, there is a reserve capacity till which the symptoms of vasospasm are not seen, and ischemia does not occur. And thereafter, hypoperfusion occurs when the cerebral blood flow falls below 30 milliliters per minute of 100 grams of brain tissue. So we need to maintain the renal cerebral blood flow in normal persons. And as it goes down, it becomes symptomatic, initially reversible, and then can lead to permanent neurological deficit and death of the cells. Under special circumstances like after SAH, when an aneurysm bleeds, there is raised ICP which changes the cerebral blood flow. Depending upon how much is the bleed, there is a biphasic spasm phase. Initially, the normal vessel goes into acute contraction, producing severe vasospasm, followed by dilatation, initial recovery, and then possible restoration. This acute vasospasm phase lasts for about 3 to 4 hours. It stabilizes for a few days, and then there is emergence of delayed cerebral vasospasm from day 3 to day 21. The pathophysiology behind cerebral vasospasm is too complex, and cannot be discussed or deciphered in a very short period of time. But we know that there are a number of biomarkers which come out and are responsible for the response of the arterial lumen that we see subsequently. It may be secondary to RBC hemolysis, release of oxygen and nitric oxide. Prolonged smooth muscle contraction is the effect, and secondary effect leads to vessel wall fibrosis, hypertrophy, hyperplasia follows. We all know that in order to neutralize these markers, a number of trials have been done, and all of them have failed. None of them has been able to produce a good result. And in Girish Menon's article, Vasospasm Following Subarachnoid Hemorrhage, the search for the elusive drug continues. There was an editorial by Professor Sharma, where he talked about the edema of subarachnoid hemorrhage, which is a multifactorial event, and it involves several processes which produce various biomarkers, but none have been diagnostic or have been neutralized. Angiographic vasospasm in subarachnoid hemorrhage was described in 1951 for the first time by Ecker and Schneider. Fisher in 1977 was the first to correlate it with the CT, where you see a normal vessel and after a few days the CT shows a severe spasm. It is seen in 2/3 of the patient, whereas only 1/3 are symptomatic. So they present as confusion, neurological deterioration, dysphagia, hemiparesis, headache, meningismus, and low-grade fever. The mortality and morbidity associated with SAH is almost 1.5 to 3 times in the first 2 weeks. And over the last few decades, we've been able to decrease the morbidity and mortality from 30 to 15%. And the risk factors associated with SAH are the amount of blood clot present, the persistence of subarachnoid clot, that is slow clearance, poor neurological condition at the time of admission, loss of consciousness associated with rupture, hypertension, diabetes mellitus, smoking, and cocaine. Fisher grade is a good correlation. In the grade 1 and grade 2, where the amount of SAH is very less or less than 1 millimeter thick on CT scan, the incidence is low. Whereas in grade 3, almost 90 to 95% patients where the SAH is high can present as cerebral vasospasm. Usually seen from day 4 to day 12, peaks around 5 to 7 days, but symptomatic vasospasm lags behind by 1 to 2 days, and it peaks between 7 to 10 days. Therefore,
sorry to interrupt. I'm sorry to interrupt. I cannot see, I don't know if it's a problem, but we cannot see any slides. We can only see your, Dr. Harsh's face and a stopwatch. Can someone rectify this?
Ashish, go to the top right of your screen. There is an option of view. In that, click on slide by side viewer.
Okay, thank you.
Is that okay?
Thank you, sir.
So, should I continue?
Yes, please. Please continue.
Initially, Triple H therapy was used to control, but now it is going out of vogue. There were, because of the intracranial and extracranial complications associated with it, like pulmonary edema, hyponatremia, and myocardial infarction. Earlier, when we were doing either aneurysm clipping or coiling, and there was an associated vasospasm like as seen in this case, the vessels were very narrow. And by giving intra-arterial nimotropine, these vessels would dilate and you can perform the procedure. But we used to discontinue nimodipine very early, which led to a condition like this, where there was infarction of the parietal and the occipital lobe, that is the entire MCA territory. With these poor outcomes, as we were not following them on TCD, we were just monitoring them by CT scan. It was difficult to predict the outcome after intervention, especially coiling of the aneurysm. With the advent of TCD, transcranial Doppler imaging, which was done on a regular basis, whose sensitivity ranged from 60 to 80 or 90% and specificity between 50 to 100. If the mean velocities were more than 120 centimeters per second, the chances of having a vasospasm was quite high, and it was a bedside procedure. And the most important factor was a rate of rise of the cerebral velocities by more than 50 centimeters per second per day would be the alarm bells ringing that this is vasospasm and needs acute intervention. Anything above 200 centimeters per second was considered to be severe vasospasm. But in a recent publication in 2021, a myogenic response has been attributed to cerebral vasospasm, and therefore the whole process of vasospasm needs to be looked into. The blood flow augmentation depends upon the non-neural mechanism. Any increase in intramural pressure would lead to increase in vasoconstriction on the basis of this myogenic mechanism. We can see 3 slides, one in which there is very little distal spasm, the other one in which there is very tight spasm in the main artery, and the third one where there is both the distal as well as the proximal arteries are in spasm. As we all know that the cerebral vessels, which are less than 300 mu microns in size, they are responsible for 80% of the cerebrovascular resistance. In a patient with subarachnoid hemorrhage, there is acute increase in the blood pressure, and therefore, and also increase in the intracranial pressure. Therefore, we cannot compare the mean arterial pressure and the cerebral blood flow graph that we've seen earlier. This is unique to the cerebral microvasculature, and therefore we need to consider the cerebral perfusion pressure across with cerebral blood flow. And we see when there is no major vessel involvement, only small vessels are involved in a patient of subarachnoid hemorrhage, the graph shifts to the left. And this shift to the left decreases the window to control the cerebral perfusion. A little increase in the cerebral, in the mean arterial pressure by up to 140 millimeters of mercury can restore the perfusion of the microcirculation. Further fall can lead to, as there is no vascular reserve, the fall can produce ischemia. If there is only spasm of the main vessels, which are more than 1 millimeter in size, like the ICA, MCA, ACA, or vertebral artery, these are 20% reactive. They are less reactive as compared to the microcirculation. And here the graph shifts towards the right. And here, by increasing the blood pressure, the response and the perfusion can be restored much easily. Whereas if there is a combination of the two, where the major and the minor vessels both are affected, then the situation becomes dangerous. We need to understand the physics formula where flow is directly related to the diameter or the radius of the blood vessel to the raised to the power of 4. A slight increase in the diameter of the blood vessel would greatly enhance the perfusion if the intracranial pressure remains the same. Like in this cartoon, a vasodilatation of 19% would double the cerebral blood flow. and a constriction of 16% would halve the blood flow. Therefore, the ideal drug which is used by interventionists today is nimodipine. It is a preferential cerebrovascular dilator. It preferentially exerts its action on small blood vessels and has no effects on the veins. It is lipophilic dihydropyridine class of calcium channel blocker, and it inhibits the L-type voltage sensitive calcium channels, which are responsible for waves of depolarization in the axon, which finally leads to cell death. So once we block the depolarization process, it improves the neurological outcome, and the mortality associated with all grades of SAH also improves. And it also acts preferentially on the microcirculation or the vessels which are less than 70 mu microns in size. We've been using nimodipine as an intra-arterial route, intravenous route, and also during the process of coiling and clipping. Coiling here is an example where there was very tight stenosis, and it was difficult to negotiate a microcatheter up to the aneurysm. But after intra-arterial nimodipine infusion for about 15 minutes, the vasospasm gives way and coiling is possible. Another example in which after nimodipine infusion, clipping was possible. This is an example of the same. And the nimodipine was infused for a couple of days intravenously. Another example where the proximal vessels are very tight, but then they open up after nimodipine infusion. Another example where the distal circulation shows minimal spasm, but with the nimodipine infusion, not only the spasm is relieved a bit, but the symptomatic improvement in the patient is also seen. Sometimes spasm occurs late, and therefore nimodipine infusion should be given intravenously for up to 12 days. There has been a very good study from NIMHANS in which 106 patients of aneurysm rupture were part of, and 26 showed delayed cerebral ischemia. Angiographic response of intra-arterial nimodipine was seen in 22 of the 23 patients in whom it was given. The clinical response was seen in 20 patients, and 87% was a good response. And favorable outcome was seen in 19 patients after 3 months. This is what we do, or we have been doing over the last 20 years. But this was the first publication from NIMHANS, which was a retrospective study. Nimodipine is preferred because of its cerebral vascular dilatation, which is a preferential action, and it also prevents neuronal death. It can be given orally, but orally is given after 12 days. We continue IV nimodipine infusion at 1 milligram per hour initially, and can be increased to 2 milligrams per hour infusion for 5 to 14 days. If the cases are severe, intra-arterial nimodipine can also be given. There is always a question why no positive studies have come out from the US or across the Atlantic. And the reason is very clear. IV or parenteral use of nimodipine is prohibited in the US. The nimodipine infusion is used extensively in Europe and in Australia. And in India, most of the interventionists use intra-arterial nimodipine. Milrinone has come off to be one of the alternatives, but nicardipine is also tried. The last few slides where a balloon angioplasty is used as a savior to treat vasospasm. But there are few studies, and angiographic improvement in seen most of them, clinical improvement in seen almost in 2/3. It is effective for proximal vasospasm only. Morbidity and mortality is 5 to 10%, and it is used as a salvage therapy. There are certain complications like vessel perforation, rupture, arterial dissection, arterial occlusion, ischemic stroke, hemorrhagic transformation of infarcted tissue, rebleeding from uncontrolled aneurysm, and displacement of aneurysm clips. They have all been reported. So in the end, the management hinges upon prevention of arterial narrowing. That is, if you have a high degree of suspicion, start nimodipine early. Reversal of arterial narrowing either by using nimodipine or milrinone. As a salvage procedure, balloon angioplasty can be done. Prevention and reversal of ischemic neurological deficit in the long run. One small advice would be to look at the cerebral perfusion pressure, because our intracranial pressure changes over a period of time. We advise nimodipine infusion for about 12 days. High degree of suspicion in patients who have neurological deficit. Ultra early arterial vasospasm has a poor prognosis. Risk factors depend upon the amount of blood clot present. Gold standard is angiography, and balloon angioplasty should only be used as a salvage procedure. Just note that not all irregular and narrowed arteries are because of vasospasm. In this case, an aneurysm is seen in a patient who has been treated with radiation, and this was radiation-induced vasculitis. So the elusive drug still excludes us, and we need to add nimodipine in our armamentarium while the search for the mystery drug continues. Thank you. Thank you for your patient hearing.
Thank you, Harsh. That was a very nice talk. And if there are any questions from the audience? Okay.
Thank you, Dr. Harsh. IV infusion is to be given for 12 days, continuous IV infusion. Yeah,
Well,
this is
yeah.
Anita, sir.
Yes, yeah.
I'm Anita. This IV infusion.
Yes, IV infusion is given for 12 days. It is said that if the...
given for 12 days.
Pardon? Pardon?
Yeah,
Couldn't
please
hear you.
continue.
Yeah, IV infusion is given for 12 days.
Yes, sir,
or
IV.
Yes, intravenous infusion of nimodipine. As an interventionist, we suggest that it continues for 12 days. Or if you do a transcranial Doppler and the Doppler velocities come down to 83 or 100 centimeters per second, then you can discontinue and bridge it to oral nimodipine. The results are definitely better, because if you discontinue IV nimodipine early, there is a resurgence of vasospasm, and the patient who's been shifted out of the ICU comes back to the ICU. This is what we've observed in our practice.
So you are giving to all the patients, irrespective of the symptoms or signs appearing.
Where there is high degree of suspicion, patients at risk who have shown vasospasm or who have been treated with vasospasm during coiling of the procedure, coiling procedure. There it is advisable to continue it for 12 days.
And then oral therapy for another 3 weeks.
For about a couple of weeks.
Thank you.
Let me ask a few questions. So what percentage of cases would you give intra-arterial nimodipine?
Intra-arterial nimodipine after the procedure, after securing the aneurysm. The incidence has gone down tremendously. Earlier, it was about 5 to 7% cases where we would give intra-arterial nimodipine, where there is non-relenting vasospasm.
Okay.
But now it is very uncommon, because we increase the dose from 1 milligram to 2 milligrams and also augment the blood pressure simultaneously.
Okay. Okay. Thank you very much.
Thank you, sir.
Ashish Suri is still not around. Okay, so we can have the last speaker.
I'm here, sir. I'm here.
You are here. I don't see you. Okay, there
Hi,
you
sir.
Yeah, okay.
Very much here.
Okay, so we can have the next talk by Ashish. And so let me just see. So he's going to talk to us about bypass and aneurysm surgery. The floor is yours, Ashish.
Thank you, sir. Am I audible and visible?
Yes.
Yeah, thank you. And thanks DNA for the kind invitation. And actually it's an honor to present in front of Dr. Rana, who's been actually my teacher and when I was a resident and he was a faculty at Ames. It is because of his him I actually took up vascular and cerebrovascular and skull. Thank you, sir. Seeing you after a long time.
Yes, I know.
And I'll be talking about bypass is more of an adjunct which we use for aneurysm surgery. We have to realize that the rule of revascularization, we need it for giant and complex aneurysm because of prolonged clipping time, the requirement of sacrifice of distal branches. And the rule is to transiently maintain the perfusion or to permanently reperfuse the neural tissue. And the choice of revascularization depends on the extent of collaterals, the caliber of the donor and the recipient vessels, and the expected duration of the temporary vessel occlusion, especially for primary reconstruction of the aneurysm. And if we are sacrificing anatomical location of the planned vessel sacrifice. This is a very important slide that we have to understand the types of bypass. If you are doing a salvage, that means you're restoring the complete flow after a planned vascular sacrifice or an injury. A flow alteration, which I'll be coming down to, because you're supplementing the flow, or you're giving an insurance, you're saving time. And this is a very important slide from Badger's department. It states that anything above 14 minutes of clipping time or vessel compromise can lead to infarct, and anything above 30 is 100% infarct. And these are two types of flow alteration, the proximal trapping and the distal trapping. This is our application. And the low flow bypass, the ECIC is less than 50 ml per minute. And usually the donors are superficial temporal artery and the occipital artery. And this is how we dissect the parietal and the frontal branches of the STA. And then we are planning to anastomose to M2-3, and I'll be showing a couple of videos. And usually plan a double barrel if both the branches of the parietal as well as the frontal are available. This was a complex giant MCA plus an ACOM aneurysm, and this is the section I'll be scrolling through because of lack of time. This is the parietal branch which is being taken off, all under the microscope. And then we take the frontal branch after that, but keep it in the flap because there is a chance that we may not require a double barrel. So here we do the standard craniotomy by opening of the cilium fissure, then going down. And first we clip the ACOM because we didn't know actually which one had blood, from most predominantly MCA, but opening of the intrahemispheric fissure so that there is least section on the gyrus rectus. And visualize the opposite A1s. And then you see this is a posteriorly directed ACOM and a broad neck. And it's important to take off all the perforators and then on a temporary clipping that's a water bath, that is dissection of the neck. And water bath coagulation, this is so that you actually form the neck. I'll just go to after we clip this, we come on to the MCA. And that is a giant aneurysm, and we prepare both the donors. And we plan, because this was a flow alteration bypass, so we plan to bypass on both the divisions of usually the clipping time, and this is somewhere between 13 to 14 minutes. So the frontal branch goes for the infrasylvian, that is the temporal division. I think someone can mute the office. Yeah, then we go for the back wall first, and then the front wall. And then we go for the parietal branch. Of the STA goes for the the frontal division.
अरे मेरी क्विज रिपोर्ट देख रहे लिखते कैसे हैं आप नीचे जा रहे हो क्या हाँ जी वेदांश आ गया
थोड़ा म्यूट कर दीजिए please. Some then the back wall and the front wall, and then we confirm with the Doppler and then the ICG that we are through, and then we go for the temporal and then go to MC aneurysm, and then now you see our decision was right on planning the angiogram as well, that this branch is coming straight out of the fundus. That's the inferior division, so we have to actually sacrifice this branch, and no amount of reconstruction can save this branch. Plus, this is a calcified aneurysm. So we have a bypass on both. So we can plan on the clipping. So we open the aneurysm, do a thrombectomy, dissect it off the perforators, and then reconstruct the aneurysm. So that is the proximal. And this is one branch. It's just proximal to the bifurcation. And then from the bifurcation, there is a frontal division. And then we actually sacrifice the origin of the temporal division, that's inferior division, and that is flow through the from the bypass. So this is more of a flow alteration bypass. And this is another complex, this is an insurance bypass in which we could only get one branch of the STA. The other branch was very, and that even the length was small. So this is something which I would like to show, that even if you have a small length of a parietal branch, the frontal branch, so normally we do the back wall first. So here we were forced to do the front wall first, but then we do a small frugal innovation, we actually take, after we do the front wall, we take the adventitia of the same parietal branch with a Liger clip, and we put it onto the temporary clip up over the STA of the M2, M3, and then we do the back wall. A small technical jugaad. And then once we have the bypass, and then we see the flow, and now we are safe. We can, and this is a calcified aneurysm. We open the aneurysm, do a thrombectomy. And here we could easily clip the aneurysm, but the clipping time was around about 20-22 minutes. But with the bypass in, we were safe. And this bypass will not be required actually after the complete clipping. With a series of tandem clips. And that's it. So and this is a complex PCOM P2 aneurysm in which the P1 was not there. It was failed embolization by two centers, and we planned an STA P2 anastomosis and basically trapping of the aneurysm. And we took the STA, both divisions, and we did a single piece FTOZ, basically a temporal craniotomy and a zygomatic osteotomy, and did an extradural anterior, opened the posterior cavernous sinus and did a extradural rhomboid removal of the Petrus Cavazes rhomboid, that is the anterior transpeter. So that we have the shortest length of the STA right till the P2. And then we open the temporal dura, and that is the superior petrous sinus, and that is the tentorium behind the fourth nerve. Now we have the shortest route of the STA. And we here, because it's a deep anastomosis, we do a continuous stitching. I'm rushing through my videos because of time. And then we put a temporary clip on the aneurysm as well as on the proximal. And then we take the heel toe stitches and do a continuous anastomosis. And then we didn't require a second one, so we sacrificed the frontal branch of STA, and we checked the flow. It was there from the bypass, and we trapped the aneurysm, and we opened and decompressed so that the brainstem decompression is there. and we just change it. Another low flow, this is a pica aneurysm, a large complex in which there was a very broad neck. We did an occipital artery harvest. And we took the occipital artery with which was like a far lateral approach. And that is the loop of the pica before the telovelar and after the lateral medullary. That's a safer place. And do an end to side. Always, one should have the ostomy at least 2 to 3 times the size of the diameter of the donor. That's the best thing to do. Sorry, the recipient. So once this is patent, then we can actually go for the aneurysm. And here our plan was to trap the aneurysm because it was very broad neck, but you'll see the difference. That is why planning of a bypass is important. When we open the aneurysm and we put temporary clips, we're planning to bypass that. We opened the aneurysm, tried to dissect it around. And we were there. And then we saw that there was a perforator arising from that broad neck. And had we trapped the whole thing, it may be one of our important branches supplying the brainstem. So we thought best would be we already had the bypass in place. Rather than going for a trapping, we should reconstruct this aneurysm. It took some extra time, but we were safe with the bypass. So we were planning on a salvage bypass, which actually became an insurance bypass. High flow bypass, these are some publications from our department on giant aneurysms and high flow bypass. I think we'll just rapidly go through. This is a giant cavernous aneurysm with, this is a slightly old video. This is a radial artery, which is going behind the ear to the M2, because we've seen all this. So we'll just, and then in the neck, we go end to side with the radial artery. I do less high flow bypass now because the cavernous aneurysms are nicely done by my endovascular people, except for these are difficult ones. These are the ones we still have to do. These are a complex choroidal artery aneurysm. It was planned not to embolize because the choroidal was again arising from the fusiform base of fusiform aneurysm. So we planned a high flow. We opened and checked, and then we realized that we need to do it in we second staged it, and we did an end to side. This is the end to side of the radial in the neck. And now we have the high flow bypass in place. We opened the aneurysm. This was a long clipping time, 30 minutes, and we opened it, did a thrombectomy. And when we were planning to trap it, and we realized that the choroidal is actually arising. That's a choroidal artery. It's arising from just at the base of the aneurysm, and trapping that would have been impossible. So that was probably the reason our endovascular thought that maybe we could go for a surgical procedure. So we did a tandem and a stacked clipping, saving the choroidal artery. So I think with 30 minutes of this clipping time, it was better that so these are the tools which I feel very fine forceps for the low flow bypass and the long forceps for the high flow bypass. I got these from my friends in Japan. And intra-op ICG is very important, and Doppler ultrasound. We don't need too many instruments for this. Plus, I feel as a teacher that we have to train our residents and fellows in microvascular neurosurgery, since this specialty is coming down because of the number of cases going for endovascular. Plus, there is very few centers are actually operating. So, and we follow this type of training program at AIMS since a long time now, microsuturing in the lab, silicon, and then femoral vessels and rat models in live anesthetic rat, and then assisting bypass surgeries, and then independent. And there's a complete program that we have from microvascular simulation on basic, intermediate, and advanced modules. And we are thankful because of our teachers, Dr. Tanda and Dr. Banerjee, that we had this lab nearly 4 decades ago. And now it is complete federal government funded DHR, DBT, and PSD funded 3D microscopic endoscopic lab. And we believe that there's no role of small workshops. We need a 2-week or a 4-week or an 8-week training. We train more than 2,000 neurosurgeons in this lab for nearly 24 countries. And we are still active in the COVID era because I feel the training never stops. To conclude, cerebral revascularization is a major treatment option for prolonged temporary occlusion when the temporary clipping time is supposed to be long. Definitive occlusion of the parent vessel is required and there's positive BOT. And there's involvement of bifurcation like we saw, especially for IC aneurysms. What factors governing the construct of an ideal bypass, the amount of flow is required, the character of the donor and recipient vessels, and the technique. The technique is most important. You can reduce your time by a lot of practice. And the training is very important, especially for all the programs who are involved into teaching of MCH and DNB. Thank you. But I always feel that whatever we say can become redundant after 10 years. Maybe coiling and clipping, everything goes, and we have some genetic factors which can be just changed after 10, 15, 20 years. Thank you very much.
Thank you, Ashish. That was a very, very excellent presentation. I was very proud of you that you are doing all these things.
All your blessings, sir.
I'm very glad that you've gone well beyond what I have done.
No, sir. You cannot say that. I've always been your fan.
No.
I'm an old fan of yours.
I think I'm very proud to say that you.
Thank you, sir. I salute you.
What I've done.
I salute you with both hands.
Yeah.
You'll always be the inspiration for me. Very meticulous and very beautiful tissue handling. That's what I tell my residents. If you want to have good results in neurosurgery, meticulousness is most important, and tissue handling is very important.
Yes, so true, so true. And
Yes,
I'm especially happy that you've made this lab, this microsurgical lab. I think it's an excellent initiative that you've taken. And
you must come, sir. You haven't visited.
I know. I've always promised. I must.
Yes, sir. Thank you, sir.
I will.
Thank
So,
you,
any
sir.
questions from the audience? They are welcome.
I just wanted to say that are very beautiful videos and what a nice work Ashish is doing. And I'll be very happy to witness one case whenever he is doing. I will come
Thank you, sir.
to the OT and see.
Thank you.
Marvelous.
Okay, if there's no more questions, then let's have the last speaker, Ashish Srivastav. So he's going to talk to us about, what was it? About encounters with highly vascular tumors, their planning and management. Ashish, please start.
Good afternoon, everybody. Just give me a moment to set up the... yeah. Right. Oh, there seems to be... how do I make it look? Can you see the screen?
Yeah.
The full screen or just the half of it? I can only see half of it. All right.
Sir, you are visible. You are visible and also audible nicely.
Well, I was always audible, Ashish. Thank you so much. Thanks to Sudhir, I have been made the encounter specialist today. And though this presentation has got nothing to do with the pure vascular surgery, but even during tumors, you can be baffled with a few vascular problems. So I'm going to touch on those. Now, what's wrong? Huh? Why is the slide not changing? Again, the same thing.
Sir, please share again.
Share again?
Yes, sir.
Okay. Something is wrong. Just one moment. I think it is some issue here. There's some issue here. Can you see the slides now?
No, sir.
No. Can you share again?
One moment.
We unshare and share again. They had come. We could see your name and the title, and then they disappeared.
Yeah, I was trying to change go to the next slide, and suddenly just.
आप unshare करके फिर से share करें, please.
कैसे करते हैं अनशेयर? I don't know how to do it.
यहाँ पर वो शेयर बटन है ना ऊपर देखो, नहीं तो अगर आपका शेयर स्क्रीन लिखा हुआ है नीचे, शेयर स्क्रीन ग्रीन में
लिखा हुआ है,
उसको फिर से शेयर करो.
अरे something is going. No, I just don't.
Sir, green arrow for share screen.
Sorry?
You can press on the green arrow, share screen, then
I did that. Then I get an option of share this and share that and nothing comes up.
No, you have to click on your screen, double click on your screen.
Okay, one moment.
You can see your screen maybe there, maybe your slide screen.
One moment. Everything went right now. Suddenly,
maybe someone can help from the audio visual.
Sir, I will share.
I have shared, but when I share, something goes wrong.
Sir, नीचे screen share है ना, green color का arrow है. You can click this.
वो नहीं रहा ना उससे. Can you see that now? Oh. No. Okay. Something is wrong then. I'll have to. Can we see it now? No. Okay, fine. I think I'll have to do something different. I don't know.
Your slides are open in the background.
Sorry?
Your slides are open in the background. Your PowerPoint.
Yes, they are. I'm sorry. There's a issue here. अरे अभी तो आ रहा था. Just bear with me, please.
Doctor, can I help you?
Please do.
Doctor, are you in the Zoom platform?
Sir, Sobhit is there to help you out, sir, from OCC.
Sure. Please let me tell me how to do it.
Doctor, are you in the Zoom platform?
Yes.
Okay. Doctor, can you click on share screen, that green color button?
Yes, I have done that.
Okay. Doctor, just click on your presentation. If it's already opened.
Okay, one moment. Okay, done.
Just, then doctor, just click on share button.
Again on the share button.
Yes. There's a blue color share button, doctor.
Yes. Allow system preferences.
No, doctor. So once you click on that green color share screen, again one window will be opening.
Yes.
Yeah. In that, just click on your presentation and click on share.
Allow Zoom to share your screen.
Yes.
System preferences, security and privacy to grant access. Oh, hang on. System preferences.
Akash, do we have the backup?
Yes, sir. I will share, but next, please.
Go to security and privacy. This is.
Akash, please help doctor.
Yes, sir. मैं share कर दूं बच्चे.
Need some permissions or some.
Right. Permission is granted.
आशीष सर, आप प्रेजेंटेशन डॉक्टर त्यागी को व्हाट्सएप कर दीजिए. I'll try to manage it from that end.
Yeah, it is already sent to Shobhit and to everybody.
Shobhit, can you check in on the back end, please?
Okay. I will share the presentation.
The permission for access will be allowed.
Well, there was permission. I don't know what. आ गया. Okay, आ गया.
Doctor, just tell us when we need to change the slides.
Yes. Next, please. Can everybody see the slides?
Yes, sir. Yes.
All right. Next, please. So again, there's only incompletely seen. I don't know what to do. Well, this is a MRI of a tumor, a falcine tumor. And this, I have divided the presentation in two parts. One is the expected vascular highly vascular encounters and the unexpected one. So this is the one unexpected one. And this is a routine MRI falcine tumor. Everybody does it. And I don't know how to change the slide. Next, please. Can you do it from there? So this is the meningioma. We all do it routinely. Go to the blood supply from the dura of the fox and then devascularize and proceed. Nothing great. So I did that. It's not changing. I don't know why.
Just say next.
Just say next, please. Yes. So go to the dural blood supply and devascularize and proceed. So that's what I tried. And then the problems started. Next, please. This is again the same thing. And next, please. You can see the arachnoid disruption causing edema. And the one previous, please. I think there is a lot of, Then the bleeding started. So nothing, no problems. If the bleeding could not reach the dural supply, you just decompress a little bit, try to make space, and then go to the dural blood supply. However, when I tried that, I was forced to do it because the sagittal sinus was embedded in the bone and adherent to it. So there was no way I could sort of detach it from the calvarium and then go to the dural supply. So no problems. I will decompress a little bit, go to the dural supply and attack it from there. And I tried that. And once I started decompressing, the bleeding was phenomenal. Next, please. And it took me a lot of effort and time to control the bleeding while decompressing. And every time I was doing that, something was going wrong. And I was thinking that this doesn't look like a normal meningioma. But finally, I could stop the bleeding from the decompression, go to the dural supply, cut off the dural supply. However, even after a substantial decompression, the posteromedial part of the tumor continued to bleed every time I touched it. So I had to content myself with a subtotal resection. And because there was, I was expecting edema post-operatively, I did not replace the blood. And the blood loss was almost 3 liters after almost 10 to 11 hours. So I had to content myself with just leaving it safely and getting out. Next, please. Next, please. Right. And this was the next day scan, which showed that there's residual tumor, obviously, and there's a bit of a hematoma. And you can see the tumor posteromedially and at the edge of the dura. The bone flap is not there. However, because the patient started becoming a little confused, I got this scan and then took her to theater, took out the hematoma from the frontal area. Because of the blood loss, the platelets had fallen to 58,000, and that was probably the reason why, despite good hemostasis, there was a hematoma formation. Next, please. However, after that, she recovered very well, and I had a bit of problems with that patient because she was sent afebrile, developed a fever which persisted, and the worst of apprehensions was resolved on an MRI and PET scan, etc. There was no focus of infection, no foreign body left at the tumor site. And then she came up with a subgaleal collection, which had to be aspirated repeatedly with decreasing frequency. So because of the nature of surgery and the excessive hemorrhage and this and that, I had to wait for about 6 weeks before I could touch it again. Next, please. And this was the situation. She was operated on 20th of May, and this was on 8th of June, just to see that there is no foreign body because of the persistent fever. Next, please. And I'm going to gloss over these slides because these are not really related to the vascular part of it, but to another part of the complications. So next, please. Next, please. Yeah, this is the same thing. Next, please. I wish I could do it from here. Next. Again, next, please. Right. And this was on 14th. This was done to sort of find out the reason for the subgaleal collection and what was the status. Next, please. Again, next please. And you can see that there is a lot of brain herniation, edema, and a residual tumor there and subgaleal collection. Next, please. So we had to attack this tumor again and got an angiogram done on the 10th of July, which revealed that the blood supply was not entirely from the dura, but from a branch of the anterior cerebral artery on the ipsilateral side. And that was what was causing the trouble while I was operating on that area. Next, please. You can see the angiogram. Clearly, it is from the branch of the anterior cerebral artery on that side, the A2 segment. Next, please. Same. Next, please. Next one, please. Right. So here I was with a patient who had a blood supply which was not routine, and that was the cause for the excessive hemorrhage during the first attempt and the subgaleal collection. And also we again went in with the idea of doing a VP shunt because the ipsilateral frontal horn was probably causing the subgaleal collection. There seemed to be a connection between the subgaleal collection and the ventricle. So the objectives of the surgery were a VP shunt to reduce the pressure and cause the subgaleal collection to settle down, tumor excision, whatever was remaining, a good tight uroplasty, and replace the bone flap. Next, please. And of course, these are slides showing the ventricle connection to the subgaleal collection. Next, please. There you can see that there is some kind of a connection with the frontal horn on the same side. Next, please. Again, next. Next, please. So this was the final scan after I achieved what I wanted to. The patient was given a right VP shunt. The blood supply from the anterior cerebral artery was embolized, and the residual tumor was successfully excised. Subgaleal collection resolved, and the bone flap was had resolved. Next, please. Bone flap replaced. And this is the final MRI scan done on the 20th of November 2021 to see that everything was fine. Next, please. Again, same. Next, please. Well, my hunch was reiterated by the pathologist. It was not a routine meningioma, but which is known as something known as a myopericytoma. So this patient presented with an unusual tumor. Myopericytomas are tumors arising from the perivascular myoid cells and glomus cells, and they behave very differently, more like hemangiopericytomas, not meningiomas. But the good part was that they are benign tumors, and if you excise them completely, recurrence is, well, almost not known. And thankfully, the patient is neurologically intact with no tumor. So this was one of the unexpected highly vascular tumor landing into problems because of the vascularity. Then there are tumors which you know are going to be vascular. Here's one CP angle meningioma or a clival meningioma, which was, everybody knows they will be very vascular, and it has a large base, so there's going to be a lot of blood supply. Next, please. You can see the cleft of CSF space. And then I went in with very defined, simple objectives: tumor decompression, if possible excision, preserve the cranial nerve, there are plenty of them around, abolish the pressure on the brainstem, that was one main consideration, and minimize perioperative hemorrhage, knowing fully well this is a highly vascular tumor. So next one, please. I got a DTA scan done to localize the nerves in relation to the tumor. That makes a difference how you approach them. Next one, please. You can appreciate the 7th-8th nerve complex at the anterior part of the tumor, so the posterior approach was fine. Next, please. And you can see these beautiful diagrams of the scans of the DTA, which also show that the tumor was in close approximation to the 7th-8th complex. Next, please. Again, the same thing seen differently. So one of the objectives is to save the cranial nerves, and the second one is to save the blood vessels. And then I got an angiogram done. There were 4 feeding vessels, 2 from the ipsilateral vertebral arteries meningeal branch. Next, please. Next, please. There you can see them. And next one. And then comes the surprise that the tumor is also fed by two feeders from the meningohypophyseal trunk of the ICA. So embolization was limited because the interventionist, Dr. Mateen, told me that if I try to embolize the feeders from the ICA, the meningohypophyseal trunk, there is a risk of retrograde reflux of the embolizing material causing problems with the ICA flow. Next, please. So this is again another picture of the angiogram. Next, please. And finally, the vertebral artery feeders were embolized, leaving aside the internal carotid artery feeders. Next, please. And these are the angiograms of that. Next, please. So we consciously, the feeders from the right ICA were left alone and not embolized. Next, please. Next one. Again, next one, please. Again, next one, please. Now, I went ahead with the following the embolization, decompressed as much as possible, but as I was fearing, in the anterolateral part of the tumor, the feeders from the meningohypophyseal trunk led to persistent hemorrhage on trying to excise the tumor, and I had to limit and contain myself and get out from there. Next, please. And this is finally the result. Next one. Right. So I had to content myself, eat humble pie, come out with a subtotal resection, but thankfully the patient was safe. And of course, the battle could be fought later on, either with radiosurgery or repeat surgery. There was a substantial reduction in size of the tumor. And except for ipsilateral vocal cord paresis, the patient is neurologically intact. So this was a patient who had a tumor which was expected to be vascular, could have been treated with embolization and technique, but thing is that there is a limitation even with planning, knowing a vascular tumor, even if you plan to embolize, etc., sometimes you are limited in that effort. So this is a situation where we encounter hypervascular tumors, which can have ramifications on the surgery of these. Thank you.
Thank you, Ashish. I think these are situations where all neurosurgeons encounter many times in their lives. And so I think it's an important message that that we have to identify those patients where it could be vascular, and if possible, take pre-operative measures, and intraoperatively we be prepared for such tumors. If there are any questions from the audience?
So I would like to appreciate the effort by Ashish, the way he handled both the cases. I think it was really commendable. Not easy to keep it cool when you are fighting a tumor. You want to excise completely, always the intention. But at the same time, you are supposed to keep your cool also, and you have to decide you have to limit yourself sometimes. Thank you.
Thank you, Sudhir. I would like to mention, sorry, Dr. Rana, may I mention something? Perhaps the moderator, Dr. Rana Patil, would himself remember when he was in AIMS and I was one of his residents. We started a meningioma at 8:30 or 8:40 in the morning. And by 6:37, I started reminding him, sir, please, it's too long. We had encountered a similar situation with the surface meningioma, not even a difficult one.
That was the CP angle meningioma. I was assisting.
No. This is before you joined. At about 9:30 or so, Dr. Patil was almost stuck to his chair. And finally, we had to take it out. We could take it out. But something which Dr. Rana and taught us, I imbibed from him that day was persistent patience, not losing his cool, and not giving up the technique at that point. That's what I would like to appreciate after so many years. I mean, what, 30 years, maybe 28 years, but the persistence with the technique and the patience, that's what was imbibed that particular day.
Chalo, kuch to seekh liya.
You have learned something from him. I have the similar experience with him for a triangle meningioma.
Yeah, that's what I'm saying. These are
First day we
situations
operated
where,
whole day, then closed it. Next day again operated whole day, but we could remove it.
yeah. So any other comments from the audience? If not, we will close the session. Okay, thank you very much.
Thank you, sir.
Thank you all the speakers, all done great. Thank you.
Thank you, sir.
Okay then.
Thank you.
We'll wind up from here. Please join us in Hall A.
There is a comment session there.
Yeah.
तो हम ऊपर चलते हैं ऊपर चल रहे हैं सर